With that, and on that note, we'll get things underway. Welcome to the additional public hearing for the inquiry into budget estimates 2021-2022 for the health portfolio. Before I commence, I'd like to acknowledge the Gadigal people who are the traditional custodians of this land, and I'd also like to pay my respects to elders past, present and emerging of the Eora Nation, and extend that respect to other Aboriginals who are present, joining us via the internet, either now or over the course of the day. Before I proceed any further, I'd like to just cover off on what covered last Thursday when we had the Minister for Regional Health before us, the Honourable Bronnie Taylor, just acknowledging and thanking all those brave and dedicated emergency service workers, police, ADF and countless numbers of community groups and volunteers who have all come together to work and help people right across the state to get through this recent natural disaster. And I'd too like to acknowledge and thank you, Minister for Health, and indeed, as we did last week, the Minister for Regional Health, Bronnie Taylor, and everyone at New South Wales Health, no matter what position they hold, who are doing all that they possibly can to provide the care and support for people at this time of great need. So obviously the immediate disaster of itself has perhaps passed in terms of the event, not in all places but in many, but we now have this enormous period in front of us of the support and care and assistance we need to provide to so many citizens of this state, and we need to work together as closely as we can to deliver that in the most timely way. I welcome Mr Hazzard and all your accompanying officials today. Today the committee will be examining the proposed expenditure for the portfolio of health.
Oh, thank you.
Before we commence, I'd like to make some brief comments about the procedures for today's hearing. Today's proceedings are being broadcast live from the Parliament's website, and a transcript will be placed on the committee's website once it becomes available. In accordance with the broadcasting guidelines, media representatives are reminded that they must take responsibility for what they publish about the committee's proceedings. All witnesses in budget estimates have a right to procedural fairness in accordance with the resolution of the House in 2018. There may be some questions that a witness could only answer if they had more time or with certain documents to hand. In these circumstances, witnesses are advised that they can take a question on notice and provide an answer within 21 days. If witnesses wish to hand up documents, they should do so through the committee staff. And finally, Minister, I remind you and the officers accompanying you that you're free, of course, to pass notes. Wait for the Minister to pay attention to what we're doing here.
I'm listening to every word you're saying as well as organising so I can give you the most efficient answers, Mr Chairman.
Well, you had your back to the chair, so anyway,
but I could hear everything you were saying.
We'll continue. Finally, Minister, I remind you that you and your officers accompanying you are free to pass notes and refer directly to your advisors seated behind you when your opportunity arises. Finally, could everyone please turn their mobile phones to silent for the duration of the hearing? All witnesses will be sworn prior to giving evidence. Minister, I remind you that you do not need to be sworn, as you've already been sworn an oath to. You've already sworn an oath of office as a member of Parliament. Now, I'd also like to remind the following witnesses that they do not need to be sworn, as you've been sworn at an earlier budget estimates hearing before this committee. So I'll just go down this list. We've got Ms Pearce, Dr Lyons, Mr Minns, Ms Dawson, Dr McAnulty and Ms Walk, who will be appearing this afternoon, which means the difference being we have a requirement to swear. Yeah, so Mr Jones and Dr Gale. So Mr Jones will defer to you first, as you probably are aware. And first of all, welcome. The Minister made a request for you to be able to give evidence first thing this morning because you'll be able to provide us with some valuable reports and I acceded to that, so you're most welcome to join us today. But getting through the formality, I'll get you just for the record to state your full name, position, title, your agency, and then swear either an oath or affirmation, whichever you prefer, the words of which should be provided to you. If you haven't got them, just please put your hand up and we'll provide them. So please proceed.
Thank you. No, I do have the oath in front of me. My name is Wayne Jones. I'm currently the Acting Deputy Secretary for Patient Experience and System Performance, and also currently the Acting State Health System Functional Area Commander for New South Wales Health. And I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Thank you very much, Mr. Jones. And Dr. Gale, thank you. If
Yes.
you could proceed with the formality, thank you.
Thank you. My name is Dr. Marianne Gale. I'm currently the Acting Chief Health Officer, New South Wales Health, and I will take an oath that I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Thank you very much. And can I take this opportunity to welcome Ms. Pearce officially in the role of Secretary.
Thank you.
I'm sure Ms. Coff is watching this with eagle eyes this morning. Not.
I hope she's not.
Not she's in Queensland and she's
But I'm sure you'll do a very good job in a most important role, and we've known you over a period of time appearing before us, and we understand your professionalism and competence, and we congratulate you on your elevation, and we look forward to your appearances not just today but into the future, so you're most welcome.
Thank you very much.
Well, we'll get things underway then with questioning. We'll be rolling in 15-minute blocks through each tranche, and we'll commence with the Honourable Ward Secretary.
Thank you, Mr. Chair. Thank you, everyone, for attendance. Ms. Pearce, congratulations. Thank you. It'll come as no surprise that the first questions that I'd like to ask will relate to the North Coast and flooding, and what has been the New South Wales health response, and particularly interested in reports coming out of the North Coast. Reports coming out of the North Coast of mums in the recovery centres complaining about diarrhea, ear, nose and throat infections. What has been the New South Wales government response to that? Minister?
Thanks, Mr. Secord. Look, obviously, coming off the back of 2 years of COVID, there's been a high level of development of health's capacity. Not that there wasn't already sufficient capacity, but it's certainly been fine-tuned to respond to major emergencies. And there's no question that the terrible situation that's occurred in particularly the northern part of the state, but also parts of Sydney and some parts of the southern area of New South Wales, primarily the northern part of the state and Western Sydney, has been very challenging. The reason why we have Mr. Wayne Jones on here this morning, who has worked both in the northern area as a chief executive formally, he's off that position at the moment, but also worked in the Ministry of Health during the COVID pandemic, is he has high levels of competency in both local knowledge and also the broader contextual aspects required to respond to a major emergency. The second part of it, and I'm going to ask him to address that question. The second part, in regard to the various challenges such as gastroenteritis, he may or may not, I'm not sure, be able to address that this morning, but we'll listen and hear what he has to say, because he has limited time as he's actually on the ground in the Lismore area at the moment doing the job up there. So, Mr. Jones.
Before Mr. Jones starts, could I actually, I notice as part of your title is disaster response. Can you give us a bit of a comparison in relation to other responses that New South Wales Health has had to do in the past? Thank you.
Thank you, Minister. I'm happy to do that. Well, New South Wales Health has what we call the New South Wales Health Plan, which is a document for guiding both the state and other agencies within health and how to respond to disasters of any type. And these occur in flooding. If we've used that in the northern New South Wales local health district over the years, for floods, for fires and events such as that. Each local health district has their own health plan that's led down from the state health plan to go on what to do. The lead response and contact within New South Wales Health in this regard is the State Health Service Functional Area Commander. which I'm now acting in for a period of 2 weeks. And what we do in these responses is the local, if you don't mind, I'll refer to them as HAZFACs. The HAZFAC in northern New South Wales takes the lead in coordinating response from the LHD level. Important to note that's not the only role. Health liaison officers are put into emergency operations centres at every level, state, regional and local, to ensure that health is well connected and there's good lines of communication. We have state health service controllers in a range of functions: medical services, ambulance, mental health, public health, health communications, health share, pathology, e-health and paediatric services through Sydney Children's Hospital to make sure that we're well connected. New South Wales Health also works very closely with other government agencies, and during these floods have worked very closely with SES Police Resilience, DCJ and other groups. And the department within New South Wales Health, called the State Preparedness and Response Branch, coordinates the functional components, the meetings and so forth. They're available 24/7, and all the CEs and HAZFACs across the state understand that I, as the HAZFAC, are also available 24/7. The major health response we've seen in New South Wales with the floods is we've set up incident management teams coordinated by System Preparedness and Response Branch. All executives and disaster managers of each LHD attend those twice daily meetings. Obviously in between, depending on the nature with Northern, we'll talk about Northern slightly separately, Mr. Secord. Areas mainly impacted outside of Northern, because I will focus my answer on Northern as you've requested. But in Sydney it's been the Pea and Blue Mountains, Illawarra, Shoalhaven, southern New South Wales to a less extent, Hunter, New England and southwest Sydney LHDs. The major issues we confronted outside of Northern was the Hawkesbury Hospital. There was a period of time there early in the week where we were seriously planning and considering evacuating Hawkesbury Hospital because of the flood levels in the Hawkesbury River. Thank goodness we didn't have to reach that, but contingency plans were available. Most Sydney LHDs and the others I mentioned, Illawarra and Southern, experienced staff unavailability because of inability to get to work predominantly in Sydney with the road closures and the flooding and so forth. That led to a reduction in some services, so elective services were temporarily suspended, and a number of community health centres were closed, primarily in the Pea and Blue Mountains. There were 3, and there were 5 in southwest Sydney local health district. Now that the water has stopped falling in its volume in Sydney and across the state, services are slowly returning back to normal in the Sydney area. If I concentrate now on northern New South Wales, there's been a coordinated multi-agency response. We've been liaising directly with aged care providers in northern New South Wales. That's important. We have a good relationship with them. And obviously when flooding occurs, we reach out to our partners to make sure they're all right. And we've been also communicating with the Commonwealth Department of Ageing and Aged Care to ensure that they're incorporated in the loop. The local primary health network, Health in North Coast, again, a very good relationship. I've been supporting the services with psychological and primary health care needs. The Northern New South Wales LHD is working with a range of non-government organisations and individual counselling groups, including Headspace, to ensure there's support for community and staff available. New South Wales Health is also very active in the State Recovery Committee and the subsequent Health and Wellbeing State Subcommittee. And New South Wales Health has been actively involved and had input into the Northern Rivers 100-point action plan. Just walking through the response, the immediate response in Northern with the flood events or any emergency is to ensure we maintain provision of acute services, primarily emergency department services and emergency surgical services. So they were maintained, they were the focus point, staff had to be redeployed because as you can imagine the magnitude of the flooding meant there were many staff who could not get to work, many staff who were being rescued. So the provision of health services in major evacuation centres, part of the process is once you set up an evacuation centre, health is an agency that steps in and provides that general health and also mental health support. As you know, Ballina Hospital was temporarily evacuated due to rising floodwaters. That meant a lot of logistical planning, well coordinated between the central agency and the LHD. We've had direct engagement, as I said, with their residential aged care facility providers, particularly in just simple logistic things, ensuring they have adequate food, adequate linen, and so forth, and that's very effectively.
Mr. Jones, could I just interrupt you there? And Minister, I probably would like to read. I actually want to get, I guess, practical responses to my question. I appreciate all the information that you provided, Mr. Jones, but Minister, maybe through to the Acting Chief Health Officer, Dr. Gale, I guess I want to know, what tangible, practical measures are being put in place for people on the North Coast? Because I know that mothers have spoken out in the recovery centres about their concerns about diarrhea and ear, nose, and throat infections. And also, I've heard a call for tetanus shots up there because of water and that. So I guess I'd like to know if it's possible.
At a practical level, I mean, I think what Mr. Jones is telling you is the practical aspects.
But I want to know what
specifically on some of those issues, I'll ask him for a brief comment, Wayne, on that. But before he does that, and then I'll pass to Dr. Gale.
Okay.
There's a lot of work going on at the moment in terms of getting the local health districts in, for example, Sydney, to send staff up to the area to support, because one of the issues is that a lot of the staff up there have lost their homes.
Yes.
And some of them, of course, are still suffering from COVID. So there's been a loss of staff up there. So we've got Sydney Local Health District and a number of others are sending, and Northern Sydney Local Health District, and I think Western.
I can add to that.
Minister, thank you. These are the kind of answers that I'd like.
Staff,
Yep.
but they're also sending up. They're converting or sending up buses or a bus that we've got and other vehicles that we've got so that we can have on-the-ground medical staff actually located in Lismore, because Lismore's basically lost everything. We've still got the hospital and other areas that are up a bit higher. But to get on-the-ground confidence for people to be able to see a practitioner if they, for example, if they've cut their finger in the process of doing some clean-up, if they maybe they think they might have gastro, so they'll have doctors and medical staff there, and those are already on the way, I think, and maybe already there. Would you like to add to that first before I go to Dr. Gale?
Yeah, happy to. Thanks, Mr. Secord. Yes, we've responded, as we have through other emergencies. I think this is part of the benefit of the connections we have across New South Wales Health in these times of crisis. We have sent a mobile van from Sydney Local Health District with staff. It will be able to assist with the provision of things like tetanus shots, first aid, vaccinations for COVID, for example, as well. We've also sent 4 extended care paramedics and vehicles to the area to also participate with the district's response to this. We'll be dispatching the big red bus from Northern Sydney Local Health District, which is a mobile
been used for
clinic.
dialysis in the past,
so that we will be able to take it to some of the smaller areas of the Northern New South Wales Local Health District and park it there, and people will be able to attend that as well. So we've canvassed all of our local health districts. In addition to that, we've been sending staff since the beginning to assist with relief for the staff on the North Coast. So mental health practitioners have gone from the mid-North Coast. We've got staff on standby in Northern Sydney and the Hunter New England as well. The Northern New South Wales Local Health District has also got camper vans that it will use for mobile vaccination clinics. So there are a range of things on their way to the North Coast. In addition to that, New South Wales Ambulance put helicopters and moved those up the coast in anticipation of that need. Was also able to participate in that response with the ADF by placing our paramedics on ADF choppers. So there has been a multi-agency response, but I would like to acknowledge the work of the whole of the New South Wales health system to support both the North Coast and other parts of the state with moving staff around and vehicles to assist.
Can I just say on the gastro aspect,
yeah,
the gastroenteritis?
Generally, that is actually what I was going to ask. Are there reports of gastroenteritis outbreaks, and what are we doing to respond to that?
I'll ask Dr. Gale to address that, but I'll just say this, that in the last 2 weeks, there's been quite a number of reports of gastroenteritis up and down the coast and in various parts of New South Wales, so it's no surprise that it's also happening in the flood areas. But Dr. Gale.
3 minutes.
Yes, thank you, Minister, and thank you, Mr. Secord, for the question. Clearly, there are a number of health risks associated with the flood situation, and gastroenteritis, or the spread of infectious diseases, is one of them. As the Minister correctly said, in recent months we have seen quite a lot of gastro in the community generally. So understandably, in a flood situation or when people are gathered together, there is always that risk. So in terms of gastro specifically, in each of the evacuation centres, a number of measures are in place to make sure that any risk of spreading gastro is minimised. So, for example, there's a strong emphasis on good hand hygiene, so making sure that there's water and soap, because these basic measures are essentially, the cornerstone of preventing gastroenteritis. There's also plenty of hand sanitizer that's available in evacuation centres. As much as possible, people are being distanced in evacuation centres, so they're not crammed together, but obviously in some circumstances that's just very practically difficult. And so I know that the staff on the ground are doing their absolute best to make sure that that environment minimises any risk of transmission of infectious disease, whether that be gastro or whether that be respiratory illness or any others. We know that in a number of places with the floodwaters, it does affect the quality of drinking water and issues with the sewage system. So, we know that, and I think we take for granted that we, rely on safe drinking water, but there's a lot of work that goes into making sure that our drinking water is safe. And I know that there's been a lot of work happening in the North Coast to make sure that safe drinking water is available. But that does include, in some circumstances, when that is in doubt because of the floods, that we issue what's called a boiled water alert. And that's to advise everyone in the community that for a period of time we need to boil water. And to support some of those initiatives, there is a communications toolkit, and I'd be happy to circulate the link, and that's got a lot of information for the community about how to take those measures to protect themselves. So information about boil water, how to manage their own water supply if they've got that, issues around safe sewage treatment. So,
Dr. Gale, I'm sorry, our time's about to run out. So can I just ask you talked about the outbreak of other illnesses in the evacuation centres, and obviously COVID is still very active in the community. Are you aware of any COVID outbreaks within the evacuation centres at this point?
So I am aware of COVID cases that have been identified in some evacuation centres in northern New South Wales. Not outbreaks, no, that's right. Because as we know, COVID is circulating widely in the community, so it is expected that we will have people with COVID, and we will have close contacts who, when they seek safe accommodation, and that is the priority.
Can I ask Wayne Jones quickly to answer that, because there's a separate facility, I think, that was set up for COVID patients, Wayne, wasn't there?
And as he's
Wayne?
answering that, can I just ask what the rules are for close contacts in evacuation centres?
Could I just make a comment there, Ms Houssos? We have a document that clearly guides the anybody with suspected COVID or with COVID in evacuation centres. That was reissued to our entire health system the night that we evacuated Ballina Hospital. Dr. Gale and her team have been involved in that. It sets out all of the things you would expect: social distancing, hand hygiene, mask wearing, the use of wraps, etc. And in addition to that, as the Minister said, Mr Jones has made arrangements for a separate facility. Wayne, did you
And
want
I'll
to
ask him to say that, but also I want to point out that we've just been advised that there's no gastro been reported in the evacuation centres as late as yesterday afternoon. Some gastro obviously outside of evacuation centres because it's more broadly through the community. Mr Jones, can you just clarify, because I know you've got that separate premise for COVID patients, so could you just let the committee know that, please, quickly? Because there's a time essence here to move on to another group, I think.
Yeah, we identified 18 beds at Casino Hospital where we're isolating COVID positive patients. We do have a couple more than that who can manage isolation in their own facilities, but we're also looking at a large facility in making one of the evacuation centres, the numbers are dropping, making one of the evacuation centres a COVID isolation area to make sure there's enough capacity if we get any more cases going up through the evacuation centres.
Thank you. Ms Pearce, we'd be grateful if you could provide a copy to the on notice of that document you referred to.
Certainly.
Deputy Chair, Alderman Hurst.
Wonderful. Thanks, Chair. Good morning, Minister. I want to move on to talk about Full Stop Australia, which runs a 24-hour helpline for sexual violence victims on behalf of the government. They've been reporting that they're unable to answer around a third of calls that are coming through to the hotline due to lack of funding. What's being done to address this?
Full Stop does an amazing job, and they've been doing it for quite a while. And I know I've had conversations with them as recently, Emma, and I think there's a lot of meetings going on at the moment. But
I think you might have met with them this week or last week, within the last few days at least, yes.
Look, it was sometime in the last week or so, I think, yeah. And they certainly would like to see more funding for their service. I raised with them what capacity they had to perhaps coordinate or share services to some degree with 1800 Respect, which is the other major service. Obviously the service that you're talking about whilst it's run through New South Wales, it also provides services to other states as well. And one of the challenges, I think, is that when somebody has been in a horrible situation of being in a sexual assault, obviously, if they ring, it could be very quickly, straight afterwards, or it could be years afterwards. And to connect the individual who may make the call, which is often a very courageous call, it's helpful if they have services that they can connect with in the local area. Mm-hmm. So I think that there's work that they're keen to do in terms of additional funding that goes beyond just the call service. Part of the issue that I'm still coming to grips with is that there's the federal overlay with the 1800 Respect. There's also the fact that the majority of the funds are currently for domestic violence, sexual violence, through DCJ, Department of Communities and Justice. And I haven't had a chance yet to speak to the relevant minister about those issues because I've been flat out with the floods and COVID. But I think there's some work to be done that might be able to assist them. But certainly, from my point of view, I think they do an incredible job. And whatever we can do to assist, and I've told them that I'm happy to see what I can do to try and support them. But obviously, we have to look at what amount of money and what the effective use of taxpayers' dollars is, and make sure that there's at least less likelihood of duplication of services, although they assure me that there is no duplication of services. So it's
my understanding is that the reporting of sexual violence in New South Wales has actually increased by more than 80% in the last 10 years, according to BOSCAR, yet funding for the hotline has not increased during that time. But my understanding also is that Full Stop Australia says that they need roughly $900,000 per year to fully staff the service and respond to every call. Are you able to commit to providing some extra funding to that organisation going forward?
Look, I've given them the commitment that I will. I mean, I've only had the preliminary discussions with them, as you correctly identified, probably more accurately than me, that it was in the last week or so, and I haven't had a chance yet to actually work through all those issues, but I'm supportive of their service. I think it's incredible what they do. It's a needed service, but the question, as I said, is to strike the balance and make sure there's not both duplication and is there better ways of their service being delivered. It may be less money, it may be more money that's needed, and the source of that money is part of the issue, because the money that you're referring to at the moment comes through health. It's been a traditional aspect of the health budget. Mm-hmm. But it may be that it's more appropriate to come through the broader service through DCJ, which provides a much larger pool of funds, particularly off the back of the inquiry. So all I can say at this stage is I'm grateful for you raising the issue. Certainly, I've spent time with them and happy to pursue it. I want to pursue it, but I think I would be somewhat naive to give that commitment at this point, other than to say I'll do whatever I can. Can
you see that there's some sort of nervousness around people who work in this space around, they've spoken to the Minister for Domestic Violence and
Minister Ward?
Yeah, sorry, Minister Ward, and then she's sort of referred them back to you, and then you've sort of talked about, well, maybe it needs to go to DCJ, so they're kind of feeling like they're being thrown from one portfolio to another, and they're a bit concerned that it's more about passing the buck rather than actually sitting down. I mean, are you able to sort of get everybody in the room with that organisation to sort of work out, what is that funding that's needed and where that's going to come from, so they get some answers?
All I can say to you on that front, Emma, is I've been a minister for 11 years, and I generally manage to sort out issues, and I'll go about trying to do that as soon as I get a spare moment away from floods, COVID and various other issues. Health has been funding them, I think, for more than probably more than 5 decades. So there's certainly a role, a continuing role. The question is, well, you know what the question is. So,
Yeah. No, I appreciate that. And I think you were sort of touching on this earlier in your answer. I think you were talking about the overlap with the Federal Health Minister. So Full Stop's also requested that the New South Wales Government advocate to the Federal Health Minister to ensure that the 1800 Respect line includes a New South Wales provider to ensure that people get access to localised information. My understanding is that right now there's nobody contracted to that service from New South Wales, meaning if somebody was to actually call up that service right now, they'd be directed to a counsellor in Victoria or WA who might not actually have the knowledge of some of those local services.
Well, that's what Full Stop advised me. But a lot of these organisations, like 1800 Respect, obviously subcontracts. They get the prime contract, and then they subcontract to other local areas. And you've identified, whilst you're asserting on the basis of information that's been given to you that there are none, and that was what was given to me as well from Full Stop. I need to find out, obviously, substantively, whether that's the case. It does seem, on first principles, to be a little bit lacking, if that's the case.
If you find out that that is the case, are you willing to advocate to the Federal Minister that change, if you were to find that out?
Yeah, I just need to get more information, because my first briefing from Full Stop was literally sometime in the last, as you've told me, probably in the last week. Yeah.
Thank you.
We now move to Kate Fairman.
Where's Kate?
Kate's
She's online.
Chair.
Abigail's with us as well, so I'm not sure Abigail's got a question
I
as well.
saw Abigail walking, but I haven't seen Kate. Yep.
Thank you. I just wanted to go back to the comments, the evidence before about additional staff being sent to the Northern Rivers. I just wanted to get a sense, firstly, in terms of nursing staff, how many New South Wales Health nursing staff have been sent to the Northern Rivers to assist with this emergency?
Well, I've just sent a copy of the van, or one of the vans, to one of the members of the committee so he could see it. I'll send it to you too, Kate, if you like. But they're setting up the staff that would normally be able to man those vans, but also backing in some of the other staff that are off. But I'll ask, could you?
I also, because it's 11, I'll come back in a sec. It is 11 days since the floods hit, and what was kind of sent in the first week by New South Wales Health? Is this all kind of happening now, or were there kind of reinforcements sent in sooner?
I can tell you that in the first week, it was first few days, it was literally hell and high water, trying to deal with water that was actually affecting our own staff as well. And I think the most appropriate person there to give you the details is actually Wayne Jones. So I'll go back to Mr. Jones, since you're here. Could you address Ms. Fairman's question, please, to the best of your ability?
Thank you, Minister. The Minister's correct. The first period in this is a response is to ensure acute services are maintained with local staff, so you have a local understanding of what's occurring, and also need to mitigate the risk factors of bringing people into what was an active flood zone. So you only brought people in who were emergency services personnel in that first period. So subsequent to that, we put in additional mental health staff. I believe there's 4, I can clarify that, but 4 mental health workers from Mid-North Coast who have come up and supported, and we're in the process now of rotating additional out of Hunter, New England and Northern Sydney to ensure that there's additional staff there for at least an 8-week period. We brought in people from other agencies, services response and nurses from private in Queensland. They've been brought down on the ground. As Ms. Pierce said, we have the 4 extended care paramedics, and we have at this point in time 15 to 20 nurses, and I apologise, I do not know if they're on the ground at this time. Some are, and some are coming up over the next 2 to 3 days. And they're in addition to what the Minister is referring to with the Sydney LHD van. As you can imagine, with the flooding down in Sydney, that has created some difficulties in transport and mobilising these people to come up, so there will be a further delay in getting those people up.
Okay, so thank you for that. That's useful. So 15 to 20 additional nurses are making their way up to the Northern Rivers, so Ballina, Lismore, other areas, I assume, in the next few days. Would that be fair to say, Mr. Jones?
That's the plan. And so the rate limiting factor on that, the caveat for me on that is getting them transport. The other caveat is getting them accommodation. because many of the hotels we use are literally flooded and now beyond use. So we are in the process now of sourcing as much accommodation. Transport is also, we need to people get transport vehicles. As you can imagine, corporate vehicles, we had 65 lost vehicles in our fleet, and every spare hire vehicle has been taken by private people or other agencies. So we're working through those logistics at the moment.
Thank you. And just on the point of accommodation, I was going to ask as well. I know of quite a few actually, but families, including nurses who have lost everything. I've been informed of some who are actually staying in motels now in town to continue working in hospitals because they can't get home. Does New South Wales Health subsidise that, or is that something that the nurses are paying themselves? Do you know, Minister or Mr Jones?
Wayne?
Sorry, I don't know that answer, but I'm happy to take that on notice and get an answer back.
That would be good. Minister, do you think that New South Wales Health should step in if that's the case?
I think we should do everything that we can to assist our health staff, but I'll have that conversation with Mr Jones and the Secretary once I know a little more information. I can say this though, Kate, that in those first 5 days, it really was an immediate disaster response. I mean, issues like, for example, the SES advised us that I think there were 53 patients. From memory, look, it was 9 o'clock at night, I think, when I was told, but I think there are about 50-odd patients, and maybe correct me if I'm wrong, Wayne, there are about 50-odd patients in Ballina Hospital, and the SES advised that we could be looking at a king tide, I think, about 8:30am the following morning. So a decision had to be taken that night, and I remember in consultation with Mr Jones and I think the Secretary about whether or not we would, because it's a relative risk issue, trying to weigh up. You've got patients with particular needs and particular concerns medically, and also a flood coming towards them. So what's the risk of the flood coming in and causing more grief versus taking them out? In the end, we made the decision at about, I think, 9 o'clock at night, Wayne, but correct me if I'm wrong, to transfer them across to, I think it was St Xavier's School, about maybe 10 minutes drive away. Those were the sort of issues. And then I think we had, actually in the subsequent 3 days, each day SES was telling us high tide, in the evening, high tide in the morning, it could come in. And I remember a final conversation where we all discussed, again, those risks, those operational risks, about whether we would maintain the St Xavier's arrangement of having our patients there, but not only that, but having a temporary ED, because the temporary emergency department, I should say, the temporary emergency department serving the community of Ballina was obviously not as good as an emergency department back in the main hospital. So in the end, I remember we made a final decision that we would weigh up the risk, but decided the patients' interests were better served by taking them back, and then we would have to be on high alert for any further highs. So those are the sorts of issues that were going on in those first week. It was pretty horrible, actually, making decision after decision like that. The staffing, I think, answering a question
Do I
about...
still have time?
Answering a question about... Can I just answer the question about the nurses? Can I? I think I might be wrong, Kate, but when you get another go, or when Wayne gets another go, I think we had about 100 staff who lost their homes as well. So one of the issues there that we were looking at was whether we could get any support up there through vans and health infrastructure been working with housing, because it's primarily a housing issue. But I know Rebecca Walker and I had a number of conversations, she's here today, about whether or not we could access some of the vans that we'd used, for example, in Wilcannia when we had the breakout of COVID, and we transferred them up there. So last I heard, but we'll hear in due course, we did get some vans to be on the way up there to help housing, being able to support it. But I mean, the problem really is that the number of vans that are available is so small compared to the number of people who've lost their homes. It's horrific, really.
Ms Fairman, if I just could finish that off, and I know that time is up, but I would like to make it clear that there were immediate deployments of staff from New South Wales Health, particularly with respect to the mental health aspects from the mid-north coast. The movement of vans and other vehicles obviously has been contingent on roads being open and having the ability to get through, so that as soon as we could get them there, that's what we're doing. Many of those staff Mr Jones referred to are there or are certainly on their way. The other aspect of this, of course, is New South Wales Ambulance, who immediately stood up an IMT right back when this started at the very beginning, in incident management team, and was sending paramedics and extra resources to that area immediately. I think it's worth noting that there was no delay from our perspective in getting staff there. The rate limiting factors that Mr Jones has mentioned with respect to accommodation are a real issue, and we're working through that, but we will send whatever resources are necessary to assist our colleagues there, and will continue to do so.
Thank you.
That's the value of an inter-networked system across the state. We also, by the way, lost some ambulances initially that went under in the water as well, but we're able to recover, I think, the majority. So, yeah, it's been, as I said, hell.
Before we proceed further, can I just acknowledge the presence of the Shadow Minister for Health, Ryan Park, who's joined us for the proceedings. So
What a great privilege it is to have.
welcome. Well, he came in.
And he's gone.
He's disappeared.
Came in for a quick look and bolted.
I think it's almost guaranteed he'll be returning very shortly.
I think he was intimidated, Minister.
Minister,
So I'm sure he'll return. The Honourable Courtney Houssos.
I dispute that. Minister, I just wanted to confirm, so did you say, sorry, that maybe Mr Jones, that COVID cases are currently being isolated at Lismore Hospital, is that correct?
I'll go to Wayne Jones, because the last conversations I had with him, we had people in the community with COVID, and the issue was that we wanted to make sure that if they identified, I mean, as you'd appreciate, you've come in here this morning, you may have had COVID, you wouldn't know until you've had a RAT test.
Of course.
But if they identified, was there a possibility of them being transferred and looked after safely in a separate location, subject to obviously the constraints of being in a major flood crisis zone? Wayne, can you just clarify that? Because my recollection was you advised me you did have the first place, and I just don't remember whether there are other places as well, but if you can tell us that, please.
Yeah, no, the initial place is Casino District Hospital, not Lismore.
Casino.
There's 18 beds identified there, and we're looking now at enlarging a facility at Bar Sport and Aquatic Centre, which is currently an evacuation centre, but making it more a COVID isolation zone should we need more space.
Thanks very much, Mr Jones. And I just wanted to ask, just for clarification again on that final point about what's a close contact. So if someone has COVID in an evacuation centre, obviously usually a household contact is considered someone who needs to isolate.
The current guidelines, yeah.
That's right. So what are the rules for someone who has been in an evacuation centre alongside someone who had COVID?
It would depend on the proximity and the length of time, but since we have our Acting Chief Health Officer here, I shall ask her for her advice.
Thanks very much, Minister.
Yes, thank you. Look, essentially the local public health units will be making those assessments on a case-by-case basis in a circumstance where a person with COVID-19 was identified in an evacuation centre. It really does depend on their proximity, the size of the room, the duration of exposure, but essentially the same principles would apply to those risk assessments as would apply for people in a community setting. So if you've spent a prolonged period without masks right next to each other, then the likelihood would be greater that people surrounding may be considered close contacts. So that's really done on a case-by-case basis by the local public health units, doing that risk assessment in any circumstance where a person with COVID-19 might be identified.
Thanks very much.
Dr. Gale, we were just notified of 16,288 new cases today. So what is the current health advice on mitigation measures, and what's the current state of play for COVID in New South Wales? I know the flood is the preliminary response, but what's happening in relation to COVID?
Can I more broadly then address that COVID issue first? And I'll certainly Dr. Gale will also address it. You've raised a relevant and very pertinent point. Anybody who's been watching the numbers in the last few days would see that we're seeing an increase in apparent increase in cases. That is concerning us. Our focus has been primarily, though, on the crisis of the floods, but it is concerning us, concerning health, concerning me as a health minister greatly, that we're seeing an increase in the number of cases on a daily basis.
Minister, you just preempted my second question.
Sorry,
Dr.
Rob.
Gale, no, we're actually going down the same track here. So, Dr. Gale.
Sorry, can I just say this first, and then I'll get to Dr.
Okay, but I'll flag my question.
Yeah,
so,
you can.
So why?
I'll try and keep it short. Well, just let me
Okay,
say
why
this.
is it increasing?
I'm about to tell you.
Okay, thank you. Why is it increasing?
We have, what we're seeing is you remember how we had Omicron BA1?
Yep.
Well, what we're now seeing, we believe, is an increase through BA2. So we've actually got a further subvariant of Omicron. And what we're seeing is the numbers are increasing quite dramatically because it would appear that BA2 version of Omicron is actually more transmissible.
Yep.
Now, Omicron, we knew when it came after Delta, was certainly a lot more transmissible than Delta. That was BA1. We're now seeing what we believe to be BA2.
Yep.
We have some preliminary data done by the University of New South Wales, who were the source of the information that I gave back in, I think, December, when I indicated, much to the surprise of some in the community, that we'd be seeing 25,000 cases a day towards the middle to end of January. The same team have put together some work now. It's very preliminary, and we need to be doing a lot more digging before we give any definitive positions. But we are concerned at this point that BA2 is amongst us and overtaking BA1. And that tells us that we really need to get the community. One of my concerns, and probably Dr. Gale, will confirm her position, is that we're still sitting way off the booster doses that we need through the community. It would appear the community have largely switched off and decided that we're not facing a major problem with the virus. Well, we still are. We got 95% basically of people that went out and had doses 1 and 2, but only about 50%, give or take, have actually had the booster.
Yep.
And what we need to realise is what the preliminary evidence now is so concerning that people need to get out and get the booster fast, in my view. I'll pass to Dr. Gale. Dr. Gale.
Dr. Gale, on that, so the BA2, so it's a variant on the variant.
So, yes, so let me clarify. So the Omicron, so people will obviously recall Delta is what we were living with last year. And then late last year, we saw Omicron become the new variant of concern and rapidly take over as the dominant strain in New South Wales. And that is because any new variant essentially would need to be more transmissible or evade the immune response or the vaccine response in order to become the dominant strain. So Omicron remains the dominant strain in New South Wales. And Omicron has sublineages, is the sort of technical term. And so the dominant sublineage until recently has been BA1. What we are seeing increasing, and we are still undertaking further analysis to try and get a better sense and a better handle on it, but what we are seeing is a trend to an increasing rise of the BA2 sublineage of Omicron. And as the Minister rightly pointed out, experience overseas has shown us that BA2 quite rapidly can overtake BA1 to become the dominant type of Omicron. And again, from experience overseas, BA2 has evidence of being more transmissible. It can infect people quicker, but we don't have evidence that it is any more or less severe clinically.
Okay. On that note, Dr. Gale, so on January the 1st, the average stay in hospital for COVID was 4.5 days. Yesterday, the average stay was 9.3. What's happening? Is it, in fact, explain why it's gone from 4.5 days to 9.3 yesterday?
Yeah, look, I will take that on notice and come back to you in terms of that specific data. We do know that, as I said, from BA2, it does not appear to have evidence of being more severe clinically. So I'll come back to you about that particular point. But to your earlier point about the reasons of why we might be seeing increased case numbers.
Yes.
So our theory is that that increase in proportion of BA2 is probably playing a role. But additionally, we know that in recent weeks we have had more social mixing, particularly in younger people, with schools going back, universities, tertiary education going back, more social mixing, relaxation of restrictions. So all of those things play a role and probably are working in combination to see those case numbers rise.
So are numbers going to continue to rise?
As the Minister said, the preliminary and early projections from the modelling team at UNSW do show that we are likely again to see an increase in case numbers through March to April and in May. What we don't know, and there are significant uncertainties around those projections, we don't know exactly how high the peak may be, how long it may last, exactly when it will come, but it is likely that we will see an increase in case numbers in the coming weeks and months. As I know Dr. Chant has previously communicated, this is not unexpected. Even with Omicron, we know that, we're going to see periods of surges and periods where case numbers go down. If there is a new variant that is introduced, again, those are issues we're going to have to deal with. So our response to COVID is always going to need to be flexible and proportionate to the risk.
I want to take you to what you just dabbled on, new variants. So are there preparations underway for the next wave? Because I know you said there's the BA2, which is a variant on the variant. So there must be preparations underway for the next variant.
As part of our COVID planning, always the prospect of new variants is there, and history has shown us with the different variants that we've moved through that it's almost certain that new variants will come along. And the planning for that really are the same basic measures that we've talked about all the way along. It will be about the vaccine and how effective a vaccine is against whatever variant may emerge.
Yep.
It will come back to, again, the measures that we can all take as individuals to get tested promptly, to isolate if we're symptomatic, social distancing, masks in circumstances where you can't physically distance. All those suite of measures will remain the same even in the face of a new variant. And really the implication will be, what would any new variant mean in terms of numbers of cases, the severity of cases, and what the potential impact might be on the hospital system, but also on those in the community who remain at risk of severe disease. And I would just say finally that we know that people in our community who are at risk of severe disease, so those who are of older age, those who have other chronic illnesses or with immunosuppression, at high numbers or at low numbers of COVID, they are always going to be the group at risk. Yep. And so we always need to consider measures to protect those in our community who are at risk of severe illness from COVID.
Okay, Dr. Gale, as the Acting Chief Health Officer, are you concerned about the increase in numbers that are occurring now?
I am concerned. But what we are looking at is carefully looking at further analysis with our colleagues at UNSW and others to look at what the potential impact of those increase in numbers may mean. And we will be reviewing all of that evidence. As the Minister said, a very important and key message at the moment is for the community to be aware that this increase may come and important measures that people can take to protect themselves and those around them is particularly around the booster shot. And so if people are out there and haven't got around to getting their booster yet, or are sitting on the fence about whether it's appropriate, it's a really important time now for those people to get a booster. And similarly, if I could just add, for families with children aged 5 to 11 who haven't yet got their vaccine, now is really an important time for people to go out and be up to date with their vaccinations for COVID.
And who has access to this UNSW modelling data? And
It's the modelling is very preliminary, which is why we're indicating that, and there's a lot of extra work they still want to do before it becomes a public confirmation of what the situation is in the sense of this is definite, but it's highly likely. What we're concerned about, Mr. Secord, is that, as Dr. Gale just said, the preliminary information indicates that we could be looking in through only another month or 6 weeks, we could be looking at cases more than double than what we're currently getting. So it's concerning. But the big message is people need to understand while the community might have gone to sleep on the virus hasn't gone to sleep on the community. The virus is still out there and it can still wreak havoc if we don't go and get our boosters fast.
Ms. Husson?
Minister, I appreciate what you're saying about the modelling being still in its initial phases. Do you have any indication of when the peak might be?
Yes, on the early. Well, I'll ask Dr. Gale to clarify, but on my recollection of the very preliminary data,
Yes.
which still has to be confirmed through all. Part of the problem with forecasts, as we've talked about many times in the last 2.5 years, is the input and making sure the inputs are correct. And at the moment, we still have a relatively small population, even though, as Mr. Secord highlighted, there's an increase today. There's a proportion of those that are still BA1. BA2 is, we know, increasing, and we think that's what's causing the faster uplift. But when the inputs are essentially only a few weeks of BA2, and looking at some of the data from overseas, then you've got to say, well, you've got to do a bit more work here, folks, to be absolutely certain. But I think the community should also be aware of the fact that we've had these situations before, and they haven't been far from the mark. So if everybody were boosted, I wouldn't be as concerned. But the fact that so many people are actually sitting, I'll be careful what I say, so many people have become very relaxed and don't seem to think Omicron still exists. I don't think the virus still exists. It does, and it's out there, and it's doing this damnedest to get through the community. All we need to do, though, is to take the sort of steps that Dr. Gale's talked about, the washing your hands, keeping some distance, wearing the mask where appropriate, but most importantly, go and get your booster. Get it fast.
Deputy Chair.
Thank you. Just continue on around the same discussion around COVID. And Dr. Gale, it might be too early to sort of give any information on this, but do we know if there's any differences in vaccine efficiency on BA2 compared to BA1?
Thank you for that question. And yes, we don't have good evidence about that currently. And it is one of those caveats or one of the assumptions that we make, as we just talked about earlier, in making those projections about the modelling. Mm-hmm. Because some of the factors that are involved is, how quickly will BA2 become the dominant strain? What would immunity look like? Is there any cross-immunity for people who've had BA1 and BA2? How quickly does immunity wane? Both natural immunity but also vaccine-induced immunity. So there are a number of questions, and still internationally that evidence is being gathered, and collectively people are forming better evidence around exactly those issues. But for the moment, not very
We're just
clear.
not sure yet. Yeah, thank you. Minister, in regards to the booster shots, I think there's some mixed information out there around people who have contracted COVID before the booster, and then how long to then wait after they've had COVID to get the booster. I've heard some people are told to get the booster as soon as they're out of isolation. I know I was told to wait 1 month to 3 months, for example, and I've heard other people have been told to wait up to 6 months. Do you think that that's affecting the pickup rate of the boosters, and do we have any specific recommendations from the department as to how long to wait?
Yeah, look, Dr. Chant has said, I can't tell you how many times in public or press conferences with me, that it's 4 to 6 weeks is the current recommendation after you've had COVID. But I agree that more broadly there's a degree of uncertainty about whether you've got to have one at all after you've had COVID. The answer is yes. And Dr. Gale's just highlighted the fact that immunity wanes both after having had the virus but also having had the vaccinations. And nothing's perfect. Nothing's perfect. This is a 1 in 100 year pandemic. We are actually blessed. We are blessed to have had researchers come up with vaccines so fast. We had a whole year of utter misery with no vaccines. We had a year of getting vaccines. And now we've had the beginning of the next year where I think a lot of the community have gone to sleep on the task. And they're sitting there thinking that it's disappeared. Well, no, it hasn't. There are people dying every day from COVID, every day. There are many people in our hospitals. Fortuitously, there are a lower number in our ICUs currently, but we can't be sure that's going to continue. And we are genuinely concerned and worried about what we're seeing in terms of numbers, but also the forecasts, albeit as preliminary as they are. you know, we've literally only got that information in the last few days. So it's still a long way to go, but people have power within their hands to just roll up their sleeve and get a shot. And if they go and do that, that's the best thing they can do, plus just take precautions.
It was reported on the 18th of January that 35.1% of New South Wales health clinical staff and 29.7% of non-clinical staff have had their third COVID vaccine recorded, compared to, say, 55% of the general population. Are you concerned that the uptake of the booster seems to be lower in New South Wales health staff than the general population?
Emma, I'm not sure that those are current figures, but I do know that the issue for us has been whether or not we would make it mandatory for the third dose. We made it mandatory for the first 2 doses, and that has applied not across the whole. I mean, I hear people thinking that this is actually across a broader section of the population than it actually is. There's generally not a mandatory requirement for the whole population, but for subsets of the population who have particular reason to have it, yes. So, for example, police, because they're dealing with the public all the time, medical staff, and so on, aged care staff. Other businesses have made it an OH&S requirement to have the injection, a bit like the Parliament currently is requiring rat tests here. That's their solution to the problem, or the Parliament solution to the problem. But am I concerned? Yeah, I'm concerned. But we are doing what we can to try and encourage health staff to actually have their third shot. Many of them, of course, are in the position that you talked about. That is, they've also had COVID. So there are periods where they have to wait until after they've had that to actually have the shots because they've been exposed more than anybody else.
Yeah.
The issue is then, do we make it mandatory or not? And I've said publicly a number of times that working with both the 2 major unions, that is the Health Services Union, which I think is the 5th biggest union representing health workers in the country, and also working with the Nurses and Midwives Association. They have both expressed concerns to us, to New South Wales Health, and to me personally, that health staff have been under such pressure for 2 years that to add additional pressure requiring them by mandatory orders under the Public Health Act would not be appropriate. Now, I haven't ruled it out, but I certainly haven't been rushing towards doing it. I mean, I must say, my individual views on these things are that I don't like doing health orders. Up until the time that we had a 1 in 100 year pandemic arrive, there'd only been 2 health orders, I think, in the last decade by a Minister for Health. And now, of course, on some days it's been 3 and 4 orders, and it goes against the grain. As an individual, as a member of the Liberal Party, it goes against the grain to be doing orders. If we can work with people to take them with us on the journey, then that's our priority, but I'm not ruling out getting to the point where we might have to have orders.
Thank you, Minister. Recent modelling from Deakin University indicates that up to 10,000 Australians could be suffering from long COVID by the end of the year. How are we equipping, or what are we doing to actually assist these people with that long-term recovery going forward?
Well, obviously, what is involved in long COVID is many and varied, and many of the symptoms are symptoms that are common to other major diseases as well, and many of those people do fit within, therefore, the services that we already have. But I'll ask Dr. Gale or... Oh, actually, where's Dr. Dr. Lyons is down the end there. We'll get Dr. Lyons to answer a question since he hasn't answered anything yet.
I leave him. He's sitting back.
Dr. Lyons.
He can be very quiet, hoping I wouldn't notice he was there.
Your time to
Thank you for
shine.
the question, and thank you, Minister. Long COVID has been discussed by our clinicians extensively because there's been quite concerns about the early reports from Europe and North America around the instances of long COVID. The evidence that the clinicians are hearing published is that the incidence of long COVID seems to be reduced with the Omicron strain, and so it's not as much of a feature as it was with Delta and the previous strains prior. However, they are very conscious of the need to ensure we've got plans in place for the ongoing care for people who've got those ongoing symptoms. And our rehabilitation physicians and our infectious diseases physicians and our respiratory specialists have all worked together to start to develop a pathway of care which will ensure that the right specialist teams are involved in that coordination and continuing to provide that ongoing care in partnership with general practitioners for people who do have those conditions that do need that ongoing support. So that development work is being finalised at the moment. That will then be promulgated as one of our protocols, as we've done with the guidelines that we've issued for all sorts of aspects of treating COVID. And that will be then used as a basis on which we'll provide that ongoing care. So, as the Minister said, those services already exist that can do that. They've got the expertise to do that and the resources to do that. We'll need to be continually monitoring to ensure that the numbers of people with long COVID are able to be supported appropriately with those services arrangements.
Thank you, Dr. Lyons. Rebecca Boyd.
Thank you, Chair. Good morning, Minister and officials. Good to see you. I just wanted to pick up on the questions that my colleague, the Honourable Emma Hurst, was asking around sexual violence. And I appreciate what you're saying about you've only had a chance to speak with Full Stop this week. But just generally, can I get confirmation from you, Minister, that sexual violence services is the responsibility of health and not DCJ?
Well, generally that would be the case. And Dr. Lyons, seeing as you've starred in one answer, would you like to answer something on this as well?
Yeah. So absolutely, we take our responsibilities in this space very, very consciously, and have had done a lot over the last few years in continuing to look at the issues around how we respond to sexual violence, and supporting organisations like Full Stop. So they receive $1.5 million from Health, and have done for nearly 50 years, as the Minister indicated. There's also around $250,000 that's been provided to provide support for their counselling services. But they're not the only things that we do in this space. We've got sexual assault services across all of our local health districts, and we'll continue to support with investments in those services as well over the last few years.
So it is the responsibility of health, definitely.
So there are aspects around the immediate care of people and the response in terms of support that we absolutely see our role as being.
Yes. And that's been the case for decades. What is your total yearly spend on New South Wales sexual violence services?
I'll have to take that on notice, I'm sorry.
Thank you. Given that we have, on conservative estimates, over 700,000 sexual assault victim survivors in New South Wales alone, and that's before we include adult survivors of child sexual assault, even though we have disasters such as COVID, floods and other things, we still have 700,000 plus people needing services for sexual assault, particularly, and as you know, the trauma that can follow people throughout their lives is something that needs to be addressed. Do you think it's acceptable, Minister, that the New South Wales Sexual Violence Helpline hasn't had any increase in funding in 10 years?
The helpline is just that, Ms Boyd. It does have some, obviously, component that I think the service would like more money. From the conversation I had the other day with them, they'd like some more money for services rather than just the line, the helpline. But that's why I was saying that to Emma before, that I need to sit down and have time to go through that with the bureaucracy.
This isn't new in terms of if Health has had responsibility for sexual violence services for this amount of time, we're being told that 1 in 3 people are being turned away from.
At particular points of the time, they're telling me that, they don't have enough staff on board to actually answer the phone.
So there is far more demand than there is capacity.
The same thing with 1-800-RESPECT. There's times when they don't have, from what Full Stop was telling me.
Sure, but 1-800-RESPECT is effectively a triage service that's run by Telstra, I think, now. And
Telstra Health, I think,
Telstra Health, who then divvies it out to the other services, such as the New South Wales Sexual Violence Helpline. If they're unable to answer the phone, people who are calling for help at that really vulnerable moment, when we know that moment of disclosure and that moment of seeking help is often the most critical time in somebody's recovery from trauma. If they're not getting answered, that is going to be a much bigger health problem going forward, isn't it, in terms of mental health costs and,
potentially
all the rest of it?
I mean, I don't think you could be absolutely definitive about that, but generally I would agree with you. Look, I've dealt with the similar situations through both being the former Attorney General and dealt with all the other states and territories on similar issues, particularly with the Royal Commission that was, I think, ran for almost 3 years and obviously had major implications or it shone a light on issues that were sort of known about but not known to the level of what it was. And I've dealt with men's and women's sexual assault groups through both that and family and community services when I was the minister there. There are other services that are operational and do get some funding from other services. And as I said to Emma before, I need to sit down and come to grips with what is actually going on and talk to the other ministers who are in those spaces as well.
And I understand that you're just one person, and I do understand that you will take this seriously, but with respect, this has been health's responsibility for a significant period of time.
Abigail, you can. I mean, yes, but I can't add any more. I'm giving you my earnest
The federal
answer.
government has made a commitment to increase funding for sexual violence services, and we've seen the National Partnership Agreement for domestic violence services as well as sexual violence services getting rolled out, with 20 million recently going to the Department of Communities and Justice to divvy out. That funding is intended to include sexual violence services because the federal government has recognised that there is an increased need for funding.
That might be the funding that has gone into DCJ.
That's right.
But I haven't got my head around that part yet because I only had this conversation last week.
Understand.
As I said to you, Abigail, I dealt a lot with this when I was Attorney General. I was out arguing and fighting to get additional funds from the federal government for precisely this purpose. But for me, if you're asking me to give you a definitive answer...
I'm not. What I'm trying to ask you about is because that funding, structurally, that is supposed to go also to sexual violence services, is purely going to DCJ, is there not a gap then in that the sexual violence services will never get funded out of that national agreement because it's always going to go to DCJ and never come into health?
Well, certainly when I was the Attorney General, I understood that the money that we would eventually extract from the federal government, I shared this with all other Labor and Liberal ministers around the country, when we got the money, it would be going into supporting sexual assault services. So I need to get my head around what is actually going on in another minister's portfolio and talk to that minister and the departmental officials to try and work that out. So I can't give you a definitive answer now other than to say I'm entirely sympathetic to the cause. You and I would be arguing on the same side of the table. Dr. Lyons, I can sense the vibe that he's coming from the end that he actually wants to say something now. So
Please
Dr.
do.
Lyons.
I can assist, Minister. So, I mentioned the sexual assault services that exist already, and every local health district has a sexual assault service which is available 24/7 for both crisis and immediate response to victims of sexual assault. There's also been $19 million which we're providing annually now for implementation of recommendations that came out of the Royal Commission federally, and that's been to specifically address many of the issues and enhance those services. So examples of those have been expansion of the New South Wales Health Sexual Assault Service Aboriginal workforce. So we've actually put 23 extra positions in place across the state, specifically Aboriginal people to work in the sexual assault services. We've piloted an adult survivors of child sexual abuse service, looking at a statewide implementation from 2023 at around $6 million per annum across the state. We're expanding the New Street services.
If I could just interrupt you because my time has run out. If I could ask you to please provide on notice.
I've only got a couple more points, so I can take 2 seconds if you like. So the New Street services...
Sorry, can I just finish my sentence? So after you finished doing that, if you could also take on notice the total spend on sexual violence services from the Department of Health in the last year, and then if you could also provide that for the last 5 years so we can see a trend, that would be great.
Certainly, happy to take that on notice. So I was just going to mention the New Street services, which have also been expanded for harmful sexual behaviours for 10 to 17-year-olds, and a range of other statewide programs that have been put in place.
Thank you.
Thank you. Honourable Second.
Yes, just drawing together the evidence from the last bracket of our question. So given the increasing COVID numbers that we see as evidence this morning and a variant on the variant, Ms. Pearce, is New South Wales Health ready for the next development in COVID?
Mr Scott, as the Minister's mentioned, because this advice is quite preliminary and we're still trying to work through the implications of it, we're also doing work now to model what we think may happen in terms of hospitalisations as a consequence of this. One of the inputs that, as the Minister mentioned, look, I've been dealing with modelling since the pandemic began, and I can tell you some of it's been accurate and some of it certainly has not. Yep. The reality of it is, when Omicron first hit us back in early December last year, we had no booster rate in the state. So the difference now, and this is what we're really working through, and of course we will make this information available as we have done in the past once we get through this. With the booster rate we've presently got, which is 60% of the eligible population, we need to understand what impact that may have on reducing the likelihood of hospitalisation, and that's the challenge that is before us at the moment. So the team is literally working through that as we speak to understand. I think in terms of preparedness, we certainly do acknowledge the work of our staff right across New South Wales Health throughout this and the fatigue of our health system that has now been, more than 2 years of dealing with this pandemic. So we've got, and Mr Minns may wish to add some comments here in respect of our workforce, but clearly we do need to acknowledge them. We also should acknowledge, though, that a lot of things have happened and changed since this pandemic began. The Virtual Care Centre at New South Wales Ambulance is one initiative that has made major change to how we deal with those increased calls. And during the Christmas New Year period, when Omicron really was appearing in large numbers, we were fortunate that we had invested in those types of programs to help offset what may have otherwise occurred. So it's not just all about hospital beds. I think it's really important that whilst it has impacted our hospital system, we can, there is no mistaking that. There has also been a significant amount of work to prepare our community resources, and we had to move swiftly. I think I've said publicly before, Omicron presented the perfect storm for us in that Christmas period while people were trying to have a break. The number of cases, all of those factors combined, and the staff furloughing was a very significant issue for us, which is why it's so important for our health staff to have that booster. But the resourcing and what we've done in the community space, I think it's important to remember that well over 95% of people with COVID do not set foot inside a hospital. And the point of that is that we needed to very quickly move to be able to provide information to people as to how to safely care at home, but more importantly, what to do if their condition deteriorated and they needed help. And that was very important. So Dr. Chant has spoken publicly many times about connecting people to care when they need it. We set up so that every time a positive case, both for RAT and PCR, comes into the patient flow portal in our system, it immediately then links. We do a risk assessment, which is all done electronically. Don't ask me to explain that in detail. But the risk factors of those patients based on age and other factors is taken into account. And then SMSs are sent providing that information. So there is I could talk a lot about the preparedness, but it is significant.
Thank you. Go ahead.
Thanks very much. Minister, I just wanted to ask you then, what's the latest advice that you have about people catching COVID a second or possibly even a third time? Given the increasing numbers in the community, what's the latest advice about whether people are likely to catch that? Perhaps, Dr. Gale, you might be able to answer that one.
They certainly can catch it again, but Dr. Gale.
Yes, thank you. We do know that reinfection occurs, and we have seen that that was a particular feature of Omicron when it first emerged, that people overseas who had previous strains, who had Delta, also got Omicron. So reinfection with COVID we know is absolutely possible, but clearly vaccination reduces that risk, and also previous infection does provide some level of immunity as well. So yes, we do know that reinfection is possible. One of the things that we need more evidence about, and we're watching closely, is what that looks like, especially for BA1 and BA2. and whether previous infection with BA1 confers much immunity to BA2. That's yet unclear. We are also aware of circumstances in certain cases in people overseas where actually co-infection of BA1 and BA2 has been identified. So there's a lot more that we still need to understand about how these strains intersect with each other, whether co-infection is possible, and what patterns of reinfection look like. So there's a lot of scientific work still happening to globally get a better understanding on those issues.
Dr. Gill, take you up on that. So it's possible to actually get BA1 and BA2 simultaneously.
I'm aware that there have been documented cases. So
Have there been cases in New South Wales of that?
not to my knowledge,
Not to you.
yes, and certainly not extensive, but I am aware that laboratories have detected that. As to the significance of that or how common that may be or what that means clinically, my understanding is that that evidence is still emerging, but clearly something that as the scientific community will be looking closely at.
Ms Pearce, I wanted to come back to you. My colleague asked earlier and talked about the difference to Dr Gale about the difference in the average length of stay, that we've seen quite a significantly longer, almost twice as long, in fact more than twice as long. On the 12th of January it was 4.5 days. As of yesterday it was 9.3 days was the average length of the stay. Now I understand that we're seeing lower numbers, but if we're likely to see a new increase, and we are seeing a lengthening of the period that people who are going to hospital, what preparations, how confident are you that, given what you've said about the health workforce being fatigued, how confident are you that you will be able to still provide the best possible care to the New South Wales community?
The team are looking at the length of stay right now because my understanding is the average length of stay is not at 9 days, but rather since the 1st of January is at 4.1 days. So happy to take that on notice and provide more information to
So let me
you.
just clarify, Ms Pearce, on the 12th of January, the average length of stay, this is according to publicly available data on the Health New South Wales website, the average length of stay was 4.5 days, this is at the 12th of January. Yesterday it was 9.3 days. Now I accept that there are lower numbers of people going into hospital, but my concern is that nurses are constantly telling us that they are overworked and understaffed, that this is something that's happening right across our health workforce. If we are seeing COVID cases in hospital for longer, if we are seeing but we are also seeing increasing numbers, then how is our health system going to cope?
But the health system is coping, and we've had far more numbers. But let me make it very clear that our staff have all been under massive pressure for 2 years, and they continue to be under less pressure but still pressure, because they've still got, like all of us who've been through this, we're still suffering from the post 2 years of absolute exhaustion. So but the health system is a big system. Our system is networked. It's a $30 billion system. I mean, anyway.
Can I just finish, I guess, Megan, I might pass to my colleague, Dr Lyons, but what we look at is the conversion rate of COVID into hospitalisation. That's one of the critical factors in terms of how we assess what we're likely to see going forward. So the number of people with COVID, how that converts to both hospitalisations and ICU admissions, those numbers have stayed quite stable. There's small movements in those. With length of stay, when you discharge patients who've been in hospital for a long time, that will skew the length of stay because the minute you discharge them, that adjusts the number. So, as I said, I'm happy to take on notice that question so we can provide you with accurate information with respect to what's happening. Certainly what we can advise, as you will have been seeing, is a gradual reduction both in ICU and hospitalisations for COVID patients. And we're also aware, of course, that there are a number of people in hospital and in ICU that have incidental COVID. So they are in hospital for other reasons. For example, in New South Wales, we count back 14 days. So if you had COVID 14 days ago, you then recovered from that, fell off your bicycle and broke your arm and were admitted to hospital, we would count that as a COVID admission. And we've done that to be very conservative because it also could be the case that you've had COVID and seemingly recovered and then had a fall, but that fall is actually related to COVID. So we've taken a very conservative view as to how we count COVID in this state. That is quite different to other states. So, for example, I understand in other jurisdictions, it's just the day you present, whether you've got COVID or not, is how it's counted. So there are variations on the theme. We watch these numbers, as you would appreciate, and the impact on our workforce every day. But I'll pass to Dr. Lyons for some further comments. Thanks.
So just very briefly, we've been watching the length of stay, and it has slowly increased each week. And the reflections from our clinical teams is that it's likely due to a number of factors. The first is, the overall load on the system has reduced, as colleagues have said. So the number of people in hospital has reduced, the number of people in intensive care has reduced. And as people have said, we are treating the vast bulk of people now with the Omicron strain and the new strains outside of hospital. So the only people who get admitted to hospital are those who are more severely ill and are likely to have other conditions which might impact on their length of stay. So the view is that we're seeing a skewed number of people now in hospital, which are the more complex people with multiple comorbidities who are likely to need other treatments. And the other issue is that, as Ms Pearce has said, is that people who are admitted with other conditions but have COVID as well because of the level of community transmission are counted in those numbers. And the thing that might be driving their length of stay is their other conditions. So we've been monitoring it very closely and making sure that, and there's going to be further assessment done, as Ms Pearce has said, to understand more about what is changing that length of stay.
Kate, we'll move to you. Your full allotment of time is 8 minutes, so we'll go till 10:05. 11, I should say.
Yeah, okay, great. Thanks, Chair. Minister, I just wanted to move to the New South Wales State Health Plan towards 2021. The Victorian Public Health... Sorry.
Sorry,
No, sorry, I'm hearing things. No?
I apologise.
Are you right, Chair?
Yeah, sorry, yes, you've got 4 minutes.
Sorry,
4 minutes.
just it's easy to hear things and think someone's actually trying to talk over me when I'm asking a question. Okay, so the Victorian Public Health and Wellbeing Plan for 2019-2023 lists climate change 43 times, with the first of 10 priorities of the plan being tackling climate change and its impact on health. The New South Wales State Health Plan towards 2021 lists climate change exactly 0 times. Surely you'll agree, Minister, that this is a gross oversight on behalf of your government to not prioritise the impact of climate change on public health?
So you're talking about the past plan that's already now passed, is that right?
I'm talking about the only plan that's in existence at the moment.
Yeah, but it's passed. It's 2021, and they're working on the new one.
Okay, so there's no plan in existence, Minister. I think that's what we're working on.
What I would say, Kate, is that I would share your concerns. I'm not going to argue with you. I would share your concerns. I wasn't the minister 10 years ago when it was done. Health, I think, in the new plans that are being developed at the moment and being consulted on, whether it's for regional or whether it's the broader state plan, I would envisage that there would be some consideration given to climate change because I'm of the view as Minister that would be crucial. So no argument from me. 100%. I mean, my first degree was environmental science. I've been arguing climate change for 30 years. I can remember arguments in my kitchen with members of the Liberal Party and the Labor Party, both telling me I was off my cracker because I was actually saying there was environmental climate change occurring. So no argument from me. It should be in there.
Okay, that's very good to hear, Minister. So what work is New South Wales Health doing at the moment to assess and manage the risks of climate change on public health?
Look, climate change obviously has ramifications, particularly in regard to people with a range of conditions. But I'll ask Dr. Lyons, who might, I'm not sure, but just to keep him on his toes, I'll ask him whether he has anything. Otherwise, I'll take it on notice. But Dr. Lyons, can you contribute anything to to the question by
Always
Mr.
happy to assist, Minister.
Oh, yeah.
Yes, Minister.
Yes, that's exactly right.
Thank you for the
I get that regularly.
thank you for the question. So we are in the final stages, as the Minister said, undertaking a revision of that State Health Plan towards 2021 and have the next version available to be published. It's just working through its final consultation processes at the moment. It's called Future Health. And just to reassure Ms Fairman that there is very much a focus on sustainability of healthcare and the impact of climate, not only from the point of view of the impact on the community and how we need to respond, but also in our own impact on environmental issues as a health system which has a large workforce and a lot of services that are provided. So our use of renewable energy, our impact on waste and waste disposal, how we can minimise those, our use of single-use items, which is a major factor in healthcare delivery, as you're aware. There are a whole range of factors that are being considered in the context of that future health strategy, which will very much put in focus our actions and what we need to do more of. But just to reassure, there is much work that's already underway. Many of our districts already have extensive plans around moves to renewable energy, reductions in waste, looking at the footprint and impact on the environment, but also thinking about what we need to do to respond for our communities in respect of climate change and its impacts.
Minister, given the impacts of, and thank you for that response, given the impacts of floods, bushfires and everything else that climate change is going to throw at us, are you pitching for an increase in the state's health budget to cope with the expected increase in demand?
I got to tell you, Kate, that I'm pitching for an increase in the state health budget all the time. But the problem is that whilst I argue black and blue for such increases for a whole range of reasons, every single day, I get requests from different groups wanting more money for this, for that. We heard about some issues a little earlier raised by your colleague. But I think there's no question that it may involve more money, or it may involve being smarter about the way things are done. I just want to say that, it is, at some point, the health system is going to swallow the entire state budget if we aren't cautious, because at the moment, I don't know whether you're aware of this, but I was amazed this morning when I was hearing about the increase in defence by the federal government to understand yet again that health in New South Wales employs 3 times the number of people that are the entire Defence Force for Australia. 3 times the number in health, just in New South Wales, let alone what it is in all the other states and territories. So health is like a massive black hole where we could drop every dollar in. But what I would say to you, rather than answering the specific question about the funds aspect, is to say I personally am committed to doing whatever it takes to get our environmental footprint minimised, but it will take time like everything else. And unfortunately, climate change appears to be already here. So you won't get any arguments. You won't get any arguments out of me, Kate, that there shouldn't be more done.
Time now needs to move across to Deputy Chair.
That's right. Thank you. Thank you, Chair. Recent research and scientific trials in Israel have shown the effectiveness of a 4th COVID vaccine. And I know that obviously New South Wales Health website recommends a 4th dose for people who are severely immunocompromised. But can we expect a 4th dose to become available at some point to the general public? Is that something that Health is looking into?
That question, Emma, is really one that I think has been discussed already at a national level, because that's something which would not just be a New South Wales issue. It would be principally discussed through the AHPPC. I'm not sure whether Dr. Gale's been on that, but I know Dr. Chant would thrive every day on at least a couple of hours of the AHPPC, plus numerous other national discussions. But I will ask Dr. Gale whether she now has a dose of AHPPC and whether she can give us an update on it.
Thank you. Yes, and as you rightly point out, a number of jurisdictions overseas, in Israel in particular, has introduced a 4th dose. So those decisions and those considerations are made nationally by ATAGI, so the Australian Technical Advisory Group on Immunisation. And I am aware that they would be looking at that data very closely, and I can't speak to the detail of their considerations. But I think it may be possible in the future and plausible, depending upon, their assessment of that evidence, that a fourth dose may be recommended. But I would suggest that it may likely be for segments of our population who are at greatest risk. And that will be something that ATAGI will consider and advise on. But it's plausible that as we go forward with COVID, that people's vaccination schedules may be different depending upon their level of risk. So it may be that if you are older, if you've had an organ transplant, if you have, severe or end-stage liver or kidney disease, that your vaccination recommendations may be different to the rest of the general public, and that may or may not include a fourth dose. So it's my understanding that ATAGI is looking internationally at that evidence and will, obviously look to see their recommendations and implement that in New South Wales if that is what the recommendation would be.
That's Dr. Gale's advice. Can I just say that everything she said, obviously, I agree with.
Mm-hmm.
But I think, having had discussions with those who are in this space as well, that we simply don't know enough yet to know whether it may not be just 4 doses. It may be annual doses.
Might be a yearly thing, in the same way we have a flu vaccine.
Exactly. So we just simply don't know. And AHPPC does discuss these issues. There's 1 or 2 members of that feed into ATAGI, that feeds into the national advice that goes to the federal government, that comes back through national cabinet. But they're all still, there's no playbook. It's a 1 in 100 year pandemic. We're still playing the game. Some of us not playing it that well by not going and getting our booster shot. But it may well be, there's 4th, maybe 5th. But one of the other issues that's being discussed at the moment is that there could be combined flu shots and COVID shots available. All that's still before us. It's still on a path that we haven't yet walked.
Okay, thank you. I've also got another question, just sort of moving back to the sexual assault issue. What services are available in New South Wales for child victims of sexual assault, particularly for victims under 16?
I'll ask Dr. Lyons to address that, but I just was handed a note from one of my staff just noting that apparently New South Wales will receive $80 million in total from the Commonwealth. This was what I think Abigail was asking before. Was it Abigail? Yeah, Abigail.
Yeah, it was Abigail.
Yeah. So New South Wales will receive $80 million in total from the Commonwealth under the Family, Domestic and Sexual Violence Responses National Partnership Agreement, 21 to 23. And the first of 4 $20 million Commonwealth payments under the NPA were received in November and has been allocated. And more than half of the first Commonwealth payment, 10.5, was used to bolster existing frontline domestic and family violence services, which experienced significantly increased demand due to the COVID pandemic. So there's a lot of work going on in that area, but I'll ask specifically in relation to children, I'll ask Dr. Lyons if he could assist us, and if he can't, then we'll take it on notice. Dr. Lyons.
We might have to take the detail of what... could you just read...
Sorry, the question was what services are available in New South Wales to child victims of sexual assault, particularly victims under 16 years of age?
So there are services available as part of the comprehensive services that we offer for sexual assault victims. And we have some specific services available as well, as I started to outline in relation to problematic harmful behaviours. So what I'd like to do is indicate that those services are available, but to give you the specifics, we might take that on notice and provide those specifics to you on notice.
Thank you.
Thank you. Well, just noting the time, we'll now break for morning tea. We've got about 7 minutes turnaround, so we'll be back on at 1:15, so don't wander too far. back, so thank you very much, and thanks for cooperation, just so we can keep essentially on time for our program. So back to the opposition on what's that called?
Thank you, Mr. Donnelly. Minister, you'd be familiar with the recent health inquiry into rural and regional hospitals and the evidence that related to hospitals, particularly in Western New South Wales and Southern New South Wales, where there were periods where there were no doctors in those hospitals. And we put on March the 3rd, the budget estimates put to the new Rural Health Minister, Bronnie Taylor, about hospitals not having doctors and that, and she said that was a tricky and disingenuous claim. So what is your response to 24 clinical staff at Yass Hospital who expressed concern that the hospital was without a doctor for several days during the Christmas period?
Well, first of all, I'd say I am very familiar with the rural and regional inquiry, and I acknowledge that from time to time, individuals have obviously raised concerns about care for themselves or their family. I deal with those issues all the time. But I would also say, Mr. Secord, that there are nearly 3 million people who go through the emergency department every year, and there are 2 million people who go through the wards every year. So there's 5 million people of our population, 5 million attendances. And I think in total that inquiry has, I think, 700 submissions.
Is that right, Greg?
Yeah. So that's 700 submissions over my time as Minister for Health. On the 5 million people passing through, that's 30 million, and there are 700 complaints. Well, I acknowledge that in many of those cases they are substantive, but they also have to be put in context. And the New South Wales health system, as I said a little earlier, is the biggest health system in the country by a long shot. 170,000 staff, a $30 billion budget this year alone, almost tracking to a third of the entire state budget. And of course, individually, there's been a lot of changes in the way health is delivered. There's a much more specialised approach. People expect not to have, they expect to have specialist services that are available for them in ways that sometimes just aren't practical. Now, the Yass Hospital, you're referring to, I think, Christmas period. Well, as I recollect, the Christmas period was right at the peak of Omicron, and it had burst forth, and we had, like in many smaller facilities, there's not as many staff to back in the staff that are there. So in that particular facility, I think that's a 12-bed facility, and I think over Christmas and New Year, from recollection and discussions a week or two ago, there were 5 or 6 patients in that hospital, not of high acuity, and like many smaller hospitals, in the middle of Omicron, it was hard to staff because we had many staff furloughed. It's a lot easier, but still complex, in the big ones that have thousands of staff, like, for example, Westmead. But in that small facility, there were some challenges, as you'd expect, because staff were furloughed off. I know that the big challenge for health, and I had those discussions many times during the last 2 years of COVID, was to keep the doors open and to make sure that staff were there to look after the minimal number of patients that were there in the Christmas period. I heard the Secretary say a little while ago that obviously, I think she referred to it as a convergence of factors. That is, when normal staff or many staff are trying to take leave, GPs are closed, and doctors are not available. And I think you're highlighting that that was one of the challenges we faced. No patient, though, suffered at all any negative consequences. They were all well cared for. I've seen some tweets put out by your colleague who made a token appearance, as it was highlighted by Mr. Donnelly this morning. The Labor... A fleet of foot appearance here this morning at the committee. I see he's tweeting and trying to cause disturbance by backing in union allegations, which I think is disappointing because...
Well, Minister, on that note, I'd actually like to seek leave to table the letter. It's from 24 clinical staff at the hospital. Now, it's from them, and I think that Minister, it's genuine, heartfelt, and they actually say that a dangerous situation, and that's a direct quote, a dangerous situation has been created, and they actually expressed concern that when they actually got a doctor at the hospital, that the doctor was unable to find the emergency equipment to use it or locate it. So I guess the question I go back to is that your rural health minister rejected and disparaged claims that there were doctors without hospitals, and she said...
I'm going to take a point
I think
of
you mean
order at that.
hospitals without doctors.
Hospitals without doctors, I'm sorry.
Chair.
So I just want him to respond. I just want... Sorry.
I just need to address, sorry.
Sorry, is there a point of order being
Yes,
taken?
Chair, I'm taking a point of order. The Honourable Court has put words into the Minister for Regional Health.
I have the transcript right here. I have the transcript here.
Order. Yep.
Chair. I think the Honourable Court, if he's intending to quote the Regional Health Minister and her estimates appearance, then he should do so with a complete recollection of the statements, not pinching certain sections. And I'd ask to everything to be put into context that the Honourable Court is raising.
Mr. Chair, I was referring to page 25 of the transcripts, and she uses the phrase tricky and disingenuous, and I seek leave to table the transcript and the letter from the 24 clinical staff at the hospital. Thank you.
To the point of order, I'm not sure that it's really necessary to table.
You asked me to do that.
I asked you to put into context what the Regional Health Minister did during her estimates appearance.
Well, can I just say this? What disturbs me even further is the proposition by the Minister earlier in answering this question that the 700 submissions, it's in fact 700 plus submissions, is representative of the total amount of complaint with respect to the New South Wales health system outside Sydney, Newcastle and Wollongong. The fact of the matter is, Minister, we did travel the state and we heard from numbers of people, numbers who've had multiple complaints, and to say nothing about those people who did not make a submission to the inquiry for one reason or another. So you're actually taking passage through wards and emergency and laying that up against the 700 to diminish the significance of the manifest complaint with respect to the New South Wales health system outside Sydney, Newcastle and Wollongong. Problematic such that the government has actually gone and in fact now put into place a minister specifically for regional health to try and deal with matters that obviously have not been capable of being able to be dealt with. So I do take some umbrage about this issue of context when in fact we have the minister starting off by trying to create a context which diminishes the significance of the issues that have been raised all around the state over an inquiry that's run over 12 months. So perhaps in matters of context, we'll leave it there. And I think this budget estimate hearing really does invite absolute honesty about numbers in terms of explaining what's going on.
Mr. Chair, I would ask that you, and I acknowledge and appreciate you at a personal level, but I would ask that you exercise neutrality as a chair of this committee rather than invoking other experiences from another committee. That's my first comment to that. And secondly, I don't have any problem with Mr. Secord tabling whatever he wants to table because I've answered the question as best as I can, and I think the Secretary would now like to add some further information.
Oh, no, before the Secretary does, I mean, I do not accept the proposition of being impartial. You answered a question and you set up the answer in such a way...
Well, you just accused me of being impartial.
Yeah,
so I'm just now pointing out that you're in a position of being a neutral chair.
I am a neutral
and you
chair,
are now
and
speaking from the chair from evidence of another committee that I don't think is appropriate. And I'm entitled to say
Minister, you may think it's not appropriate. I'm saying it is absolutely appropriate.
Well, I'm saying it's not.
This is a budget
Chair,
estimate...
I'm just going to raise a point.
No, I haven't finished. This is the most significant budget estimates hearing we've got. It's following on from the previous budget estimates. This is a supplementary hearing. The suggestion by yourself, and you said this, that you didn't even know the number of submissions. You said around 700 and you looked at me. It was more than 700, but the case may be that does not reflect...
I'm not going to argue with you, Mr. Chair.
Well, that does not reflect the totality of the issues in the state with respect to health, which you tried to lay out and put against those ED numbers and those ward numbers to create a position. So I think we've got to be clear about, if we're going to be absolutely precise about matters, to explain it as such and not try and sort of jaundice an answer in the way that you did.
I'm not going to argue with you. I've asked you
I'm
to
grateful- I'm
exercise
grateful.
your neutrality,
Yep.
and you are exercising as you wish. You are the neutral chairman. So I would ask that the secretary now be able to address the comments from Mr. Secord.
Well, I haven't ruled on the point of order, so I was actually responding to the point of order.
Well, you're initiating other comments, but still, that's by the way.
Well, Minister, we can have a back and forth if you like. I can return to the way in which you tried to jaundice the numbers, as I've described, by referring only to those submissions that are made to the inquiry.
Oh, dear.
So you can jaundice things this way, but it's not going to cut. It's not going to cut. We've had this inquiry.
Well, I'm the minister, and I've made my comments, and my comments stand, and I'm not going to argue with you. You're not in a position to argue with me at the present time.
I can, Minister. I can argue with you
Well,
as the chair of this committee.
you're taking up the time of members who are supposed to be entitled to ask questions.
If you want to square off with me, that's fine. The issue is
I've been squaring off with you for a long while, Greg.
You've tried to diminish the significance of the complaints from all around the state. You chose to put that on the table. I didn't.
Can we move on?
Chair,
So,
When you
we
finish.
sort of move on.
I was
The
just
clock's
going
been
to.
stopped.
I was just going to raise one last point of order, and that was that, in a sense, I do agree with your position, but only in that the minister probably doesn't realise that of the 700 submissions, not all of them were complaints. Some were
that
complimentary
too.
of the
I know that
of the
too.
health department. So I just wanted to make that point as well.
Thank you.
Yeah. Yeah.
Now, can I have the secretary actually comment?
Not yet. Just hold it. So, yes, so how much time was we on?
Oh, stop the clock. I think we should reinstate the time. Stop the clock.
Yeah, please proceed.
Secretary Pearce will now make some comments in regard to the initial question that was some
On
time
Yes
ago.
Hospital.
But I remember it. Off you go.
Thank you. Thank you, Mr. Secord. Look, we acknowledge the concerns that have been raised by the staff at YAS. I think that's the first thing to say, and we're aware certainly that the local health district, the Southern New South Wales Local Health District, is working with a team down there and also with the Nurses and Midwives Association. So I think that's an important point. With respect to what happened at Christmas time at YAS, I was personally involved in that as the State Health Emergency Operations Centre controller for COVID. The hospital was significantly impacted as a consequence of close contacts amongst the staff right before.
Staff-wise, it was impacted.
That's what I mean, right before Christmas. And in fact, there were a significant number of the registered nurses who were impacted and were close contacts, which meant they couldn't go to work. What we were then faced with in terms of that, and given the timing right on Christmas, it was very difficult. We worked with our colleagues and we did source an intensive care paramedic who is also a registered nurse to go to YAS to assist them. So everything, to work with the doctor and another nurse there at the hospital. So I'm not saying that the situation by any stretch was perfect, but what we did do under very difficult circumstances was attempt to keep the hospital, particularly the emergency department, noting that YAS is it's around an hour away from Goulburn and 45 minutes to Canberra or so, or maybe closer to an hour. We could not leave that emergency department unattended with no staff. That is why we felt that, that was a solution. And at the time the call went out, that was what we came up with. Noting, at the same time, we were similarly dealing with other staffing requests from across the state in similar circumstances. So very specific, that instance that you're referring to around COVID. I'm not suggesting for a moment that there aren't issues in other circumstances, but certainly on that occasion that was the main factor.
And can I add to that, Mr. Secord, that yes, of course, you picked on that one as an issue, and it certainly was an issue which Health tried to address at the peak of Omicron. But more broadly, across the regional health network across Australia, it's very difficult often to get doctors, and a lot of work's being done on that, both at a federal government, but also with all of the Labor and Liberal state governments around the country, to try and find ways to get doctors to work in those regional areas in greater numbers than they currently do. It's a huge challenge. And certainly there have been meetings, a number of meetings now, with the federal and state government ministers, Labor and Liberal around the country again, to try and work out better ways of encouraging young doctors particularly to go into the regional practices we've got a real problem because we've got a lot of older doctors who've worked 365 days a year, 365 days a year, 24 hours a day for years. And they're coming to retirement phase. They're all exhausted. So it is concerning as to how that will be addressed. Having said that, one of the initiatives that we've got in New South Wales now is to have GPs encouraged to go into the bush, into the regions, by having a joint funding arrangement with the state government and the federal government. It required some federal government amendments to their legislation, but we've got it, and there are 2 trials that are occurring at the moment. And we've also increased the number of regional positions in New South Wales. So it's a challenge for us, but it's a challenge in every state and territory right across Australia.
Ms. Pearce, you said that this had occurred at similar occurrences had happened around the state at the same time during the peak of the Omicron wave. How many staff were dispatched from Sydney? How many health staff were dispatched from Sydney to regional hospitals to fill voids at that time?
Can I just clarify? By that I meant that COVID, obviously, at the time, in terms of the impact on staff furloughing, wasn't just impacting regional hospitals, it also impacted metropolitan hospitals. I would need to take on notice the number of staff deployed at the time, but we certainly had other examples within major hospitals in Sydney where, particular discrete groups of specialist staff may be impacted at times. That resulted in us having to come up with solutions to address those issues, which is what we did right the way through Christmas and the New Year. And can I also add, I'd like to thank the individual who went to Yass and disrupted their own Christmas plans to assist. I think that gets lost in these conversations. We've had staff move right across the state to assist each other to help their colleagues throughout this entire pandemic, and that will continue.
Ms. Pearce, we certainly do appreciate the efforts of the health staff that have worked across the state, particularly over the Christmas period, to fulfil those vacancies.
Too, by the way, Courtney, just in that one period, we had, I think it was 6,100 staff who were furloughed, either as close contacts or as cases. So it was a massive number of staff that were taken out of action in that period. So it was quite a challenge for the entire state. And I know, talking to my Victorian Labor colleague, he had similar issues. But as the Secretary said, we've had amazing health staff who've backed in, gone from one hospital to another, one hospital to an MPS. We've had people just working enormous hours backing in when their colleagues were off sick or close contact. So,
and we've heard similar stories about healthcare workers going above and beyond, and we do appreciate that. Ms. Pearce, I'm interested to know how many, you said that there were specialist units that were required that were completely knocked out by COVID and by close contacts. I understand.
No, I didn't say they were completely knocked out. I said they were impacted.
Okay.
I would have to take on notice the number.
Yeah, that's what I was going to ask. If you could provide on notice with the number of specialist units across the state
Can I just say
that were required to be closed.
The
and
Secretary is being very nice, saying she might be able to do that, but I know I've asked that question in the past, and I was told it was a massive amount of work to go back and try and work that out. And right at the present, we're in the middle of a COVID pandemic and floods.
Minister, I appreciate that. Ms.
That,
Pearce has just taken it on notice. I'm interested to know how many regional hospitals were left without a doctor over the Christmas period as a result of the COVID cases.
Many local regional hospitals work on the basis of the local GPs being on call into the hospital. So it's not that simple to categorise that.
Yes, I understand that, but I'm interested to know.
We'll do as best as we can, but I'm just highlighting that that's the system that operates.
3 minutes.
No, actually, Minister, I want to take you to what we've just touched on. So Minister Taylor has claimed that she's been brought in as Mrs. Fix-It. Now, that's a direct quote.
I read that somebody else put that to her. It might have even been you, Walt.
No, it wasn't me. It was Kate Fearman.
Kate Fearman. So to be fair, I don't think the minister actually said that. But she certainly.
But the creation of a minister for rural health is that a reflection on the state of rural health in New South Wales, and is that a reflection of the last 10 years?
No, I think it's actually. We have a minister for, she was, and prior to her there was another minister for mental health as well. I think each of the states and territories have different systems that operate. We have the biggest system in the country with the most, as I said, I know the chairman wouldn't think much of my analogy, but 3 million people going through the emergency departments, 2 million going through wards and outpatients and so on. It's huge. It's huge. So I think that the avenue that's been adopted to try and give some additional assistance and a focus on regional health is very good.
We've only got 1.5 minutes to go, so I might just ask a slightly different question.
Sure.
Minister, when will hotel quarantine end?
Look, that's under review at the present time. We've actually minimised. You probably know we had, I think it was up over 6,500 staff a day operating between police, health and others, looking after all the hotels we had. We're down to only, I think it's 2 at the moment, but I might ask, but at the moment, answering your question, it's diminished to a very small number now, primarily focused on people coming in who are not vaccinated from overseas. But it may be that in the fullness of time, there'll be a decision taken by the National Cabinet that it's no longer a priority, because obviously there are numbers of people in the population who have COVID. When it was first established, we were aiming to try and stop any COVID through the population. That was the aim across the country. And some states just closed their borders, like WA, and never to be seen again until, March, only a couple of weeks ago. So just in time, by the way, for the Labor Premier to come and argue his case in a Supreme Court case was very convenient. But anyway, I think...
I understand he'll be quarantining after his return. But
Well, anyway, I think it's got to be on the agenda at some point, but it hasn't been determined as yet at a national level. But
can you just
you'd have to query
the current capacity is?
Sorry,
the current capacity.
I'll ask whether one of the team, Nigel, do you know that? Or can I take that?
No.
Oh, Susan says she knows.
Presently,
Sorry, Ms. Pearce.
We still have a cap, as you'd be aware, with respect to unvaccinated travellers coming into New South Wales. So that cap has dramatically reduced the number of people requiring hotel quarantine. My understanding is that there is one police hotel operating. We still have a special health accommodation as well for those unvaccinated travellers, and we've continued to provide that service. We have reduced the period from 14 to 7 days as well, in line with the other arrangements around
And that was
COVID.
a national cabinet decision.
Correct, yeah.
I think the one that's currently there is being managed through Sydney Local Health District, isn't it? Through RPA.
The police are still involved, but we still have the
No, the
special
health
health
one.
accommodation. Yes.
The health one is
yes.
being managed through
yes.
RPA.
Yeah.
We'll move on to the Deputy Chair.
Thank you, Chair. Minister, I just want to continue our discussion around sexual violence services. Just to clarify, I know we talked about the funding historically coming from the health portfolio, but do you, just to clarify, the sexual violence services, do you feel that the responsibility for this falls under Minister Ward's portfolio, or does it fall under your portfolio?
I think, look, primarily health, but I think what the issue there is, Emma, is that the fact that we had the Royal Commission and the fact that there were funds coming through from the federal government has put that into a more challenged position. And I can see why, for example, Full Stop would be thinking that they should be getting some of those funds. Like I said earlier, I just haven't had time with everything that's going on to actually pursue that one, because it was only brought to my attention whatever day it was in the last week or so.
And is that sort of the reason why sexual violence services funded through that National Partnership Agreement on Domestic, Family and Sexual Violence, why that first $20 million payment only went to domestic and family violence?
I wasn't involved in that decision, so I can't answer that question.
Okay, that's all right.
Sorry, I'll just ask, Dr. Lyons, do you have any knowledge of that?
No, Minister, I think it was a decision that was made by another agency, not health.
Yeah, I don't think it ever got to health, so no, Emma.
Okay.
I can't comment on it.
Minister, I wanted to get your response from Minister Ward saying that the funding for sexual violence services is health's responsibility, and that the federal money for DCJ and New South Wales Health will continue to sort of go there, and that that the funding will go to DCJ, and that New South Wales Health won't get any of that funding. Is that what you're trying to sort of unravel now? Is that what you're going to have meetings on going forward?
Well, I haven't seen those comments. You've said that. But what I'm saying is I think there are arguments that having heard full stop's arguments, that I'd like to have those discussions if I could just... I probably would have been having those discussions today, actually, if I wasn't at this all-day meeting, so, yeah. But I will as soon as I can, beyond COVID and beyond everything else that I'm doing.
Are there any other sexual violence services funded by New South Wales other than Full Stop Australia, or is it just Full Stop Australia?
Well, I think Dr. Lyons said before, he was referring to the fact that we have sexual health services throughout the state, but I'll just ask Dr. Lyons to give further information on that.
So we have extensive services about violence, abuse and neglect in all its forms right across our state, and there have been significant enhancements of those services over the years. A real focus has been on how we support people and how we screen for people who may be at risk, and those have been our focuses over the last few years. And we're very conscious of the fact of the need to continue to enhance those services, and they have been enhanced, as I indicated, in a range of different ways. But we're also doing things at the moment, looking at our violence, abuse and neglect services and programs, and looking at how they respond in the context of COVID-19 as well. So there's been increased services focusing on risk assessments and referral processes in relation to COVID-19, reviewing and locally adapting the clinical pathways, providing child and adult sexual assault medical forensic examinations for people who may or may not have had COVID. That's been providing crisis and ongoing therapeutic services via telehealth as well, and using that technology to support people getting access to the sorts of services that they need. So this is an ongoing focus, and we will continue to look at how we provide support. There's also been screening programs introduced for domestic and family violence in our
So I just wanted to know, I only want to know about sexual violence services. So I'm just sort of splitting those up, and I think that's where a lot of this confusion is coming from, is that, yes, there's a lot going into domestic and family violence, which is desperately needed, of course, but that there seems to be this neglect on these sexual violence services. You mentioned, Dr. Lyons, that there are other sexual violence specific services in New South Wales. Have you received requests from any of those services for increased funding as well?
Not to my knowledge.
Are you able to take that on notice to confirm?
Yes, happy to do that.
Thank you.
Do you have some, Emma, do you, that are actually saying they've asked?
No, I'm just throwing that question out there.
Actually raised it with me, although occasionally I've had requests from individual members, Labor and Liberal, for one-off funding to help various services, particularly, anyway, a number of different services where I've normally stepped in and tried to help with those services. But usually it's for an annual increase of some sort, or not an annual, as in continuing, because I don't have the immediate power to do that, but I can normally assist if a member draws that to my attention. But I don't recollect anybody raising that recently, but if you have anybody, let me know.
Thank you. And has the presentation at sexual violence services increased during the pandemic in the same way as we've seen an increase in the presentation in domestic and family violence services?
Do you know that?
I haven't got the details.
Take that on notice.
We'll take that on notice, thanks.
If you can take that on notice, yeah, thank you. And why wasn't sexual violence services included in the $484 million domestic and family violence package that was announced last October?
You'd have to address that to the relevant minister. That's not something that I've been involved in.
So, and I guess that sort of takes me back to this issue where, you know, sometimes when we talk about sexual violence services, it seems to be rolled in with domestic and family violence, and sometimes it seems to be separate and fall under different ministers. So just to clarify, so sexual violence services fall under you, Mr. Hazzard, and domestic and family violence falls under Minister Ward, is that correct?
Look, I think that's a reasonable starting point, but the issue is that they've obviously had funds come to them through the Federal Royal Commission, and the Royal Commission, as I understood it, I mean, it was effectively largely to do with sexual assaults, and so those federal funds came in a way that was directed to DCJ, and I think it was similar in other states, and decisions have obviously been taken within that ambit, but I can't add any more until I've had those discussions that I've talked about now on a number of occasions this morning.
Thank you, Minister. I want to move on to maternity issues. I've been speaking with maternity advocacy groups that have brought to my attention that while the World Health Organization says that the ideal rate of caesarean sections is between 10 to 15%, the rate in New South Wales is actually above 30%. While obviously caesareans are an important tool and sometimes obviously absolutely necessary during childbirth, I was quite shocked that obviously New South Wales is so much higher than the recommended ideal rates. Do you have any information about why the rate in New South Wales is so high compared to the recommended rates?
I'd start this by just saying that there's been a lot of research done, not only in the broad sense of the rate of caesareans, but also geographically. And I know I've seen research that's indicated sometimes it relates if there's perhaps only one doctor in the location who has a particular preference, and obviously, well, the argument might be, it's never clear, that advice is given on the caesareans to patients. But there's also broader issues, I think, and that is, it's been put to me anyway, that we are seeing a lot older demographic of women having their first child. And obviously the medical decision that's taken is frequently that it's in an increased ratio when you're having an older woman have her first child as to the appropriateness or otherwise of a caesarean for all the logical reasons. But I'll ask Dr. Lyons if he can expand on that or whether he'll take it on notice.
Yeah, I can expand in the general. So I think that, this argument about there is a specific rate which is recommended for caesarean sections, I think we need to look at context of that. If you look at around the Western world, there's been increases in every healthcare system in caesarean section rates, and a lot of that is being driven by changes in demography, as the Minister has outlined. We are seeing that women are generally having babies older, and we've also seen increases in the sorts of conditions that might create risk in pregnancy. So the incidence of diabetes in pregnancy and other factors are certainly driving decision-making around what's the appropriate care to be provided. There's also been concerns around people who've had a previous caesarean section, ensuring that they have minimal trauma with a future delivery, and looking at caesarean section rates that relate to previous. So if you had a previous caesarean section, more likely to have a subsequent one. So all of these factors are driving the change, and we're also seeing differences between what's happening in our public funded services and what's happening in the private maternity services. So there are a whole range of factors that are driving this change, and I think we need to look at it very carefully before we assume that a certain percentage is the right percentage.
I think, did you say that they were World Health Organization figures?
Correct.
Yeah, well, the WHO, obviously is worldwide, and in some jurisdictions, birthing is more likely to occur in a much younger age demographic than some of the Western countries. Whereas I said, and now Dr. Lyons has also said, we have women in their late 30s and into their 40s, and even older sometimes, having a child, and that presents. As recently as 3 nights ago, I was talking to an obstetrician about this. I've had obstetricians in my office arguing both ways, coming in and saying, we need a policy on this, or we need a policy that's totally the opposite. Obstetricians have a range of views on these matters for a whole range of reasons that Dr. Lyons has said it's not simple. And I don't know that we should be relying on a WHO figure as being the norm. We should be looking at what we can achieve here, but it's got to be done in a safe way for both the baby and the mum.
Mr. David Shoebridge.
Thanks, Chair. And
welcome, David.
Thank you, Minister, and thank you to yourself and all the senior staff for coming here today. Minister, I thought I'd ask you about matters probably that haven't been addressed to date, which is the role of Justice Health and your role in reviewing deaths in custody.
Reviewing
deaths in custody, particularly where those deaths appear to have happened for medical reasons. Minister, I'm certain you're as troubled as I was when there were those 2 deaths within 3 days down at Junee Correctional Facility, the privately run facility in southwest New South Wales in January.
I talked about it, so you know that.
Well, indeed, and I don't, and I know your concern is genuine, and I'm not suggesting otherwise. But I know we spoke soon after there was public information given about the second death. when did you get formally notified through the department that there'd been those 2 deaths within such rapid succession, just 3 days apart in January of this year?
I don't remember. But I know that the second one, I think I might have not have even got a formal notification. I think it might have come through informal sources. I can't remember.
Well, it's
What's the significance of that anyway?
well. I'm going to ask what if anything you then sought to have done in order to get some reporting or oversight from Justice Health down into Junee, given those 2 deaths happened in such rapid succession?
Well, obviously I asked for health more broadly to ensure that Justice Health was looking at those issues to make sure that there wasn't some major concern, some systemic issue that was going on there. But it was also part of the issue is that those deaths will go to the coroner to determine a number of factors. So it's not easily done.
No, we found out from, but I'll come to you, Ms. Pearce, in 1 sec. But we found out from budget estimates, from corrections budget estimates earlier this week, that the man who died alone in his cell after being diagnosed with COVID, who apparently had comorbidities that made him more vulnerable for COVID, was put on the transport list to be taken from Junee to Sydney, but was then removed from the transport list and left by himself in the cell overnight, during which he died. Were you aware of that?
No.
Ms. Pearce?
Look, Mr. Shibadri, I can make some high-level comments and in respect to what we did after that, not in regard to that particular example that you just gave about the transport. On the 3rd of February, there was a multidisciplinary review of from New South Wales Health on site at Junee to look at infection control practices. The review team found improvements were required to personal protective equipment and cleaning practices and the management of COVID-positive patients, the administration of boosters, and other governance arrangements. So those findings have been communicated to Correctional Services New South Wales for action and follow-up. And as the contract signatory, Correctional Services are responsible for that follow-up and rectification plan. We will certainly have an interest in ensuring that those things have been attended to, and we would need to take other aspects of this on notice.
Are you in a position to table that review with the committee?
I'd have to take that on notice, Mr. Shibridge.
No, I understand. I'm more than happy if it gets taken on notice. Was Justice Health or Health advised of the fact that the man who died alone in his cell without medical treatment had been taken off the transport list?
I'd have to take that on notice. I'm not aware of that.
There's no one here from Justice Health, and we weren't notified that we were going to be asked questions specifically on Justice Health, so have to take it on notice.
Because we hit a minister, we hit the stone wall with corrections on earlier this week, which is why they directed all the matters to this budget estimates hearing. So that's why we're where we are, Minister.
You know, on these sort of issues, if you have any information or any concerns, you can always ring me. I'll always respond to you. I always have.
Minister, I'm not in a
position to comment today.
Minister, this isn't a. I'm not coming. I accept you have a genuine concern. I accept you respond when matters are raised with you. This is just, given the heat of matters that we've had to deal with, the earliest possible opportunity I've had to raise it. And I'm not doing this as a gotcha moment in any way. But, Minister, could I ask you to, when you review that concerning evidence that we had from corrections about the man being taken off the list, to also review the fact that this same facility, Junee, has had 2 coronial reports in the last 2 years about other deaths, both of those are First Nations men, where there were a series of caustic findings against the health, caustic, very negative findings against Junee for the inadequate health care. Ms. Pearce, were you aware of those 2 relatively recent coronial findings, one as recently as November of last year, pointing out the inadequate health care provided at Junee?
Not in detail, Mr. Shibridge. No.
Well, just to assist, the first was The first, in terms of the coronial report, was into the death of Jonathan Hogan, a young Wiradjuri and Murrawarri man who died on the 3rd of February 2018. And that coronial report was delivered in, I think, May of 2020. Made a series of recommendations about trying to address the grossly inadequate mental health services at Junee. Do you know if those recommendations have been implemented?
I would need to take that on notice, Mr. Sheebridge.
And then the second coronial...
Sorry, David, did you ask the same question to the Corrective Services Minister?
I did, and they said they would take some on notice, and largely it's a question for Justice Health and Health.
It's a private facility, and that does create, I think, a difference there. But look, I'm happy
Minister,
to...
in large part, you're pushing against an open door there. This is really the primary responsibility, because of the way the contracts are drafted, lies with Corrections New South Wales to enforce the terms. But there is an oversight role for Justice Health. So it's in that oversight capacity.
Whatever the issues are, in terms of that, let me make it clear that I'm more than keen to try and sort out if they haven't done what they should have done.
Indeed.
Then we need to use the full forces of whatever we can do to get them to do it.
Which is exactly why I'm here, Minister. And the second death was the death of Keith Whitten. Keith Whitten died in actually November 2015 after an overdose of paracetamol. And again, a whole series of deeply critical findings about the lack of training, the lack of adequate attention, failing to escalate his deteriorating condition and have him taken to hospital. Those findings were delivered and recommendations on the 19th of November 2021. Can you indicate, if you can, as soon as you can, on notice, the extent to which those recommendations have been implemented that you're aware of?
Absolutely. I mean, if we can find out, and we'll do what we can to find out what they've done.
Yep.
And I'm happy to talk to you offline about it, because I share the same concerns if that's what's going on.
It is, and I'll finish with this. We now see these pattern of deaths from inadequate medical treatment, and we don't have the final coronial conclusions about the two most recent deaths. But there was a man with very serious comorbidities with COVID who wasn't given medical treatment, was taken off the transport list, and then died alone in his cell as recently as January of this year. I think we'd agree, and I'd just check we agree. We can't wait 5 years for a coronial report before we address what's going on in Junee, can we?
I agree.
Yep.
Honourable Courtney Hughes.
Thanks very much, Mr. Chair. Minister, I've got some documents that I'm just going to provide to you, which is an extract from the Hunter New England Clinical Services Plan, which your office provided to me, which I appreciate. I just wanted to take you through the specific reference to the new promised Foster Tuncurry Hospital.
Which, sorry?
The Foster Tuncurry Hospital that's been promised. So I just wanted to confirm, I think there's a couple of copies. There's one for you and there should be one for the Secretary as well there. This is just an excerpt from the document. The full, I didn't want to print the full 150 pages. I just wanted to confirm that that is the plan for the clinical service, the plan for the clinical services that will be available at the Foster Tuncurry Hospital. Is that correct?
I'm sorry, a clinical services plan is prepared by the clinicians in the context of the local health district. There are 15 local health districts. There's more than 170 projects going on. If you're telling me this is what's in there, then I accept that that's what's in there. But I don't see that level of detail, because it's being done through both, as I said, the local health district and eventually discussed with health infrastructure.
I understand that. So, Minister, this says that the Foster Tuncurry Hospital will actually be set up as a satellite urgent care centre. I just wanted to know how many nurses, and perhaps Ms Pearce, you might be best placed to explain, how many nurses are likely to be employed at an urgent care centre?
I think we'd have to take that on notice, noting that an urgent care centre is a different proposition to an emergency department. But Dr. Lyons, did you have any comments to make on that?
No, we'll have to take the notice, because it'll depend on the volume of patients that are likely to be seen through the centre, and the minimum staffing you'd have on would be 2 on each shift, so there would be at least 2 every shift of the day, 3 shifts a day, 7 days a week. But it may be that there are more staff than that because of the volume of patients likely to be seen, so we'll take it on notice.
Okay.
And sometimes what they're doing is they're looking at the particular demographic. I think Foster Tuncurry has an older population and more likely to come in, and it depends on whether there are other GPs in town, what's the likelihood of the numbers coming through. So it's a whole lot of factors that would need to be sorted out on that front.
Yeah, so the clinical services plan goes through the fact that there is a low number of GPs in the area, and so therefore it would be a nurse practitioner-led model. It also goes on to talk about the need to consider an aged care model, obviously given the demographics. Ms. Walk, can I turn to you, because I asked you about this in March last year about the hospital. You said that at the time that we would need to wait for the clinical services plan before we would start the planning for the hospital. Have you purchased the land for the hospital now that the clinical services plan has been completed?
No, we've not. But
Okay.
we have done a site investigation report and investigated approximately 10 sites.
10
as
sites?
possibilities.
Okay. And do you have a time frame for purchasing the land?
The clinical services plan will need to be approved by the Ministry of Health, and then we can do some planning concurrently with that.
Okay. And do you know when the clinical services plan will be signed off by Health? Do you have a time frame for that?
No, I have to take that on notice.
Okay. And so the land hasn't been purchased. You've got 10 sites. Are you able to, I'm not sure who I should refer this to. The budget gave a $7.9 million allocation between 4 electorates for an external consultant about, I assume, investigating the plans. Are you able to give a breakdown of how much of that money was spent on the Foster Tuncurry Hospital?
I'm sorry, I'm not clear on which consultant or which plans.
There was a budget allocation for $7.9 million that covered 4 specific local projects. Are you including Foster Tuncurry?
I think, I might be wrong, and if I'm wrong, please correct me, Rebecca. I think what you're talking about is there would have been a budget allocation to look at planning for the new facility, but that doesn't necessarily mean getting exterior consultants. That could be the funds that go into parts of health to actually do the work. So putting together a clinical services plan, doing some preparatory work. They've got people out looking at, as you just heard, 10 sites. I hadn't heard that, but 10 different sites. All those things take work and take up money because you've got to pay people to do it. So as in your own staff, but it's an allocation for them to do the work.
I understand. Well, perhaps if you're happy, Minister, you could take that one on notice and just give me a breakdown of how much of that $7.9 million went towards the Foster Tuncurry Hospital project.
I'm happy to take it on notice. I'd be surprised if they could actually do that, but maybe. Okay.
Okay, that would be great. And of the 10 sites, Ms. Walk, are you able to, are they in Foster, are they in Tuncurry, can you give us any more information on those?
They're in both of those areas, I understand it, and there is a preferred site now that's being within those reports.
There is one preferred site. Okay, and do you have any kind of time frame for when that might be purchased, or are you working towards? I understand you're waiting for the clinical services plan, but do you have a deadline? Can you say by the end of the year?
Sorry, didn't mean to interrupt.
No.
As I understand it, it's only been announced. There's only budget for planning at this stage, so that's the work that we're doing, the planning work.
Okay, that's excellent. Thank you very much for your time.
Okay.
I'll take on.
Thank you. Minister, I want to take you to Southwest Sydney Hospitals and the emergency department at Campbelltown.
I'm sorry, can you say that again?
Yeah, I want to take you to Southwest Sydney Hospitals and to the emergency department, the new emergency department at Campbelltown Hospital. Now, I understand that the capacity for the emergency department is a 67-bed facility. When will the emergency department operate at that capacity?
I can't answer that straight off. I'd have to take it on notice, but I know I was down there a couple of weeks ago. Have you been down to have a look at it?
Not in the last couple of weeks, but in the last few months, yeah.
It's incredible. It's by far and away that new acute services building. I think it's about 8 or 9 stories. And it's been built for future capacity because Campbelltown and that southwestern region is growing. Right. So a lot of the areas may, or not a lot, but some of the areas may or may not be opened immediately, which is also adopted under the former Labor government. So if you've got cranes on site and building on site, it's cheaper to build for today and tomorrow. So the question you've got in terms of a...
The question I have is specific. When will the emergency department operate at capacity? If you don't know, Minister, you can take it on notice.
I'm just saying that it may not be known at this point because it depends on future growth in that local area. But it's quite amazing, and I know everybody's very keen to get in there as soon as possible.
Now, you talk about, in this answer and in previous answers, you've talked about future capacity. When I've raised subjects of ghost wards or, emergency department parts not being used in that. So are you confident that
But you know that that's actually just poppycock. You know that. It's just politics and poppycock.
Okay.
Because you know that when you build a hospital, you build for the future, and of course there's going to be areas that you have for growth.
On that point.
But it's a political device that some people resort to when they're feeling a bit naughty and wanting to be a bit silly, and that's what you do occasionally. Mostly you're pretty sensible, but occasionally you're a bit silly.
Minister, on that point.
I think the Minister might be misleading the committee there. He's not often...
Come on,
actually, he's pretty good, mate. I've got to say, I think that Mr. Secord most of the time behaves himself extraordinarily well and does a good job for opposition, but sometimes he does get a bit silly. But then we all do when we're opposition. That's opposition.
Minister, on that point,
yes,
I want to talk about the 67 beds in the emergency department at Campbelltown Hospital.
67 beds. Sorry, say that again.
The 67 beds in the emergency department. So are you...
I've answered the question.
No. So I'm asking you, I'm moving on to the next part of the question. Are you confident that that will respond to the increased growth in the MacArthur region?
Well, that's what the advice is from New South Wales Health, obviously, if they've built to that. So one would assume that. Having said that, the area of southwest Sydney, which I know quite well, is growing tremendously fast. But that's certainly been the forecast that's been done.
Now, as part of that growth down there, one of the recommendations to the inquiry into Southwest Sydney hospitals, was the proposal for pediatric surgery and subspecialties at Campbelltown Hospital. So, what's happened to that recommendation?
There will be pediatric services there, but I think Dr. Friedlander and who's the other one down there that keeps pushing? Oh, that's right. Greg Warren, of course. Who I love dearly, but nevertheless, Greg and Dr. Friedlander have been arguing for highly specialised services for paediatrics rather than the broader paediatric services. And certainly the current model that's recommended nationally and is adopted nationally is that high-level paediatric services, because of the particular needs, are best located in specialised paediatric hospitals, and hence Westmead and Randwick. But there certainly are going to be services available, paediatric services available. It's a matter of delineating between what's safe and what's appropriate.
Now, Minister, you've actually raised that. And one last question before I throw to my colleague. So, based on what you've said, Westmead and Randwick, how many people, how many families, how many children actually make the trip per week from the region, MacArthur region, to Randwick and to Westmead? And if you're unable to provide that answer today, please take it on notice.
Well, that wouldn't necessarily be easily done.
Oh, yes, it would be.
No, it wouldn't. And I can tell you that those two children's hospitals, you're interested in just where your colleague, Greg Warren, has been making suggestions which may or may not be safe for the children, and Dr. Friedlander.
You're saying that Dr. Friedlander and Dr. Warren's proposal is unsafe?
I'm saying...
sorry, Mr. Warren and Dr. Friedlander, sorry.
What did you say first off? Dr. Warren, did you?
I said, yeah. So you're saying their community-based proposal is dangerous?
I'm saying that it may not be.
What the Minister said was exactly what you heard.
Yep. Thank you.
And the Hazzard will reflect that.
Thank you.
Great. Sorry, have we run out of time? Or can
We've got a whole day.
I think I answered it appropriately, but it has to be done like everything else in health. We're talking about relative risks before, even on moving patients in and out of Ballina. When New South Wales Health is making decisions, as each other health jurisdiction in the country makes, they make them on the basis of what's the best interest of patients. And sometimes you'd be surprised to know, Walt, that it doesn't always relate to what the local MP is arguing. And sometimes it requires a level of expertise that goes beyond that. and neutrality about their position. So Health's advice is that, yes, we should certainly have paediatric services, and we will have the paediatric services that Health have recommended in that local area. But if it's a high-level matter of high acuity that requires highly specialised services, those paediatric specialists, physicians, surgeons, neonatologists, etc., will be operational in Westmead and Children's at Randwick.
I just want to correct one thing before I throw it. Yeah, Mr. Warren is not a doctor, but Dr. Friedlander is one of the state's most respected paediatric specialists. So
He is, but he's also a local federal member. And sometimes when you enter politics, as I've noticed from over my years, that you do tend to get slightly distorted factual perspectives.
Ms. Hughes.
I'll let that stand. Minister, I just wanted to ask,
Thank you.
go
Is that
back to
agreement?
the question. No, it's definitely not agreement, but I'm not going to be on limited time. I wanted to come back to the question about population projections.
Having said that, can I say I have a high regard for Dr. Friedlander and for Greg Warren.
And
They're
as
both
do
good
I.
local
You can
MPs.
do your
Minister,
tidying
but
up
can I
later on,
just-
Minister.
What was that?
You can do your tidying up later on.
I'm just saying I do like them both personally.
And
tidying
so
up
do
later
I.
on,
But
Minister.
Minister, I want to ask you
The
about the
record will show
population
it.
projections.
Huh?
I want to ask you about the population projections for Campbelltown Hospital. Do you rely on the Department of Planning for those, or does the Ministry of Health do their own projections?
There's a uniformity that was taken, I think, actually under Labor, but many, many years ago, that there would be one source of truth, and planning is that source of truth. Having said that, obviously Health does its own double checks, but all agencies rely on planning's figures.
Okay, thanks very much, Minister. Ms Pearce, I just wanted to ask one final question on the Foster Tuncurry Hospital. The clinical services plan, the existing one for Hunter New England, expired in 2017. Do you have an estimated date of when that clinical services plan will be signed off by the Ministry?
I'd have to take that on notice unless you can comment on notice, thanks.
Okay, thanks very much. I think our time's about...
Can I just make one further comment
one
with respect to the Southwest, however, regarding population growth? The health funding model very significantly accounts for population growth, and I think we did raise these issues in the inquiry regarding the Southwest and Sydney Local Health District. I can advise the committee that over the past 10 years, that area has had a 73% increase in budget, the highest increase of any local health district in New South Wales.
Huge. Minister Hazzard, in our earlier exchange, I asked you to take on notice, and you didn't really take it on notice. I wanted to know the number of children, families that seek services at Randwick or Westmead Hospital, and you didn't take that on notice.
Over what period do you want it?
Well, I'd like to know last financial year.
Okay, could I say this? I'll take it on notice. I'm not going to guarantee that we'll give you the answers, because if it takes an enormous amount of work from Health, it's not warranted. But if we can get it out of Health, I'm happy to do it, because I'd be interested to know too.
Thank you, Minister.
Can I ask, Mr. Chair, who's speaking next? Sorry, who's asking?
Deputy
Emma,
Chair.
would you mind? I've just received an urgent piece of advice from Dr. Gale, and Dr. Gale has just indicated she'd like to draw it to the committee's attention, and it is very significant to do with Japanese encephalitis.
That was my next question.
Sorry. Well,
That's okay, it's good.
we can wait if you like.
No, go.
Do you mind, Emma?
No, I don't mind. That's fine.
Thank you. Please
I'll just
proceed.
ask Dr. Gale. She's just received information which is concerning about the extension, more case, or another case anyway.
Thank you,
Gale.
Doctor.
Yes, thank you, Minister. Yes, so I just wanted to let you know that we this morning have received confirmation of an additional case of Japanese encephalitis. So this brings the New South Wales number to 4 confirmed cases of Japanese encephalitis, and we do have a number of other people who remain under investigation and undergoing further testing. So the additional case is a lady in her 60s who is also from the Griffith area. I'm pleased that she apparently is out of hospital and recovering at home, so that is good news. The committee may recall that yesterday we announced the sad death of a gentleman in his 70s who was also from the Griffith area as the 3rd confirmed case. So that gentleman is the only death that we are aware of JE in a New South Wales resident to date. But that is the, update on confirmed cases in New South Wales. So it is concerning, and there is a lot of work being done, which I'm happy to take questions on if you'd like to hear.
Mr. Chair, one quick indulgence question. JE, is it spread by mosquitoes or can it be human-to-human contact?
Mosquito.
So it is spread by mosquito bite.
Right.
So yes, it's only spread by infected mosquitoes. And so what really is the unfortunate thing in relation to this situation is that previously Japanese encephalitis, the virus, was not found really on mainland Australia. It is endemic in countries around Australia, in Southeast Asia, in East Timor to our north, and it's usually a virus found only in tropical areas. And so this was a surprise to all the experts working in the field to identify at the end of February pigs who showed symptoms of Japanese encephalitis. As people will be aware, there are now a number of piggeries confirmed as having pigs infected with Japanese encephalitis across New South Wales, Queensland, Victoria, and also South Australia. And what we have uncovered, as I've just outlined an update of in New South Wales, but also in other jurisdictions, increasing numbers of cases that are confirmed to have Japanese encephalitis, and other numbers under investigation, and we expect those numbers to increase in the weeks ahead.
And that's all from the Griffith region, isn't it?
No, so there are two
Wentworth,
cases
Cora.
around the Griffith region, and as the Minister points out,
Wentworth.
the Wentworth, New South Wales, and also Corowa.
Wentworth, Corowa, Griffith, but obviously the piggeries are more broadly spread, and it's quite possible that we may see cases more broadly spread. The real concern, in summary, is this has never been seen beyond the northern parts, the northern climes, the northern parts of Australia, and into the Torres Strait and into the Asia Pacific. So it's quite concerning that we've suddenly got it moving so far south. And it goes to Kate's earlier commentary about, is climate change relevant to health? Well, of course it is, and this is another perhaps portent of the changing climate. Very concerning. And people need to be, what Gail has not said, is that, again, people need to understand in New South Wales, no matter where you are right now, there's a lot of water around and a lot of mosquitoes around. Take it seriously. Close your wire doors, wear long sleeve shirts, put on some sort of insect repellent, and keep yourself as safe as possible, because it's certainly capable of killing you.
Happy Chair.
Thank you.
Sorry, Emma, thank you for that.
No, that's all right. I think I might actually continue the discussion on I will call it JE, as the Honourable Walt Secott has called it. My understanding is that there is a vaccine available. Has there been any consideration being given to rolling out vaccinations for people in affected areas or for anyone working inside piggeries where the disease is spread from?
Ask Dr. Gale to address that.
Yes, thank you. No, you're absolutely correct. There are 2 vaccines available for Japanese encephalitis. Both are safe and highly effective. In Australia, the use of the Japanese encephalitis vaccine has been quite limited, because really it is only for travellers. If you were planning to go and spend a month in East Timor or to parts of Southeast Asia where Japanese encephalitis is endemic, then you might visit your travel doctor, your GP, discuss your risk, and they may advise a Japanese encephalitis vaccine. So largely that has been the use in Australia of this vaccine. And as such, the supplies in country were not big, because that's a fairly limited group of people, especially recently as people are not travelling as much. So when evidence came to light about potentially local transmission and the presence of Japanese encephalitis, a lot of urgent work was undertaken by us at the state and also the Commonwealth, and further actions are ongoing to increase the supply of Japanese encephalitis. In New South Wales, we do have a supply, and we acted quickly. Vaccine, apologies, the vaccine, not the virus. We don't want any more of that. So we worked to get an urgent supply of as much vaccine as we could get. And I am aware that the Commonwealth is actively engaging in increasing supplies. We have started rolling out vaccine in the first instance to workers in affected piggeries and any of their family members who may live on site. Currently in New South Wales, we're aware of around 13 affected piggeries, and New South Wales Health has been in touch with all of those piggeries and working out vaccine arrangements. So we've already provided vaccination clinics this week to a number of those piggeries, and there's a vaccination clinic happening today, in fact, with a very large number, hundreds of workers being vaccinated. In some locations, the vaccine may best and most efficiently and quickly be delivered in working with local GPs. So we are facilitating that with local GPs to make that vaccine available for those workers. On an ongoing basis, and we're working closely with the Commonwealth and other jurisdictions, we need to carefully get more information about what the risk of Japanese encephalitis may be, in what regions, to which populations, and all of that information coming in will guide us at a national and a state level as to which populations we should target all available vaccines. But in the first instance, vaccinating piggery workers and their families, given their proximity to pigs and that cycle that we know that is happening between mosquitoes and pigs, is the first priority. And I would just add, in addition to that, we're also looking at vaccinating people who work closely with mosquitoes and with, so for example, laboratory workers, people who work in that industry, vets for piggeries. So we're also looking at making sure we offer vaccine in a timely way to those individuals. But certainly much more planning, much more risk assessment that's underway, and that advice is going to evolve over time.
Thank you. And Dr. Gale, you said earlier that, that locally acquired cases of disease have never really been identified here. Are our local health staff equipped and trained on how to treat people who are coming into GP offices or hospitals with this virus?
Yes, great question. And it is certainly something that all our clinicians, GPs, and also our staff working in hospitals are going to need to become more familiar with, because previously, if a person presented with encephalitis and they had never been overseas, Japanese encephalitis would not be something that you would normally think about and test for. But clearly that has changed. And promptly, so as soon as we found out about this, the next day we issued a clinical alert across the New South Wales health system to alert ICU physicians, emergency department physicians, infectious disease doctors, all our public health units, to be alert to people who may present with encephalitis. And also we have alerted our GP network through a GP alert. There was a webinar held this week with GPs, and in other forums we have also advised our GP colleagues to be alert for this. In terms of clinical treatment for Japanese encephalitis, there is actually no specific treatment. So that treatment remains the same, of supporting anybody with severe encephalitis in intensive care. So yes, a lot of communication and engagement with our clinical community about this significant change.
And what measures are being taken to try to control the spread of this?
Yes, thank you. So one of the really key things at the moment, and probably the most effective measure at minimising the harm of Japanese encephalitis virus, is for a very strong community message, as the Minister has said, around avoiding mosquito bites. That is the most effective thing that any of us could do to prevent being bitten. And the advice that the Minister outlined is absolutely correct. So avoid going outside in the hours where this mosquito bites, between dusk to dawn. Wear long-sleeve clothing, basically minimise any exposure to skin. Use insect repellent, so those containing DEET in particular, picaridin, eucalypt oil. And I would specifically highlight that most repellents are effective on children as well, and it's particularly important to apply insect repellents to children. We know that in endemic countries overseas, often severe illness is seen more often in children. So it is really important message for our community to apply repellents. Follow the instructions, obviously, on any product, but protecting children is very important. So mosquito bite avoidance is very important. We are also working closely with our experts in mosquitoes and what we call vector control, so controlling the thing that spreads the disease, which in this case is mosquitoes. And they're working with national colleagues about what are effective mechanisms to best control mosquitoes. It is challenging because as we'll be aware, there are a lot of mosquitoes around. There are lots of breeding grounds. Mosquitoes can fly long distances. So in control strategies, so for example, fogging or killing the adult or killing the larvae, we need to think about that in a very strategic and targeted way that's most likely to be effective. And I know the experts in the field are actively considering exactly those issues. What there is clear advice on, and what has already happened and is happening, is controlling the vector, so controlling mosquitoes as best we can around the affected piggeries. And so we're working closely with the Department of Primary Industries and with those affected piggeries to enhance the existing vector control that they already have in place in those piggeries. And that's happening as we speak and has been happening because there is evidence that that will be effective if we can do it as well as we can to try and break the cycle of transmission between the mosquitoes and the pigs. And just to explain that, and I'll finish, sorry for this long explanation, but pigs are a bit special in Japanese encephalitis in that they are what we call amplifying hosts. So the mosquitoes bite pigs, but pigs can also sustain a level of high virus that can infect the mosquito back, and so it continues this cycle of transmission. So pigs are what we call amplifying hosts, and that's why controlling mosquitoes, particularly around pig farms, is very important.
Thank you, Doctor. Kate Fairman.
Interesting.
Kate?
Thank you, Chair. Thank you. Minister, I just wanted to go back to one of your comments earlier in today, where I think you said that the BA.2 variant might see COVID cases double within 2 to 3 weeks.
Yes.
No, I didn't therefore hear what after that what your government is doing to mitigate that, what public health orders might come in place, whether masks are going to be mandated again.
Kate, I think actually what I said was that in the next few weeks we're expecting the numbers to more than double. But that's on the basis of very early advice from the researchers at the University of New South Wales. And I said there's a lot more work to do, and Dr. Gale also confirmed there's a lot more work to do before there's absolute certainty about it. So I guess what we're saying today is on a precautionary principle, early advice. If we don't share that information with the public, then that would not be appropriate. But equally, the information is very it's very early information. And I think it may be that there are measures that have to be taken, but I think that we've also I talked about the logical one, and the logical one is to go and get vaccinated. You know, there's, I think, as at today, there's, I think I said just over 50%, I think it's about 56% of people, give or take, who are eligible over 16, who have had the booster. That leaves about, 44% of the community who haven't had the booster.
Thank you, Minister. Yes, thank you very much, because you have said that earlier. That's great. I agree with you, of course. When will 12 to 15-year-olds be able to get their boosters?
Dr. Gale?
Yes, thank you. So on that question, again, we rely on the advice that will be considered at a federal level by the Australian Technical Advisory Group on Immunisation and their advice in relation to boosters for those under 16 years old. So I understand that they will be reviewing the evidence on that and providing advice in due course.
Okay, thank you. So just, okay, that's fine for that. I'm probably running out of time for other questions. I quickly just wanted to go to the response to the Special Commission of Inquiry into Weiss Minister. It's now 2 years since that report was handed down. Your government promised to respond to the report, I think by the end of 2021 or in 2021. Where is that up to, and why haven't we seen any response to the ICE inquiry report yet?
I think you're aware, Ms Femin, that the response is a whole of government response. and it's being managed not by health, so I can't comment on the specifics other than to say that obviously health have given our view, and it's complex. And whole of government means there's a lot of different portfolios and a lot of different aspects that need to be considered. And the government is doing its best to make sure that there is a comprehensive, completely broad-scale response when it becomes available.
So just in relation to that, obviously the Special Commission of Inquiry was held in response to terrible situations regarding the drug ice, as well as other drugs, people unable to get treatment. This is still continuing, particularly in regional New South Wales, but of course everywhere. When was the last time New South Wales had a formal drug and alcohol policy?
I think obviously health has its own approach to drugs and alcohol, but you're asking about a response to a commission of inquiry, and the commission of inquiry was completed by Dan Howard, and as I said to you, the government is responding to that as it can in a whole of government approach. It's not something which you should be addressing to me because I'm not the minister responsible for that response.
Yes, Minister, I am addressing it to you, though, specifically. Dan Howard himself wrote in the Sydney Morning Herald that we have had no formal drug and alcohol policy whatsoever for a decade. Surely that fits within your remit, even if you don't have control ultimately over the government response to the ICE inquiry. Surely you can do your bit and ensure we have a strong drug and alcohol policy in New South Wales.
Well, I'm sorry. The inquiry, obviously there are medical practices and procedures that respond to people who use drugs and who find themselves at disadvantage as a result of that. But in terms of the overall prevention, that's a whole of government response. I'm not arguing with Mr. Howard's comments in whatever paper it is you're talking about, but I'm just responding to you and saying that it's a whole of government response. It's been made very clear by the Premier and others that it's a whole of government response, and I can't elaborate or give you information that is not within my immediate purview. I can't do that.
Minister, are you suggesting that you're not going to do anything in relation to alcohol and drug, for example, increasing funding for alcohol and drug services to ensure that New South Wales Health is able to respond in terms of treatment much more? Are you saying that you don't have a responsibility outside of the ICE inquiry to ensure that you can do as much as possible to potentially meet any of those recommendations?
I think that's what's commonly called putting words into one's mouth and to my mouth. Don't do that, Kate. I've indicated that you asked a question which is around the Commission of Inquiry. I've indicated to you that the whole of government approach will be available at an appropriate time by the whole of government. That's not something which is in the purview of the Health Minister. But of course there are a whole range of things that Health currently does and will continue to do in regard to treatment for drug and alcohol and addictions. And I might ask Dr. Lyons, I don't know whether he's got any information there, but he would be the person who would have some of that information which may assist you if you're interested to knowing what's currently happening. But that wasn't the question you asked me. Dr. Lyons, do you have any information on that currently? Or would you
have a little bit, Minister. So
okay, well, why don't you share that with Ms. Fairman?
New South Wales Health, we're responsible for a range of services in this space. As you're aware, we deliver education, brief intervention, treatment, rehabilitation and continuing care programs, and that's statewide. And we do that through the services we operate, but also with arrangements with other non-government services. In the 2021 budget year, that's this budget year, we have committed over $330 million to those services across the state. And in addition to that, the announcement by the government of an additional $7.5 million in November 2020 for a drug and rehabilitation residential care service in Dubbo to support some of the specific issues out at Dubbo. So, I mean, we recognise there's still much more to be done, but we are committed. We run a lot of services and we are investing in a range of services and resources to support people with these conditions.
Thank you, Doctor. to the opposition.
Minister, I want to return to some questions I asked earlier about the Minister for Rural Health, and I'd like to move into her areas of responsibility. And some time ago, she said that it's still being worked out. Now, she claimed at budget estimates last week that she would have a responsibility of 9 LHDs and their appointments. How will that actually work? Will she appoint the LHDs, those people, to those positions, or will it still remember?
Which LHD? Oh, sorry, what
Well, she said she would be responsible for 9 of them.
But what positions are you talking about?
Well, I was asking the boards. The boards.
Oh, well, you didn't say boards.
Oh, I'm
Now you
sorry.
say
I
boards.
assumed that you meant boards. Sorry, Minister.
I don't know. I never take.
Okay.
I would
boards.
never guess what you're going to ask about, Mr. Secretary.
Boards.
What about it? What's your
Membership of
question?
boards.
I want to know membership of boards. Will the membership of boards be with her, as she has claimed, or will they be with you?
I'll do a point of order, and the Minister might like to check the hands out on that. I'm not sure. I was there.
Okay, let me
I'm not certain that she said that she would be appointing
Champ,
us
let me
if she
rephrase the question.
consulted, and
Champ, let me
consulted
rephrase the
process.
question.
So I wanted to get the
Minister,
words
will you
right.
be responsible for the LHD board appointments, or will the Minister for Regional Health be responsible?
As I said to you earlier, I'm delighted to have another minister helping me, and she helped me before anyway. I don't know. I amused myself for half an hour watching some of your questions, which were exactly as I would have expected.
Thank you.
Actually, exactly as I expected.
Thank you.
And I won't pass comment on it other than to say they were as expected. Having another minister who can take part in the biggest budget and the biggest staffing in the country by a long shot of any government agency is an absolute delight. And having her working with me, as did Tanya Davies previously, in the mental health area has been incredible. They were also readily available to assist, and whenever I was appointing anybody to boards or to doing anything like that, I always worked with the ministers anyway. So there's actually practically no difference, except that it might be possible now, as the minister's indicated, that she can take primary responsibility for some of those issues, but we'll work in a collaborative way. I heard a whole lot of dribble. I'm sorry, a whole lot of dribble. Are you a junior minister? Are you a senior minister? Sorry, don't even suggest that to me today, because if you do, that will just show how juvenile this committee has become.
Okay.
I won't engage in that. We work collaboratively, and we will do exactly what's necessary for the patients and people of New South Wales.
Are you chair? Okay. Minister, now I want to take you to, there's a community-based petition led by Dr. Joe McGurr, member for Wagga, backed by the New South Wales Farmers Association to actually set up a rural health department. What's your response to that campaign?
Look, I think Dr. McGurr, I respect him greatly, but I think that Queensland doesn't have such an arrangement, Victoria doesn't have such an arrangement, South Australia doesn't have such an arrangement, Tasmania doesn't have such an arrangement. There's a slight subset in WA for regional health because they have very small remote communities up through the Kimberley. But I think that there is a good argument to say that there needs to be a focus within the agency, that is within the overall Ministry of Health and the local health districts, but particularly the ministry, on how to balance the regional health focus. How that should be done is being worked through, as the Minister indicated to you last week. But a separate department, whilst I respect Dr. McGurr's view, I think that it's a bit... I think it was the Deputy President of the Rural Doctors Association in Temora who actually said she and the Rural Health Doctors Network oppose it. And I think there are, like everything else in health, there's a million different views. But I don't see that it necessarily is valuable to fracture the current health system. I think it's more managing it within the overall network, because many of the issues, for example, as we were talking about before, children's health, we have some amazing paediatricians working in some of our regional major hospitals, Wagga, Dubbo, Orange and so on, to Tamworth. But for major work, they still have to come and have an association with city-based, highly specialised services. And so that concept is important for patient safety and for patients' best outcomes. Where we can, of course, it'd be wonderful to have services in the full range in the regions, but it isn't always possible as is evidenced by what's going on not just throughout the entire states of Australia, but in fact the United States and other major countries of large size. So I think that having some sort of focus within health on the regional health, and I accept that's one thing I accept definitely out of the inquiry that Mr. Donnelly. Do you chair that, Greg, or do you not chair it, the regional one?
Well, yeah, you would know that.
I'm just asking, did you chair it? I'm not sure who chaired it.
Yeah.
You chaired it. I think that there's some valuable concepts that come out of that allow more focus on the regional health issues, but a separate department would fracture health, so I don't see that necessarily is the answer at this point. But look, I'm not closed to anything, working through with health and discussing those issues as to what would be best.
Deputy Chair.
I just want to return back to zoonotic diseases, which we seem to be talking about.
Sorry, Emma, I missed the first part.
Sorry, I'm just returning back to zoonotic disease outbreaks, which we seem to be talking a lot about recently. But earlier this week, Safe Work New South Wales put out a press release urging people to be wary of floodwaters and muddy soil that could be contaminated with leptospirosis. Have we seen any cases in New South Wales of leptospirosis, and what's the current situation there?
On that one, I will absolutely defer to Dr. Gale because leptospirosis is not my area of expertise. Dr. Gale.
Thank you. Look, in the context of floodwaters, leptospirosis is always something that we watch out for carefully. And we know that in certain parts of the state and up north, we have had in the past some localised outbreaks of leptospirosis. So it certainly is something that we're vigilant about. But as to the current case numbers, I don't believe there are any, but I will come back to you and happy to take that on notice as to an update on any cases and also the measures that have been taken. But in the context of floods, and it has occurred in the past in parts of the state, outbreaks of the disease leptospirosis, but I'm happy to take that on notice and come back to you with some detail.
It's more of a precaution.
What does leptospirosis actually do, Dr. Gale, just out of interest?
Oh, yes, well, I'll have to refresh my memory as well as to the full clinical manifestations. So,
praise the Lord.
Yes, that's right.
To Kay Fairman.
Thank you, Chair. Minister, I just wanted to quickly turn to bed block at Westmead Hospital with ambulances. On the 3rd of March, a photo was taken with 12 ambulances lined up between 9 and 10 p.m. I understand the entire Western Sydney and the PM Blue Mountains is at that time meant to have 31 cars, so over a third of those ambulances were parked at one hospital. I'm interested to know what you think is the root cause. I understand that not one of those 12 ambulances would have been able to respond, obviously, to a priority 1 incident, as they all had patients that they were in the process of offloading and transferring care, which can take hours. Do you know what's going on there?
Look, I think it's fair to say that from time to time, all hospitals will have some issues, particularly if you have COVID patients in the emergency department, and that's the nature of being in a 1 in 100 year pandemic. The concept of what still causes major grief in other states, that is ambulance blockage, is actually very rare now in New South Wales. And the person sitting to my left, the Secretary of New South Wales Health, has been one of the major reasons why we don't have it, because at any one time in the morning, at least I don't know whether she'll still do it as Secretary, but as Deputy Secretary, she would be up at 2 a.m. and 3 a.m. and 4 a.m, making sure that ambulances are directed to hospitals that are not as busy with, for example, COVID patients. So I'm going to defer to Ms Pearce to give you an answer more broadly.
Ms Fairman, I can't speak to the specifics of the 3rd of March that you've raised, but what I would say to you in general terms about photos of ambulances in emergency departments is that from time to time, certainly we do have a large number of ambulances in emergency departments. It doesn't mean that they are all significantly delayed. That is one point that I would make, and we will be able to clarify that. We have worked very hard for many, many years, and we work very closely with the New South Wales Ambulance Service 24 hours a day, as the Minister has indicated, to ensure that we avoid, wherever possible, those types of delays. But it's not to say that it doesn't happen. It does from time to time. We saw a very significant increase in emergency department attendances across the Christmas and New Year period, then somewhat of a decline, and over the last 2 weeks we've seen quite a significant increase once again. Our emergency departments certainly have been impacted by the management of COVID. We are still managing those models of care to keep people safe, but certainly this is something that has our attention all of the time, and we work very hard, as I said, to ensure we get our ambulance paramedics out on the road as quickly as we can. I did, and look, self-praise being no recommendation whatsoever, but the Ambulance Service Chief Executive did pass comment just this week that New South Wales is admired by all other states for the involvement of the New South Wales Ministry of Health with the service to ensure that we certainly don't turn away from what their issues are as we deal with other hospital issues. So I just simply can't state strongly enough the level of effort and energy that goes into that every day.
The self-praise in this case is appropriate, Ms Pearce.
Well deserved, I've got to say. If you look at what happens in some other states, New South Wales is way out, light years in front in managing the issues.
Our time.
Well, thank you.
And that's due to Susan Pearce.
It's due to our whole system.
Oh, yes, due to the whole system, but it's also due to you and the work you do with the whole system.
There's no INT.
Well,
That's right.
thank you, our Senior Health Minister and officers. We'll break for lunch.
The government will...
I think I said that... Anyway, I'm not going to bother. Don't do it again.
The government will withhold asking questions. We felt no need to seek any elucidations from the Minister at this time.
Excellent.
Is that a reflection on me?
Yes. Yeah, it actually is, Minister.
I bet it is.
Correct.
Negative.
Thank you very much. We'll have
So what time do we come back?
2 p.m. Proceed, yes.
Committee Chair and to the members of the committee, thank you for your time this morning and for whatever time we have this afternoon. But I was just going to indicate to you that a number of the people at the table are dealing, in fact, pretty well everybody is dealing with the issues to do with both the floods, Japanese encephalitis and the issues to do with the BA2 COVID. And I'm wondering if at all possible, I'm not going to...
I understand the request.
I'm just going to ask whether it could be possible to terminate the day-long conference committee meeting at 3:30 if possible today, or earlier depending on what the committee members think, but 3:30 at the latest.
Well, I just want to speak to Deputy Chair, but we'll let you know. I mean, we'll work towards that. I think that's probably likely, but I just need to consult with the Deputy Chair. I just can't unilaterally
on behalf
decide
of the health officials
I understand
here,
that.
would be very grateful.
Chair, the government would have no opposition to that.
Thank you, Honourable Secord. No, sorry, that's all. Looking there.
I've aged
I
about 50
apologise.
years.
Yes, no, I'm sorry. Don't take that the wrong way. Where's Fang?
Gone grey.
So-
and lost a bit of hair. So, you know, just the glasses
May we
the
get
same.
matters underway, but before we do so, I just need to deal with the formalities of our two new witnesses that are joining us this afternoon. So both Dr Penner and Ms Cross, thank you for joining us this afternoon. So in terms of the formalities, it's a name, agency, and there's the swearing of either an oath or an affirmation. So I think you've been through the drill before. So perhaps we'll start with Dr Penner, please.
I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth. So help me God.
Thank you very much, Doctor. And Ms Cross, we'll have you sworn or affirmed.
Jacqueline Marie Cross, Chief Nursing and Midwifery Officer. Affirmation: I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you for joining us this afternoon, Ms Cross. Thank you.
Thank you.
So we'll get matters underway, rolling in 50-minute tranches, and commence with the opposition.
Could I also, interrupt for 2 seconds? I've just been advised by the Secretary that she wants to clarify, you asked about YAS before?
Yes.
Ambulance had given us information which nuanced a little bit, needs to be clarified.
No.
In relation to the person who was there, brought in, that was a paramedic and a nurse, we now think it's possible, we've got to do some more checking, so just want to put it on notice that it's possible the person was a paramedic and a medic, as I understand it. So we'll take that on notice to clarify once we really pin it down, having in mind the diverse advice that we've got at this point, which is just happens in such a big system.
I understand.
Yes.
Thank you. Honourable Watson.
Thank you. Minister, I'd like to take you to, security and safety issues in the health and hospital system. You'd be aware of late last year, in the last quarter of last year, a violent incident at Port Macquarie.
Yes.
Yes. I was just wondering if there were any changes or implementations or learnings that came out of that involving the health and hospital system.
Mr. Scott, every time there is an incident, there are learnings. There's no doubt about that. One of the issues that I have at the moment is I've been working. You'd remember that there was a review by Peter Anderson, former Labor Police Minister and Health Minister, who's did an incredible job reviewing the security issues, and I've been working with the Health Services Union, who represent the majority of security officers through our health system. Security officers are employed, obviously, by the individual local health districts, and individual local health districts with their individual independent boards, which are subject to some central direction but nevertheless are independent, have varying views on how the security should be conducted. I was of the view that we were moving towards a trial to give security officers more powers, particularly to detain and to effectively, search on a person. That was certainly something that I was even more motivated by following the incident at Port Macquarie and other incidents for that matter. most recently I've been having discussions with the HSU and security officers and police and representatives of the Attorney-General to see what is achievable, because it appeared to me that it was been 2 steps forward, 1 step back. And I'm now working with them. I think it was a meeting maybe 2 weeks ago, just prior to the floods. And the floods have sort of distracted us away from that for the moment, but certainly working on that, and very keen personally as a health minister to empower security officers, but it also has to be done in a way that recognises that in a hospital environment, a health environment, they're part of the broader health team. And I think from my discussions with some of the security officers, they don't always feel that that's the case, that their views are not respected. There's obviously got to be appropriate training and appropriate understanding of those relationships, quite complex. And we would be probably going a step further than anybody else in the country's done, but I'm keen to do it. But I also have to work with those relevant groups that I just talked about to make sure that it's viable.
Now, I understand as part of the Anderson review that he recommended that there be an inserting a new part in the Health Services Act dealing with hospital security, safety, and recognize the duties, powers, rights, and responsibilities of security staff and any related matters that would arise from safety on hospitals. And he also noted that there were and he wanted to recommend that removal of all legal barriers hampering the transport of patients or people at hospitals from one part to another. Do you have a timetable on responding to the Anderson review?
Well, I think that's what I'm saying, that my response has been to work with the relevant parties to try and see what's achievable. I'm very supportive of the Anderson review, and working through that, though, what happened was that there was discussions with very senior police going back maybe 6 months, 10 months, something like that, who indicated that they were supportive of a number of these amendments, which go, as I said, further than has previously been the situation in any state or territory in recent years. It used to be, as Gerard Hayes reminded me on a number of occasions, it used to be that we had special constables or special constable status inside the hospitals. But over the years, it's become a focus on the more holistic role of a security officer as part of the health team. Where it's becomes problematic sometimes is the limited powers that security officers have, and in some environments it's a better association and relationship with the doctors and nurses who are looking after the patient. I mean, that's what a hospital is about, looking after the patient.
So, Minister, is the stumbling block the Attorney General's department? Is that where it's been quite a while since the...
I don't think so. I think the issue was more about, well, maybe it is, but it's not what I've seen so far. Okay. What I think is the major issue has just been to try and work through whether or not the police are in agreement with it, but it's certainly, I've had discussions. I just said, did I say that Karen Webb was there or not? Anyway, the new commissioner was... Karen Webb, made herself available, which was wonderful, because she'd only been in the job for I think a week or two, and she made herself available for a 7:30am meeting. I saw today there was criticism of the new commissioner. Could I just say I think that was wholly unfair and unreasonable. She works herself, like every other police commissioner, completely into the ground, and she's been doing that both in her former position and in her current position, and I was appalled to see that article today in the Telegraph. But anyway, she has been working very hard on floods as well. It seems like some journalists think you can't walk and chew gum at the same time, and maybe they can't. But nevertheless, she does, and she works hard at it, and she has been to a meeting with us, and she understands the needs, and we're working through those policing issues. And once we've settled on those, then we can have those further discussions with the Attorney General's office.
Now, I want to take you to, in 2019, actually I remember it from the estimates. It came from an afternoon session, and we'd asked one of your departmental officials about a pilot involving body-worn cameras.
Oh, yeah.
And
for security or for paramedics?
For paramedics.
Yep.
For paramedics. And it was announced that in November 2019 there'd be 3 locations for a 12-month trial. So what were the findings and recommendations of that, of the 3 locations?
Well, the discussions that I've had with the Chief Executive Ambulance are that it went well. I've spoken to a lot of the paramedics at the front line. It went well. What actually happened, though, was that it went on hold during COVID because suddenly the paramedics couldn't actually they couldn't wear the camera on their clothes because they were covered with the PPE. So it all came to a bit of a stalling halt. But the early indications in the trial, while it lasted pre-COVID and PPE, were that it worked well. And I'm not sure whether they've now got to the point where, because not all paramedics are now wearing PPE all the time. I'm just not sure where they've got to, but I'm happy to take that on notice because it's something which was in my mind as well to ask the Commissioner, but I haven't asked him in the last few weeks.
Thank you. Courtney?
Thanks very much. Minister, in relation to the government's rail shutdown, obviously there were plenty of health staff who were stranded on the day. When did you become aware of the shutdown?
You're serious? You're going to start asking the Health Minister. This is maybe we should. Maybe I should move this committee actually to finish at 2:30, not 3:30.
I will do a point of order, Mr. Chair. I mean, clearly this is outside the Health Minister's ambit in terms of the budget. This is a Transport Minister question. So
I'm just asking the Minister.
It's not. I'll answer it. I'll answer it, but I think it's a pretty dumb question to be asking a Health Minister, to be honest. In the middle of COVID, flood, and Japanese encephalitis, to ask me when I found out about the railways is just absolutely ludicrous. But when I woke up, when I saw it on the radio.
Well, Minister, I'm asking you this because we've talked this morning about the unprecedented pressure that's on our workforce, on our health workforce.
Absolutely.
And I'm interested to know whether you tracked how many nurses, how many doctors, how many of our health workers were unable to get to work on that day.
But that's not what you asked me. You asked me what time I found out, and it's completely irrelevant. I'll ask the Secretary.
I'm interested to know.
Minister. You understand that you don't get to ask the questions. The members ask. No.
I made an observation.
No.
Which I'm entitled to do.
Well, Minister, your triad against the honourable member asking the question, I think, is pretty poor form on your part. The question was asked to lead then to the question about the inability of healthcare workers to get to work.
Chair.
It's perfectly reasonable to ask the question.
Don't worry about it, Wes.
So you're the only minister who comes along to hearings, as far as I know, and puts down questions so blandly as you did. It was a perfectly reasonable question from the honourable member. Your attitude towards questions you don't like is to be so dismissive. It had a context. I would have thought an apology to the honourable member is the least you could do in the circumstances.
No, because what I'm saying is asking a health minister about transport when I found out is ludicrous. Anyway, we'll move on to the second part of the question.
No, it's perfectly appropriate question. The health workforce in New South Wales was significantly impacted by the transport strike. So it's perfectly reasonable to ask you questions. Now, you might want to put it down and say it's not relevant. It's perfectly relevant. If you don't want to answer the question, that's fine, but it's a perfectly relevant question. Totally in order.
Minister, did you track the
Can I now go
absentees
to
on
ask
the
the
day?
Secretary to answer the question that was relevant? Madam Secretary.
No, Minister, no. Both questions were relevant. The first question was in terms of understanding your time, that you understood the situation, and then we move on to the question.
Chair, I will raise a point.
Well, I haven't finished.
Okay.
So there was two parts to it. Setting up the context to ask you, and then the impacting question. Perfectly in order.
Setting up's the word.
So you can't dismiss questions. You don't get to dismiss questions, Minister.
Actually, I get to answer them in the way that I think is appropriate.
Yes, but you don't get to dismiss them.
I answered the question. I said it was irrelevant.
Minister, it wasn't irrelevant.
I'm not going to argue with you. I'll give my answer. It's irrelevant. And now I'm asking the Secretary.
Minister, you can be pig-headed and try and dismiss questions that way. It
I can be
reflects on you.
Chair,
it reflects on you.
I feel
can be
as
accurate.
No, it reflects on you very badly.
Well, actually, having watched you in last week with my colleague Bronnie Taylor, I don't think you're in a position to go criticising me, Mr. Chair, so I will now ask the Secretary to answer the question.
No, the Minister Taylor had to go down that line of discussion if you like.
Well, why not? Madam Secretary, could you answer the question, please? The relevant issue in terms of the staff impacts of the railway line, please.
Ms. Hussos, we'd have to take on notice the actual quantum of staff. If we can get that information for you, we'd be happy to do that. What I can tell you is that every Monday we have a meeting with all of our chief executives across the state just to check how the weekend's gone and understand what Monday is looking like in terms of patient flow. During that meeting that morning, as I recall, the train strike was on a Monday, if I'm not mistaken. We asked our chief executives during the course of that morning as to any staffing impacts that were associated with the transport strike. Certainly, I'm not saying that there were none. What I can say, though, is that the impacts were relatively limited from what I can recall from those discussions, but we can take on notice the specifics for you.
That would be great if you could give me either the total number or the proportion of the workforce that was absent on the day. Were there any specific, special initiatives or anything? We heard, anyone listening to morning radio heard about nurses paying hundreds of dollars for Ubers and for taxis and all kinds of things that were going on on the morning. Was there anything specifically that was provided to?
Government member.
I haven't heard that, but happy to. Have you heard that? Have you?
It was on.
It was on.
I think it
It
was
was
on
on commercial.
ABC.
It was on commercial radio and the ABC.
Yeah.
On that basis, I'll find out from. I'll ask the secretary to find out from the LHDs, because it would only be the metropolitan LHDs, not the north side, or a little bit of the north side, mostly west and southwest. So we can find out what was done on that front. And if you have any specific issues of hardship, raise it with me, and I'll raise it with health. Yeah.
Thanks very much. How much time do I have?
Well, listen, we won't be able to be available to complete by 3:30. We'll have to press on beyond that. So let's keep going. So.
Okay.
Yeah.
Are you okay?
Yeah,
I've
sure.
got some questions.
Minister, I'd like to take you to Eurobodella Hospital.
Sorry?
Eurobodella Hospital.
Yeah. Mm-hmm.
So last week from rural health, regional health, we were told that no site has been secured yet. Through you to do Ms. Work, what is the status of the allocating, securing of the land? Or do you have
what you were actually told, because Dr. Lyons read it out just before the lunchtime break, was the facts. And the facts are that more than 30 sites were looked at.
Yep.
And that health infrastructure determined on a particular site, which on the 20th of December,
yep,
the relevant notice under the, what is it? Just terms compensation legislation was served.
Familiar with that.
And that's what you were told by Dr. Lyons on that day. He didn't mention the date, but I had texted him with the date. And it was served on the 20th. And by the second week of April, what happens off that, if you're not familiar with the just terms?
No, I'm very familiar with the legislation.
Well, I'll explain it to the rest of the committee so they know. What happens is, if you have, they had negotiated for 13 months, I think, with the owner of the property, and he wasn't inclined to the price that they considered was fair. So on behalf of taxpayers, the next step is to serve the notice, which warns him that it will be compulsorily acquired. And that will be around about middle of April. And at that point, the land will then be gazetted through the resumption processes. It has to be signed off by me, signed off by the governor. It then becomes an asset of the Crown, taxpayers, and the discussions around the value of the land becomes a matter for the valuer general. But I'll ask Ms. Walk whether she wants to add anything to that, or is that sufficient?
I think that's accurate, Minister. Thank you. We are continuing to have discussions with the vendor. Those discussions are amicable. We are in the process of looking at the correspondence from them, seeking further valuations for ourselves to inform potentially a further offer. So we're very open to making an offer which is hopefully acceptable to the vendor. And in the meantime, we will continue down the processes of the Just Terms Compensation Act.
So you should have.
No,
I'm sorry.
Yep. We'll move around.
Sorry, Emma.
Deputy Chair.
Thank you. Thanks, Chair. Research has shown that 1 in 3 Australian women experience birth trauma, and that 1 in 10 women experience PTSD after childbirth, and that these statistics are actually getting worse over time. Are you aware of this? and what's sort of being done in that space?
I think you're aware that there's been a lot of work done through the mental health portfolio for women more broadly with childbirth, both antenatal and postnatal. And as to the physical injuries, I'll ask Dr. Lyons whether he has something to add to that.
I'd appreciate, Ms Hurst, if you could define up a little bit more around what you mean by birth trauma, because I think there are different views about the childbirth process, and depending on the perspective, it can be a different interpretation of what's actually traumatic. So I'd like to understand a little bit more about what you mean by that.
It's based off an article which I can give you a copy of. I do have a copy of it here, but it doesn't sort of go into detail. It's sort of a self-reported, obviously PTSD is quite specific, but that was 1 in 10. But I'm assuming that trauma is that self-reported trauma that they had a difficult experience for a variety of reasons during that childbirth process. But I can get that article if you need to.
That's okay. I was interested just to understand a little bit more about what you meant by that, but I can talk about the services that we offer, and we offer an extensive range of perinatal services, including support for mothers and fathers. And particularly where there have been issues of concern around the mental health and well-being of the parents involved, and we have an extensive range of those services available and have expanded them recently, including a contract with the Gidget Foundation for support, and we're also just about to expand into the perinatal services that we were promised as part of an election commitment. So we've got 2 statewide services that are being built at the moment, one at Royal Prince Alfred and one at Westmead, as those units will provide the high-level services for people who aren't able to be cared for in a community or outpatient setting. But it involves a multidisciplinary team involving psychiatrists, psychologists, social workers, and a range of parent craft type services as well. So in addition to the extra services we put into Tresillian and Keratani over the last 2-3 years, we're actually expanding those high-level quaternary services as well for those people who really need that high-level care.
Thank you. And I guess the other reason I wanted to talk about women self-reporting trauma during childbirth is because one solution that's been put forward and has been quite strongly advocated for by maternity advocacy groups is the continuity of midwife care throughout the pregnancy process, so that women can have a midwife that they know throughout the birth process to advocate for them. At the moment, only about 10% of women can access a known midwife at birth, while in other countries such as New Zealand, it's 90%. Is this something that's being looked into at all?
So I can answer that, thanks, Ms. Hurst. So I think the most important thing from our point of view in terms of the services we offer in New South Wales is about ensuring that there's choice available. And so we have a range of services available, including models that include that continuity of care for midwifery services. And the really important thing is to make sure that parents, women in particular, are offered that choice about how they'd like their birthing experience and what type of care they'd like to be provided, because there are a range of different views about the type of care people would like to receive. So wherever possible, we look to offer that choice, including models which would include continuity of care through midwives.
But is that choice available to most women? Given the statistics that the advocacy groups are telling me is that only 10% of women actually have access to that continuity of care model. I mean, if only 10% have access, is that a choice?
Well, I think we need to look at that in the context of how the services are provided and where they're provided. And as you know, it varies it's very different across the state. So we've heard examples of where in rural services, for instance, we may not have as much choice because there aren't as many providers available. But where there is the ability to actually provide services across a range of different types of models, we do look at having that choice available. So I can't offer an opinion about the percentage, but I would say that where it's possible to offer choice, that's our position.
Thank you. I'll just got one more and then I'll throw to you. Minister, I also spoke about this issue with Minister Taylor and she was very open to meeting with advocacy groups in this space to see what can be done. Are you interested and open in attending those meetings with Minister Taylor as well, considering it sort of crosses between both portfolios?
In relation to the midwifery?
Yes.
Yeah, sure.
So,
How many hospitals currently offer the continuity of care model?
I'd have to take that on notice and get the detail of that, but there are many hospitals that do offer community midwifery programs and continuity of care through midwife practice.
Yeah, okay. Can you also provide if any of them do outreach specifically with called communities?
Certainly.
Thanks.
Sorry, what was that question?
Were there any specifically offer?
Certainly, and I don't know whether the Chief Nursing and Midwifery Officer would like to comment, but certainly the last time I looked at this, all of our local health districts have midwifery continuity of care models, and they're quite extensive across the state.
Yeah. And another piece...
so Jackie Cross is our New South Wales Chief Nurse, so I don't think she's necessarily a midwife, but she can give advice on that. So
I'm the midwifery officer.
What?
I am the midwifery officer.
Oh,
as
there
well.
you go. Okay.
But I can actually talk about one of the initiatives that's come out of our office over the last 12 months or so. So we have a principal advisor for midwifery, and she's been leading a piece of work looking at what they're calling a modified antenatal postnatal service, which is a form of continuity of care for our midwives. So she's been supporting the midwives across the state to implement that locally. So at the moment we've got 10 maternity services that have introduced that MAPS model. It was trialled at the Royal Hospital for Women, and it's been taken up quite well with our midwifery leaders. So that's one of the initiatives, as I said, that's coming out of our office to try and get another model around continuity care.
and Ms. Cross, is there anything online that we can read about that example that you're giving? Is there reports or...
I can provide you with that. There's actually also, there was a research just recently that came out of, I think, Canterbury Hospital about the model itself and the satisfaction, I suppose, for midwives, but most importantly for the women who were working within that model. So be happy to share that with you.
Thank you.
Do you want us to table it, or do you want us to send you one? What would you like? Or, Mr. Chairman, what do you want?
Whatever's easier. I personally don't mind. Did you want it tabled or?
Yeah.
We'll table it. Yeah.
Okay,
if you're comfortable with that.
But actually, if you could table it, but also send a direct copy to the Deputy Chair, please.
Thank you. I appreciate that. Minister, I've asked you on a number of occasions about transparency in government funding for animal research, and you might be aware that we now have an inquiry in PC2 on this issue of animals and experimentation. Are you open to the idea of greater reporting where government funding is used that relates to animals used in medical experimentation?
I don't see why transparency shouldn't be in all areas. Yeah, sure.
I'd also like to bring up...
Can I just say on that, Emma? I mean, my view would be that's my first position, but I guess I'd have to take advice from health on it. But if you, as I understood it, you've got the inquiry going. And I would presume you'll... where's it up to? Have you pulled any... Have you called for...
We're just open for submissions at the moment.
Oh, okay. Well, I might ask health. Has there been a submission from health yet?
Not that I'm aware of.
We might find out if there's been a submission from health.
Dr. Penner.
Dr. Penner.
There is a submission going through the DPC from health.
It's the first time you've spoken in a parliamentary inquiry? Is that it?
No, it's not.
But there is a submission.
Good. So there's one coming from health. Dr. Penner looks after all of the research aspects for health, and so he can make sure that that comes through.
Wonderful, thank you. I'd also like to bring up the issue of funding for alternatives to the use of animals in experimentation. New South Wales Health, as you know, has a variety of grants for a wide range of research initiatives, including things like gene and cell therapy. Would you be open to setting up a grants program to develop alternatives to the use of animals in research?
I would have thought that already they try to avoid the use of animals if at all possible, but perhaps I could ask Dr. Pennis to give us a little bit of information about that, but I'm not averse to it at all. I just
to clarify, it's a little bit different. I mean, so the use of animals in research, yes, they are supposed to sort of meet certain criteria to use those animals, and they do look at alternatives, and they're required to. But what I'm actually talking about is research into the alternatives to actually switch it. So the UK and the US have specific funding available for researchers to find alternatives. So one alternative that people are looking at the moment is the forced swim model where they drown animals in water. And so people are actually trying to say, can we look at depression under a different model that doesn't use animals in that way? And so there's a lot of different governments around the world that have specific funding to look into research. Can we do this on tissues?
I would be very sympathetic to that position, but I would like to take some advice from those who are more expert than I am in it. But if at all possible, yeah, I support it. But I guess it depends on if there's research funds available and it's limited and it's going to save, for example, lots of little kids or something with research. I mean, I'd want to know what the balancing act is. But first principles, I agree with you. If we could avoid having, as much as possible, any research involving animals, that would be fantastic. Totally agree. So the rest of it I'll take on notice if you don't mind. I'll get some advice.
Thank you. And I'm not sure if Dr. Penner had anything to add.
No, nothing further to add.
Okay. On the New South...
I didn't mean to cut you off if you want to say something.
No.
That's all good.
You want to say
No, it's fine.
On the New South Wales Medical Research website, there is a policy directive entitled Human and Animal Research and the National Health and Medical Research Council Act 1992. This policy is listed as being obsolete since September 2018 and doesn't seem to have been updated since then. Are you able to explain why there doesn't appear to be any kind of current policy regarding animal research?
I'll ask Dr. Penner whether he can answer that, and if he can't, we'll take it on notice. Dr. Penner.
I think we'd need to take it on notice. I need to find out why.
Thank you, if you don't mind. And I've just got a couple of other questions you probably would want to take on notice because they're follow-on questions from that. But are there plans to update that policy? I note that there are current policies on the same page surrounding human research, so it's actually quite unclear why animal research has just been left out there. And also, where would people working within New South Wales Health look for guidance regarding the rules and ethics surrounding animal research in the absence of a current policy?
So at the moment, a lot of that is on the Department of Primary Industry, regarding the ethics and scientific review of animal research. But we'll look into all of that to ensure it's all covered.
Thank you. Thank you for that. Minister, it was reported that between July 2020 and December 2021, that New South Wales Health seized more than 100,000 illegal vaping products with a street value of more than $2 million. Are you able to tell us a bit more about these seizures and where most of these illegal vaping products are actually being sold?
A lot of the... well, first of all, can I indicate that I know there are arguments from some quarters that vaping is an exit strategy from smoking. I don't agree with that at all. I think that the advent of vaping has seen so many kids take up vaping that it's atrocious. I also see a lot of people who clearly think they're very cool with vaping devices in their hands, some around this parliament actually. And I shake my head and think of what I was told when I visited the Woolcock Centre one day by one of the respiratory researchers, which is that the chemicals in vaping are largely akin to what you'd find in antifreeze, but dressed up with over 500 different flavours. And the effect on people's lungs is just appalling. So in terms of vaping, we have been looking at this in health. I know there was a move at one stage by the Federal Minister, Greg Hunt, to try and bring together a policy position in the federal parliament, but I think he was largely defeated in those efforts to take steps to try and deter vaping. Vaping currently is not illegal in New South Wales unless it involves nicotine. Nicotine obviously, well, nicotine for children, nicotine products generally are not appropriate for all the obvious reasons. But the real issue, I think, is that a lot of this equipment, well, some of it is, I think, from vaping shops, even though they would deny that. But a lot of it does come in from, what's it called, internet The interweb. No, the internet. So it's very difficult to stop it. But I can also tell you that as a result of our concerns, Health is actually currently preparing a campaign which is due to be made public in the near future to try and warn the community, particularly kids in schools, how dangerous it is. I fear, though, that like most of us, we all have an optimism bias that thinks it won't hurt us, so it's going to be a long, hard fight.
Honourable Courtney Hughes.
Thank you very much, Mr. Chair. Minister, can I ask you, I'd like to ask you about if you're aware of the concerns raised by residents living in the Woollondilly region about significant delays in their access to paramedic treatment?
I'm not specifically aware of that, no.
So my understanding is that your government made a commitment to recruit an additional 12 paramedics for that area over the course of this term of Parliament. Is that correct?
I haven't made that undertaking, but what we did do was we announced that we were, it's about 2 years, 2.5, actually it was before COVID, so it would have been about 3 years ago. Actually, I remember now, down at ambulance headquarters with Jared Hayes there from the HSU, we announced that we were employing another 750 paramedics over this next few-year period, and maybe out of that, ambulance decided that there were going to be allocations to particular areas. I can ask ambulance for you and give you an answer on notice, but it's not that level of allocation I'm not familiar with.
If you could provide us with an answer specifically on the 12 that were slated for
When do you
Woollondilly.
think, just so it makes it simpler, do you know when you think it was announced?
No, my understanding is that you made a commitment to recruit an additional 12 paramedics.
I did.
Yes, the government made a commitment to recruit an additional 12 paramedics for the area. Look, if you can provide us with a progress on the 750 and whether, I'm happy for you to check if there's 12, but how many of those have been recruited for the local area?
I'll get ambulance to provide it through Health and table it here, because I don't know the answer to that question. And I don't remember, I don't have any recollection at all of a specific number, but it's possible that ambulance has done that, yep.
I mean, it's been well publicised in multiple media outlets about the backup of ambulances.
Sorry, I should have asked the Secretary, do you know anything about that?
Not specifically in relation to the 12. I don't know whether Mr Minns has an update on the 750 overall, because I think you might like to comment about that, Phil.
Mr Minns?
Okay, so the commitment commenced in 2018-19. So in that year, 213 paramedics were added and 13 emergency call takers. In 1920, there were a further 209 paramedics and 12 call takers. 2021, a further 167 paramedics and 13 call takers.
Sorry, can you just, for 2021, was that the financial year 21-22?
No, 2021.
Oh, sorry, yep, 2021.
167 paramedics and 13 call takers.
Yep.
And in this current financial year, 21-22, 111 paramedics and 12 call takers.
Okay.
I should have actually said, I said 750 paramedics, but in view of the fact that Mr Minns has been giving you more specific detail, what I'd say is 700 paramedics and 50 paramedic call takers, basically. Yeah.
Excellent. Okay. You would be aware that there's been significant media reporting about the backup of ambulances, and I think one of my colleagues raised it with you.
Kate asked it, didn't she?
Earlier today. That's right. Do you have any response specifically around Wollongong? What's been happening down there? It's been well reported in the Illawarra Mercury.
I'm sorry, I'm not familiar with it. Tell me what you're referring to.
The Illawarra Mercury reported that paramedics were being stuck waiting for more than 4 hours on the 27th and the 28th of February.
I think that's the same issues that the Secretary addressed before. Generally, the backlog, the backing up of ambulance has been amazingly well managed, as I said earlier, because of the work that the Secretary and the team have done. But there can be individual hospital issues too, and I'm not going to name them, but practices in a particular hospital in the emergency department, for example, may not be as streamlined or as efficient as others for a variety of reasons. It may be that they have different makeup of patients that are in the emergency departments. It may be they have more COVID patients in the emergency departments and have to deal with. I mean, Westmead, for example, had all sorts of problems, and in the end, during the peak of was it Omicron or Delta, they had to set up a venue outside ED to be able to triage who had COVID and who didn't. And that got a bit of media attention, thinking, oh, that's terrible. It was actually very good because they were thinking outside the box as to how they would actually manage those issues. And in the process, you would from time to time have perhaps more than you would usually have in terms of ambulances. But there can be a whole variety of reasons why that might be occurring. But, and during February, of course, you're talking about February this year or February last year?
February this year.
February this year. I'll ask the Secretary whether she wants to add anything further, but I can't add any more than that at this stage.
Look, with respect to Wollongong, they have been extremely busy in the emergency department at Wollongong of late, and yes, they have had some delays there. One of the issues, Wollongong, I will say, the emergency department team there do a fabulous job, and so it's unusual for them to have experienced this. One of the issues that has been explained to me is that with regard to discharging patients from the hospital, they've been somewhat challenged by that. They've had a number of elderly residents needing to go back to residential aged care facilities and haven't been able to return them in a timely fashion, so that's caused some issues back into the wards. So we are well across those issues. The district team and the hospital team are well engaged, and as I said earlier, in regard to the Ms Fairman's question, we work on this all of the time. It's not indicative of their overall performance. Wollongong is a very good performer in regard to their emergency department KPIs. In particular, with regard to the triaging of patients, they're one of the best performers out of those A1 hospitals, but certainly they have had a challenging time of late.
Thanks very much, Ms Pearce. I wanted to move on to the question of nurse ratio or staffing levels of nurses to patients and ratios. Minister, do you currently track ratios within the health department, particularly in ICUs?
Do I personally track it?
Does the Ministry of Health track it?
Each hospital obviously has to manage what they need to manage within, whether it's their ICUs, whether it's in their emergency departments, whether it's in their wards. I know I've been meeting with ICU nurses, and Brett Holmes on behalf of the Nurses and Midwives Association, usually with representative nurses, and some of those, or those nurses anyway, the ones that have had those meetings, have expressed concerns about staffing levels in ICUs, if that's what you're referring to.
Yeah, absolutely. Well, the Australian College of Critical Care Nurses and the Australian New Zealand Intensive Care Society both advocate and recommend minimum staffing levels within intensive care units. Mm-hmm. What's your position on that?
I've indicated to the Nurses and Midwives Association that I'd like to see a little more work done on that aspect. Some of the issues they've raised have been around, for example, if a nurse has to go off for some reason, go to the toilet, go for morning tea or lunch, that there might not be appropriate staffing within individual hospitals, such that you can have the usual one-on-one ICU patient arrangements.
Is it your expectation that in the New South Wales health system we should be operating at one-to-one in an ICU?
Look, it depends. There are differing levels of ICUs too. I might ask Mr Minns to comment on this because he's the one that has been most involved. Mr Minns, would you like to give any further clarification to Ms.
So we have a ratios framework referred to as nursing hours per patient day, and it operates in about 380 plus wards across the system. Mm-hmm. And that framework produces the same kind of ratio that the Nurses Association is seeking in terms of one nurse to every 4 patients on day shift and afternoon shift, and 1 to 7 on night shift.
That's on a general ward though, is that correct? Or that's across the wards generally?
There are 383 wards where that model of staffing makes sense because of the typical volume that you experience in those sorts of wards. I can give the committee a list if you like, of the wards where that framework operates.
Thank you, that'd be good.
We also have something that's akin to a ratio framework in maternity, which is called Birth Rate Plus, which is a formula originated in the UK. It's in the award as a method by which you survey the workforce requirements for safe practice in a birthing context. And you do the survey, it talks about the acuity of care, the number of patients you're typically seeing, and it produces a staffing profile that our districts need to follow. And you need to redo that survey periodically. And it would be the case in Western Sydney, where we redid the survey after some issues associated with some of our maternity services there, where there'd been some expansion in the number of births coming through.
Sorry,
ICU,
Mr Minns, I don't like to interrupt you, but the nursing hours per patient don't apply. My understanding is they don't apply to EDs, ICU, HDU.
No, because the standard of nursing is higher than the nursing hours per patient day framework.
Okay.
There are people at the table who've worked in those environments who'll vouch for the fact that it's typically one-to-one care or one-to-two care with additional supernumerary staff. So the level of staffing in EDs and ICUs sits quite a bit higher than what you normally would associate with a nursing hours per patient day ward.
Thanks very much. Mr Minns, do you track the breaches of the nursing hours per patient day?
We survey the districts periodically.
How often have those surveys been conducted?
I'd need to check with the team. It's at least twice a year.
Okay.
Can I just make a point? We actually survey what we call unders and overs.
Yep.
And we have given the Nurses Association that data when they've requested it. And it is the case that equal to the cases where we've not completely met nursing hours per patient day, so the unders, we have as many or more where more hours have been supplied than the framework requires. So it's important that you look at both scenarios. And that's occurring, that variance around the standard occurs for probably two main reasons. If there are issues trying to get rosters covered, associated with either late notice sick leave or situations like that, if we talk about a non-COVID period. And overs are associated with the circumstance where the nurse unit manager or the midwifery unit manager decides to have staff additional to the framework, which is what we think the strength of the framework is, that it relies on the expert advice of clinical nurse managers.
Thanks very much, Mr Minns. It's true that the staffing model hasn't changed in over 10 years. Is that accurate?
The nursing hours per patient day framework hasn't changed, no.
Okay. And is there any plans for a review?
Can I just clarify there? The government has been in government for just over 10 years, and the nursing hours per patient day was actually from Minister Tebbett, the former Labor Health Minister, in agreement with Brett Holmes at the time on behalf of Nurses and Midwives Association.
I accept that, Minister. We also accept that more than a decade has passed. Perhaps it might be time to review it. Would you agree?
Well, I think it's under constant review. Everything's under constant review in health. But what Mr Minns is just indicating at the moment is Health's view is that that's the appropriate formula which allows the flexibility but the capacity to do the job. Now, that's something which obviously you've rightly, I think, and I quite accurately, you pointed out that it's a bit different in an ICU because that's not the nursing hours per patient day formula. It's a different formula. It's different in midwifery, in maternity. So there are a number of different areas that are subsets of the overall formula. But I'm just pointing out that's not something which the coalition put in play. It was something which we've adopted and accepted as wise counsel from the Labor Party in its former incarnation in government.
Well, I appreciate that you accept wise counsel from the Labor Party, but it has been more than a decade that you've been in government, Minister. Perhaps it's time to look at it. I mean, the nurses did strike on the 15th of February for the first time in almost a decade. On the day, the Premier said he's always happy to sit down with unions to resolve the issues that are at play. Has the Premier met with the Nurses Union and its members at this point?
Yes, he met with Brett Holmes, yeah.
Okay, thanks, Minister. Mr. Minns, are you able to just provide on notice when those surveys were undertaken, the dates and which wards the surveys were conducted in? Is that possible?
Yeah, it would be with respect to the nursing hours wards, the 380 or thereabouts.
Okay, excellent. I think my time may have...
No?
Okay, well, I'll...
Keep going.
Thank you.
I can jump in.
Yes.
Minister, taking you back several years now, you'd be familiar with the Sydney Children's Hospital Network, and the have cardiac surgery been restored at Sydney Children's Hospital, Randwick? Been 2 years.
The review committee that was put in place has made decisions about what is appropriate and what's not appropriate for various levels of paediatric cardiac surgery at the two facilities. But it's essentially a clinical issue around safety of the patients. It's not about the government. It's about what the clinicians between two highly specialised and in many cases subspecialised physicians who are involved in paediatric care actually consider as safe for patients.
So 2 years on, is cardiac surgery occurring at Sydney Children's Hospital Network?
Appropriate levels of surgery that the
Randwick
clinicians consider from that committee is occurring as far as I'm aware. And I know that I've seen
as far as you're aware,
seen a video that went out from one of your members who is taking a political point of view rather than what's in the interest of patients. And it's an easy political hit, but it's not actually what's in the interest of patients. And I'm sure you would do that because you're above all that.
So no surgery is taking place at the hospital?
I didn't say that. I said appropriate surgery as determined by the committee that is actually, the clinical committee, is actually taking place.
Minister, in the last... Sorry, I forgot about the bell. I apologise.
Sorry, what's happening? The bell?
No, I continued to ask. I forgot. Sorry.
Was there another? I didn't hear the bell either.
I didn't hear it either.
When you and I are actually in this, we missed the bell. Can I just indicate that I'm happy after... Did you get another go soon or when?
I hope so. Do I get another go?
Plenty of time.
Yep.
Okay, well, if you have another go...
Yep, I'll be back.
I'll ask Dr Lyons to answer the question, okay?
I'll be back.
Excuse me, Chair. I could clarify and should clarify part of my answer to Ms Fussell.
Please do so.
So there has been a slight adjustment to the nursing hours per patient day framework, not the way it works, but the allocation of hours. So the government made an announcement in 2019 that the hours allocated per patient day, that framework, would increase from 5.5 and 5 in peer group B and C medical and surgical wards to 6. So the normal metropolitan peer group A standard is 6 hours per patient day. Historically, from 2010, 2011, those numbers had been lower in peer group B and C hospitals, and they were in fact increased in 2019.
And that followed discussions and negotiations that I had over quite a lengthy period of time with the Nurses and Midwives Association, and they agreed on those changes. They were happy about those changes, but obviously their basic argument is they just want fixed ratios, that's it, across everything basically. So, yeah.
You say go on.
Thank you, Chair. Going to something completely different. The Public Works Committee had an inquiry into coal ash repositories, which I think we've had a small chat about once. The government...
I'm sorry.
That's right.
Sorry, just go back. I missed the first part. I'm now
It's
focused
okay.
on coal ash, but what did you ask about?
Coal ash.
Yes.
So the Public Works Committee had an inquiry into coal ash repositories. The government, one of the recommendations in that inquiry was that New South Wales Health undertake an assessment of the health of residents near coal ash dams to establish the health impacts, because although in that inquiry it was acknowledged there were health impacts, there's a lot of research yet to be done to really work out what that looks like. In the government response, the response was, and I'll quote, New South Wales Health is committed to understanding the impacts of coal ash on the health of communities. It then goes on to say New South Wales Health will propose alternative study types, alternative to the epidemiological assessment that was suggested, which are better able to address the community's health concerns. I just want to see where that was up to. Just off the top of your head.
What an excellent question, Abigail. Thank you for that. Coal ash, as in like next to power stations and so on, is that what we're talking about?
Yeah, it's kind of leaching into the
I
water.
vaguely recollect you raising that once before, and I do recollect many years ago there were some concerns about selenium, I think, that was actually possibly, there were some arguments about it possibly causing fish with two heads and various things. So,
it does, yeah.
Yeah, but interestingly, selenium is in hair shampoo and other things, but in a different form. Does anybody here at this table of learned health experts able to contribute to this?
No, but happy to take it on notice. Yeah.
Sorry, Abigail.
That's okay, yeah. If someone could take on notice what is being done in relation to that.
I promise you, if there was an inquiry, there will be someone somewhere in that 170,000 staff who are working on this issue. I just haven't heard about that one. Sorry.
That's absolutely understandable. Can we turn back to the funding for women's health services, and in particular in relation to trauma and other issues connected with sexual assault? In fact, sorry, slightly differently. The women's health centres in New South Wales, I understand that they've had no increase in core funding since 1986. Except for restricted indexation and award variations. They've had no increase in their funding. Why is that? And will the New South Wales government look to increase the funding to the women's health centres?
I'm not sure that's. I hope that's not exactly correct. Maybe it's gone up at a certain ratio, but I hope it has. Can I ask Nigel? Do you know about that? No, sorry, Dr. Lyons.
So I don't know the specifics of the women's health centres, but with our non-government organisations, we provide support to ensure that there's increases that reflect our increases of salaries and wages and goods and services costs each year. So that might be the indexation you're referring to that's gone up, but not an increase in terms of service enhancement. That's what I think you're alluding to.
Or even the CPI increases.
Well, we do provide for all of our non-government organisations. The relationship includes any increases that would include wages and CPI costs.
I've never come across, in my 5.5, 6 years, almost 6 years as Minister, I've never come across an organisation who hasn't got growth money as each year. So maybe what they're saying is they haven't had a big expansion of funds beyond the normal growth stuff. But if you've got any details of the particular ones you're talking about.
Perhaps if you could take on notice.
Have you got a letter or something that we can get a copy of and we can...
I could provide it to you separately.
Okay. That's fine. Give it to me and I don't think it's necessarily a matter for the committee. I'll just take it on board and deal with you on that one.
Thank you. The funding for the sexual domestic family violence healthcare pathways that provides healthcare to women and reflects the impacts of COVID-19 on the rate of sexual domestic and family violence.
On what, sorry?
Sorry. I'm going to start again. The question is in relation to the sexual domestic family violence healthcare pathways, which I understand is a program that is currently being funded. Is there going to be any increase in that funding to take into account the impacts of COVID-19 on the rate of sexual domestic and family violence in New South Wales, which has been increasing under COVID-19?
We were talking before, I think it might have been Emma that raised it initially, but may have been you, but Emma raised some of it as well. I think there has been increases, but Dr. Lyons, do you have any specifics on that?
I haven't got any specifics. I did talk to you in response to a question previously this morning about that pathway that we've invested in to provide that support, recognising that there have been issues in relation to COVID. But I don't have an answer on whether there's likely to be more funding provided. So,
and in relation to the answer that you provided earlier, was any of that funding going to specific sexual violence services, or was it all going to family and domestic violence services?
That's what you were out, but we talked about that this morning. I think Emma raised that. And the point that she was making this morning was, and I think you made a little bit of it before you left, was that there was an allocation of funds through DCJ off the Royal Commission and I think I then read, I then gave some details about the first 20 million that had come through.
None of that was going to sexual violence services.
No, that's the point that was made both, I think, by you and by Emma this morning. And what I indicated then was that I haven't had the opportunity, since it was raised with full stop with me in the last few days, to actually get time because of these sorts of commitments. I just haven't had time to actually talk with my colleague who apparently has managed the money coming through DCJ. But I've indicated that I will have that conversation to try and find out what other opportunities there might be.
But to clarify the information that was provided by Dr. Lyons.
So we did provide advice this morning that we did have $19 million that was an investment that came through the response to the Royal Commission to health.
Is that through the National Partnership Agreement or through something else?
It was through the response to the Royal Commission into institutional responses to child sexual abuse. So I think there was an MPP around that.
It was the national. I actually, can I just reread this for Abigail, please?
Certainly.
I was given this morning after you and after Emma raised it, so I read it out, which was that New South Wales will receive $80 million in total from the Commonwealth under the Family, Domestic and Sexual Violence Responses National Partnership Agreement 2021-2023. The first of four $20 million Commonwealth payments under the NPA was received in November 2021 and has been allocated, not by me.
No.
More than half of the first Commonwealth payment, 10.5, was used to bolster existing frontline domestic and family violence services, which experienced significantly increased demand due to the COVID pandemic, which we were talking about this morning. The first Commonwealth payment was also allocated to programs supporting children and young people in refuges, male victims, survivors and perpetrator intervention and men's behaviour change programs. Actually, I didn't read that paragraph this morning because that wasn't what we were focused on, but that is... peak groups including Domestic Violence New South Wales, No to Violence and ACON also received a portion of that funding.
Yeah, and we were aware of that, and I think that's the same information that was given to us, given in response to my questions to Minister Ward last week.
Sorry, can I add one further thing which
was
in... You'd think I would have read this out this morning because it's it's highlighted, but I didn't read it.
Okay.
I've just now read it. DCJ will be consulting with stakeholders, including domestic and family violence and sexual violence peak organisations and other government agencies, such as New South Wales Police and New South Wales Health, about further allocations under the NPA. No decisions have yet been made about future allocations. All of that sounds quite hopeful.
It does. And just to clarify, if DCJ is the one administering that additional 60 million that's left out of the 80 million, it will be able to actually give some of that funding to sexual violence services, or will it need to come through health?
You're asking whether it should come through the established connections.
I'm just checking that we don't get to the same point next year and we ask about this and they say, well, it was administered for DCJ, so it didn't go to sexual violence services because that's health's responsibility.
But they're saying that they will, and I indicated to Emma this morning that I think that there's good arguments to say it should. There should be some allocation. It's a matter of me sitting down with the Minister and also getting health to work with DCJ.
Yeah.
But clearly that's that appears to be advice we've had from DCJ. It must have been post whatever discussions took place with Minister Ward, whenever they were.
Okay. Thank you.
I'm sorry I don't know exactly when that was because I've been busy with floods and COVID. But
that's all right. So the Housing and Mental Health Agreement, which I understand was going through review and had quite a lot of consultation, where is that up to in terms of implementation process for the new HMHA?
I think that's largely been managed through the Mental Health Minister's office. But does anybody at this table have any capacity to answer any of that, or should we take that on notice?
We'll need to take it on notice. I was just looking to see whether I've got anything on the table.
That's okay.
We'll come back to it if Dr. Lyons finds something in his magic box of tricks there.
Thank you. I understand there was a Domestic and Family Violence Service hospital co-location pilot project in 6 New South Wales hospitals. When will the evaluation results be available for those?
We might as well harass Dr. Lyons again.
So on about? Sorry, I was looking for the other one.
Can you repeat that, please? There we go.
So many varied questions here. Looking at the co-location of domestic and family violence services within 6 New South Wales hospitals. Apparently it was a pilot project done.
I'm not sure about the co-location. I know we've done a lot of work with domestic and family violence in relation to screening programs and new models of care, but I'm not aware of that one, so we'll need to take that on notice. I'm sorry.
Okay, thank you. Has New South Wales Health finalised protocols and referral pathways for women and children who present with potential and actual head injuries from sexual and domestic family violence at New South Wales hospitals?
That's a really sub question.
So I think
I will ask again whether any of the you've got almost the entire leadership of the New South Wales health system here. I don't know that anybody's got any leadership anywhere else than that.
Not specifically with regard to head injuries.
Anyway, we'll try and find out for you.
Thank you.
Yep.
This one I think maybe you'll have hopefully have some more information on. In relation to, and I think this is a question I asked at the last estimates as well, but in relation to the access to terminations under the, I forgot what we ended up calling that legislation. It was reproductive.
They tried to change it, but it ended up still as the abortion.
Right, okay, yep, abortion, law reform. We were hearing a lot about, especially in rural remote areas, there being nowhere to actually go to get a termination. Have you got any oversight as to how that is tracking and what is needed to ensure that every woman can access a termination under that legislation?
I haven't seen anything in the last little while, but I know it was a real issue because there was a service, for example, down near Wagga, I think it was, from memory, that was actually taking women from like hundreds of kilometres away. It was a real challenge. Can I take? Oh, first of all, I'll ask the team because, as I said, collected intellect here.
So I can offer some comments on that.
Yes.
So that has been a big issue, and we have been working very closely to do what we can to provide choices and advice for women who are in that position. So there's the first thing to mention is that we introduced the New South Wales Pregnancy Options Helpline, which was in October 2019, and this gives people who call advice about where they might be able to access providers in their location and support for how their specific needs might be able to be met, recognising that there are some challenges in some parts of the state of accessing those services. We've also been having discussions with a range of non-government organisations about how we can have additional supports provided for access to terminations through the services they provide. And those are ongoing discussions, recognising that the vast bulk of the terminations that are actually provided in New South Wales are not provided in New South Wales health services. They're actually provided in early pregnancy and usually by providers outside of what we do. The sorts of terminations we do in health are always at the complex end of the spectrum and are usually those that are later in pregnancy. The vast majority of the other terminations are provided outside of our services. But we are very keen to ensure that women can access the care they need, and we're looking at how we can get some further non-government providers active in that space.
And I stress in that from the government's point of view, obviously the legislation is now in place. From the Health Minister's point of view, I would be supportive of services that provide the holistic, obviously not just here's the abortion, but all of the counselling that should go before it so people know and are given advice on what is a really challenging and awful decision to have to make.
Perhaps on notice, if you could provide by local health district the number of,
available services.
Registered, available services, registered providers.
I'd be interested to know that too now because it's been, I think, a year and a half. Because that was before COVID, wasn't it?
And
it's been
if you
2
could
years.
also put for the 12 months prior, so we can just see how that's tracking and whether it's improving.
No, that's a good. I think that's a good thought for me too to actually see what's happening there.
Thank you.
Do you want that? Sorry, do you want that given to the committee or do you want that to go to you? I don't.
Just as an answer to a question on notice, so it will come through the committee staff.
Thank you. Minister, I'd like to return to cardiac surgery at Sydney Children's Hospital. You said that you were going to get one of your advisors to provide. Thank you.
I was going to throw it to Dr. Lyons, if he's got that there.
Dr. Lyons.
So thanks for the question, Mr. Scott, and you're aware of all of the complexities around this particular issue, and the Minister's alluded to them as well. It's a very vexed clinical issue. The issue is that the tertiary services of paediatric cardiac surgery, the numbers of children requiring those surgeries had got reduced down because of technology and some of the other less interventional procedures that are now available, to around 350 children a year requiring that sort of surgery. And having that provided across the two sites was becoming increasingly challenging, and there's been a series of reviews around that, getting independent experts and everybody else involved. Where the Sydney Children's Hospital Network is at the moment is that there is a service that is provided across both sites, but there's an emphasis on ensuring that the care is provided in the appropriate setting depending on the complexity of care that's required in relation to the cardiac surgery. The more complex procedures are undertaken at the Westmead end, and there is the ability to provide appropriate cardiac surgery at Randwick site. Now, the advice I have is that there have been around 9 procedures or 10 procedures undertaken at Randwick of the non-complex nature. There is a joint service for both paediatric cardiology and paediatric cardiac surgery, and the teams are working jointly to ensure that there is appropriate access for children at the site that most appropriately meets their needs and the care that's safe and high quality.
And do you have a breakdown of what occurs at Randwick and what occurs at Westmead?
I haven't got that in front of me. We could provide that on notice, but the emphasis is here that with 350 procedures or less, the ability to keep highly skilled paediatric cardiac surgeons undertaking the number of procedures that they need to do to maintain the skills required to maintain those services in a sustainable way is at a point where it would be impossible to have 2 rosters independent of each other.
Right.
It's a really complex issue, Walt, and I think...
I'm familiar with it.
Well, I know what the trite political positioning can be, but at the end of the day, I mean, if we could intervene and have it at both locations and keep it safe in every way, well, obviously that would happen. But as Dr. Lyons has just said, there used to be a number more, but now it's 350, maybe 400 if you're really lucky, or well, unlucky.
It's tracking down, Minister.
It's tracking down because of all the other earlier interventions that occur. And last I looked, there was about 5 of the subspecialty surgeons who are capable of doing, it's not just general cardiac, they might work on a particular little subsection of a heart that's that big. And so their views, the clinicians' views are, the safest way to deal with these tiny little hearts in tiny little people that can be, like 23 weeks onwards, is to deal with it for that level of cardiac surgery in one particular location. The location they've chosen is obviously Westmead. The issue is that this broader cardiac surgery that is capable of being done at Randwick. But also, if you think about it, the recommendation is that each of these surgeons should be doing at least 200 operations a year to maintain their competency and their skill sets of, as I said, working on tiny little hearts, on tiny little subsets of the littlest hearts you could ever imagine. And those doctors are actually doing less than about 30 or 40 because there's 5 of them. So it's just not up to keeping competency levels up. When you look at the website of Dr. Solomon, who's an orthopod who leads the charge on this, he's not a paediatric cardiac surgeon at all, but he's leading the charge. When you look at his own website, he talks about the hundreds of cases that he does every year as one of his competency factors. Have a look on his website. So I think it's really complex, and I must say again, it's not something that's a government policy. It's about clinical decision making by the top of the top clinicians as to what is going to keep tiny little babies alive. And I would just ask again that people desist. I'm not saying you are, by the way, Walt, you're asking neutral questions at the moment, but I'm just saying again that it would help if it were not made a political decision. It's got to be a clinical decision. If it was my tiny little baby, I would not want the decision making and the person who holds the key to my kid's life to have been put in that position by a political decision.
Can I ask a question in relation to the reduction of cardiac surgery occurring at Randwick, is there a cascading or a flow-on effect onto other procedures at the hospital? If you don't do that, does that in fact impact on other things that occur at the hospital?
I have a view based on the experience that I've had in the last 5 years, but I'm not going to give it because I'm not a clinician.
Okay.
I'll ask the clinician to give the view, and he's the most expert, and he's a Deputy Secretary responsible, so Dr. Lyons.
Dr. Lyons?
So that is a concern that's raised, that it will have a knock-on effect and have huge issues in relation to the intensive care unit and the trauma service and a whole range of other services that are provided. There is a commitment from the network that if any of those services are impacted, then they will provide the backup by having a paediatric cardiac surgeon available for those procedures to be undertaken locally. So this networked arrangement means that the surgeons are available for each of the hospitals, and where there's a need to have a paediatric cardiac surgeon available because there's another procedure being undertaken that needs that support, they'll provide it. It hasn't had an impact in the last 3 years where there's been a lesser number of paediatric cardiac surgery procedures provided. I mean, they're doing a huge amount of work to ensure that they've got availability of ECMO, which is the extracorporeal membrane oxygenation for the really critically ill children who need it, that they can have that at either site, that they've got the people with the skills and the backup for cardiology available for all those children who need it. So it's being looked at very carefully to ensure that the safety and the high quality care can be maintained at both sites.
Now, can I ask a technical question? So, when cardiac surgery occurs, is it urgent? Does it occur in an emergency setting, or is it in fact planned and scheduled?
The vast bulk of it is actually scheduled.
Scheduled, right. And what is...
Because, can I say,
sorry, Minister.
These days, a lot of it is actually identified in utero. So before the baby's born, and in fact, these days, there's some surgery that occurs whilst the fetus is in, while it is still a fetus, while it's still in utero. So the science and the method, the medicine has just changed so much in the last few years.
What is, Dr. Lyons, so what is the current wait for cardiac surgery if your child is a patient at Randwick, and what is the wait if your child is at Westmead?
So I don't have the waiting times for each site in front of me, Mr. Sukul, but I would say that the waiting times would be managed very carefully to ensure that the children were categorised, to ensure that those that had the highest needs were able to have their surgery as quickly as possible. And I'm aware that some of these surgeries have been undertaken at very short notice because the clinical situation with the baby or the child was such that they needed that surgery in a very short time frame, and that's accommodated.
Could you take that on notice?
I will.
Thank you.
If there's any, I haven't heard of any cases recently where there was a delay. It tends to be to do the surgery that needs to be done for these little tiny tots.
Thank you.
It tends to be a massive team that has to be well organised and well managed and planned, big plans.
Yep.
Minister, I've asked you over many estimates about the issues around salary sacrificing for health staff, and this is something obviously that's being campaigned on by the HSU. My time's about to run out, so I'm just interested in how much money, what did the New South Wales government receive as a result of the salary sacrificing arrangements for healthcare workers in the year 2021?
It's just the doctor arrangements, or what is it?
Salary sacrifice.
Yeah, I know,
so
but
you get 50%?
It's actually a federal issue, but I'll ask Mr. Minns if he can answer any part of that question.
So to give you the precise number for that year, we'll take it on notice.
Thank you. Have I got any more time?
Yep.
Okay, excellent. Minister, I just wanted to ask you about the role of private hospitals in clearing the elective surgery waiting backlog. What role will private hospitals have in clearing that backlog? Because there's obviously a significant increase in the number of people who are on the elective surgery waiting list.
Yeah, look, different from some of the other states, we actually, off the back of the agreement that was settled with the private hospitals during COVID, we didn't send patients to private hospitals for COVID treatment. We sent patients to the private hospitals for normal clinical care and or surgery. That's continuing if necessary, although at the moment I think I'm happy to get, if you've got time, I'll ask getting tired. Ms Pearce to answer that question beyond that, because she's got more detail.
Yep, that'd be great.
Yeah, look, certainly right through the last 2 years in particular, as we've dealt with the impacts of COVID on our surgery program, private hospitals have played a role in assisting us to clear those backlogs, Ms Husos. And look, as we've stated publicly before, the last thing we ever wanted to do was to disrupt that surgery program. We're very proud of the work we do here in New South Wales. We could not have achieved the results we achieved last year without our colleagues in the private hospitals. They've been an absolutely pivotal part of our response to that. Fortunately, at the end of the financial year in 21, we managed to get the number of people on the surgical wait list down from what it had been, and we also managed to reduce the overdue patients. So the peak that occurred as a consequence of the first stoppage associated with COVID in 2020, we reduced that right before Delta hit. Obviously, in the 8 or 9 months since that occurred, that has crept back up. We're very focused on our surgery program. We will be continuing to work with private hospitals. We've encouraged all of our local health districts to have those conversations with their private providers to keep that work going so that we can get on top of that. You'll appreciate, in order to reduce the number of overdue patients on the surgery list, we need to be doing more than 100% of what we would normally do. And in order to do that, we need to utilise those services. So we're very committed to doing that. We're very committed to getting our patients their surgery as soon as we possibly can.
Deputy Chair.
Thank you. Minister, at budget estimates back in 2019, I asked about the availability of plant-based options in New South Wales hospitals. And I was told on notice that meat-free options are available at every meal, which is not quite the same as plant-based meals, which include no animal products whatsoever. Are you able to provide an update as to whether plant-based meals are available at every New South Wales hospital?
I can't right now, but I'll ask, does anybody know that, or we take that on notice? Take it on notice. Sounds like an acclamation of take it on notice.
Take it on notice. Thank you. One of the reasons I bring this up, there's been a few horror stories in the media recently with people who have allergies or religions where they eat plant-based as a religious belief, and obviously, ethical veganism's on the rise, and there's been horror stories of people being fed an apple for a meal or a pile of beans when they're recovering from major surgery in hospital. So that's why it's obviously hugely problematic. So hopefully we can see some change in that space going forward.
If you have any details of hospitals where that's occurred, let me know.
Okay, I will do that. I'll send those articles on to you. I wanted to ask about the Women's Health Framework, which was published in 2019. It sets out some of the challenges that women face in the health space and strategies to combat these issues. I'm wondering how this framework feeds into the day-to-day work that New South Wales Health and our health system does. How is this framework actually implemented?
These frameworks are put there for a reason, obviously, to give guidance to each of the hospitals and each of the local health districts. But I'll ask Dr. Lyons whether you'd like to make any commentary on that.
Yeah, so the framework sets out the strategic directions, how we should deliver services and foster environments that will help women and girls to meet their physical, emotional, social and economic potential. So it's actually been done in consultation to ensure that the right sorts of strategies are included in there to provide that guidance to our clinical services. And so our expectation is that with that framework, each and every time one of our services is thinking about a change they're making or a way that they deliver services, they use that as a basis to ensure that the changes they put in place will help us to meet those directions and goals that are established in the framework. So, mental health and violence against women are very particular areas where a lot of the policies that we look at, the service enhancements that we make, the investments in new initiatives that we put into any of the new policy proposals, all of those would be actually guided by what's in that framework and the directions that are set out in there.
Thank you. One of the conditions identified in the framework is endometriosis, which affects at least 1 in 10 women in Australia. Are you able to advise me of any work being done to particularly support women with endometriosis in New South Wales?
I'm sorry, can I just say, in terms of the endometriosis issue, well aware, we've discussed that before. Of course, there's a national framework too that is relevant to guidance for the states and territories off the back of the national framework. Again, Dr. Lyons, would you like to respond?
I haven't got any specific about it, Ms Hurst, but I mean, of course, all of our services would be providing care to women who have endometriosis, and there are a range of different treatments and options that are available, which will be a part of the services we offer. But in terms of the specifics, I'll take that on notice.
Thank you. Yeah, I bring it up specifically because it's something that was identified in that framework that's been put forward as well. Is there any plans to produce an updated version of that framework in the coming years, Dr. Lyons? Or how often is that actually reviewed?
So the framework was only relatively recent, Ms Hurst, so it's not one that we would revisit in the next little while. At some point in time, what we do with all of our frameworks is make an assessment of and evaluate the impact of them. So to have a look at what's changed as a result of having that framework in place and what other things we might need to do to ensure we continue to see the improvements or the gains that we'd like to see. So we'll be undertaking an evaluation of that in due course and then feeding that back into any further refinements in the approach and the strategy.
Thank you. I just want to go back. I've just got one question back on the vaping, Minister. The Sydney Morning Herald, and I know you sort of touched on this with your answer earlier, but the Sydney Morning Herald reported that the health authorities are working to understand the rise in vaping amongst high school students, which has significantly increased in 2021. Are you able to tell us about some of the work that's going on here to track and stop vaping in children?
If that was the Herald you read from, was it?
Sydney Morning Herald, yes.
Well, do they only refer to the high schools? Because it's actually rife in the primary schools as well. Was it only
Terrifying.
High schools?
Yeah. It's a massive issue.
I'll ask maybe our Chief Health Officer whether she might have some comments on this, because it is something that's concerning, I think, everybody. It's just, it's really quite ridiculous the way it's gone. Dr. Gale.
Yes, I'd be happy to, and thank you for raising it. And I agree with the Minister. It's a very concerning pattern that we've seen in recent years, and as you've noted, a real increase in young people and right to primary school age, as well as what we're hearing in terms of using e-cigarettes and taking up vaping. And as I think many people will have seen, a lot of those products are actually very colourful. They look quite attractive, and there is some specific marketing that does really appeal to young people, and that's part of the reason, I think, why we are seeing that uptake of vaping in young people. So it is a significant concern. And as the Minister did flag, we're looking at, and in the near future, some broader communications to have that conversation and engage young people in understanding the risks associated with that. We know that in e-cigarettes, one of the key things about them is that you simply don't know what's in it. Many of them, even if they say they don't contain nicotine, they actually do. And a lot of the seizures that you previously mentioned, when we have sent them for laboratory testing, have actually revealed that even though the labelling indicates there is no nicotine, in the actual testing of the substance, nicotine is present. In addition, there's a whole lot of flavourings, formaldehyde, as the Minister mentioned, things that you would find in, insect spray and others that are not appropriate to be inhaled into the lungs of young people. Anyone, I would say, exactly, and particularly young people. So we have a considerable concern about the harms of these products, and there has been engagement with education and school principals who've also flagged their concern about the use of e-cigarettes. And really communication with young people to make them aware of the harms, engaging teachers, engaging parents, engaging education are all things that we are actively working on, and there will be more to come in that regard. But it is a significant concern. And I would say that for young people, there are even signs that, for some cohort of young people, already they've established an addiction to nicotine. And so there is also a treatment component that our clinical colleagues also need to be aware of, and so equally engaging with GPs. And I would say as well, there are more severe consequences associated with vaping, so syndromes of acute lung injury, and people may have seen media reports of people hospitalised and severely unwell, including young people with e-cigarette or vaping associated lung injury. So it's not an insignificant issue, and we are working particularly with education, young people and parents to try and address that.
Thank you, Dr. Gale. You hinted that there's more to come on this. Are you able to sort of give us any insight into what you're looking into or what's being put on the table beyond education?
Yes, look, really it's about informing people, and the Minister may wish to, comment further, but really the key goal is about effective ways to engage young people in a conversation about this subject.
I think the campaign, just out of interest, I think it starts next week, I think.
Okay.
So it's subject to other exigencies and other pressures that are happening on our system from floods and Japanese encephalitis.
But you've got it already, a campaign ready to go.
It's almost there, almost ready to go. Yeah.
Minister, with the cooperation of Emma, I remember a number of years ago I followed this closely, and I'm sort of coming back into it. Dr. Gale, so you mentioned that there have been hospitalizations and things like that. Do you have data on the number of children or number of appearances at emergency departments and hospitals due to minors vaping and causing themselves injury?
I know of some specific instances of certainly people who had severe experiences, but I'd be happy to look into that and take that on notice.
And you shocked me with the primary school students vaping. How would a primary school student get access to vaping products?
They do, and I'm telling you, well, it's the schools are absolutely rife. Primary schools are rife with it and have been. It's been growing in the last 3 years particularly. Ask any primary school teacher and they'll tell you that their kids disappear to the school toilets, and they've all got them. Well, not everybody, but I mean, there is a lot of young kids who have them. It's absolutely terrible. Seriously, the vaping companies tell you that this is to help people get out of smoking. With respect, I don't think they're that philanthropic. I think they're actually making a profit by flogging it to kids and to people who just simply don't understand how dangerous this product is or these products are. As I said before, the same chemicals that the researcher from Woolcock Centre, the Woolcock Centre told me, as I said earlier, same chemicals as you find in antifreeze, with dressed up in 500 different flavours. It's actually appalling. It's appalling.
Thank you, Minister. I want to ask you a couple of quick questions. Oh, sorry.
We'll break now for afternoon tea.
Oh, sorry. Okay.
You still have a break.
Yeah, sorry. So,
Thank you.
Yeah, so I'm just conscious. So we'll break now till 4:45.
Well, with the government would consent to follow through if there's only one more round to...
No, there are more questions, so we'll have an afternoon tea break.
So sorry, did I miss something? Did you guys decide you wanted more questions?
There are more questions, yes.
Was that a committee decision, was it? Because I heard the committee decision before, was it?
No.
Well, in that case, can I ask, because at the moment I've got the entire executive shy of one deputy secretary sitting here, can I ask for at least the ones down there and the ones down there to be able to go so that they can get on with doing some work on behalf of the taxpayers of New South Wales? I'll keep the final few here, if that suits, because this is just cannot go on. It's just they've got to do some work.
We'll just pause there for a moment, Minister. You know the arrangements with respect to budget estimates, don't you?
I do.
Yes. So.
And I thought we agreed that 3:30
No, we did not
was...
agree. No. I said that I would consult, and I've consulted. So we're not finished yet. You make the decision yourself, which you're entitled to do so. And we never reflect on this to be here for the duration of the whole day. So most ministers choose to...
I'm talking about the executive. I don't mind being here till 10 o'clock.
No, let me finish.
I'm happy to be here till 10 o'clock.
Well, if you don't mind being here till 10 o'clock, maybe we'll need another resolution to get through to 10 o'clock, okay? We're going through to about 5:15. So, no, we'll break for afternoon tea.
Chair,
no,
can I...
Yep, sure.
I think, given the circumstances of the day and also the pandemic and floods, and also the circumstances with which we had, I guess, discussed the position that we would have, the government members would consent to another round of questions now so that we don't break for afternoon tea, but then perhaps opposition might have the opportunity to ask another round of questions and the crossbench, and then we could perhaps maybe finish a little bit earlier and allow the members to actually get back to attending to some things this afternoon that they may have that are outstanding. Would that please the Chair?
No. We're going to break for afternoon tea, and we'll be back at 1:45, and we'll continue.
You know, what goes around comes around, Mr Chair.
Mr Chair, can I add something here then?
Yeah.
Just your colleagues on, I'm not sure which committee it was on, frankly, I think it was Mr Ayres, Mr Graham and Mr Mookie, identified witnesses they still wanted to ask questions of and allowed those that no longer needed to be asked questions to leave. Is that a possible process to support?
We'll talk about that over the afternoon tea break. matters underway.
Is that on Hansard?
What's different?
Okay, let's get underway. The Honourable Secord.
Thank you, Mr. Chair. Minister, to you or to the appropriate official, given the government's commitment, an announcement about the reopening of palliative care, the palliative care unit at Westmead, can you update the committee on where the commitment is up to?
Well, you would know, Mr. Secord, that palliative care has been one of the big areas of concern for the Liberal and National Government. It doesn't matter whether it's at Westmead or in any of our hospitals right across the state. Palliative care is a vital service for people who may not be immediately at end of life, but certainly there are periods where towards the end of our lives palliative care is of vital assistance. There's been very substantial funds put into palliative care under the coalition government. You'd remember too that that commitment was displayed when we had more than 20 roundtable conferences around the state with local staff, local community members to talk about what was necessary. And in fact, one of my proudest moments, not in the city area, but in the furthermost part of the state at Broken Hill, was to attend Broken Hill Hospital and to see the incredible outreach of palliative care services that were being done there and the pride of the palliative care staff who were reaching out to individuals in their homes, Aboriginal, non-Aboriginal, and travelling for hours in some cases to get to their home to be able to give them the appropriate services and support that were necessary. Westmead is just one part of a massive effort and approach in relation to palliative care. I have obviously visited many of these facilities in my time as Health Minister. Westmead has a particular facility where palliative care is offered, but it's for patients that are currently in with others who require a range of other very serious clinical attention. And that service, in my view, would be best delivered, as advised to us by a number of the palliative care specialists out of those roundtable forums, if it could be done in a specialised palliative care structure. And by that I mean a ward that would allow for the individual patients to be cared for by appropriately qualified nurses, doctors and allied health staff, but also to allow, most importantly, for family to be very much part of that palliative process. A lot of the older facilities generally don't have, for example, spaces for families to sit quietly with their loved ones during the journey, which can be many months, indeed years on occasions. Westmead has a good facility, but it's not as good as I think it can be, and I've asked the Western Local Health District to, as part of the rebuild of Westmead, and you'd know there's vast amounts of money being spent at Westmead, to try and ensure that there is a dedicated ward that's in that facility. Now, the last advice I have is that they are proceeding with the planning of that proposal. I can't give you an absolute deadline on the timing at this point, but I'm happy to take it on notice and to get that from the local health district as soon as I can, and of course provide the answer to this committee.
As part of that taking on notice, if you could tell us where the commitment is up to as of this week, and the timeline for when it'll be operational, and maybe the funding allocation for this year's budget for that project. Thank you, Minister.
Sure.
Honourable Courtney Hughes.
Thanks very much. Mr Chair, prior to the Omicron wave, patients with chronic health conditions were given undertakings that if they received regular life-saving treatment in hospital, they would continue to be able to receive that treatment even if they did contract COVID. Are you aware of that?
Sorry, Courtney, can you say that again? Patients what?
Patients with chronic conditions that receive regular treatment in hospital were given undertakings that they would continue to receive that treatment even if they contracted COVID. Are you aware of that?
Well, I wasn't aware specifically of that undertaking, but of course they would be still getting their treatment as far as is humanly possible, because they would still have the primary health issues that need to be addressed.
That's exactly right, Minister. So I'm aware of at least one instance where upon receiving a positive RAT at the hospital, the patient was then told to leave and had a series of presentations that meant that they were effectively fighting to receive their life-saving treatment. Can you given the increasing cases today, can you give an undertaking that patients with chronic conditions will continue to receive their life-saving treatment in hospital?
The undertaking I can give is that obviously the ministry can work with those local health districts and the individual hospitals and, most importantly, the individual clinicians to ensure that they understand the importance of giving priority to those ongoing health conditions. But I would say this, to ask for a broad-scale undertaking, that's not the way health should be conducted. Clinicians are the experts. They're at the forefront of treatment of each individual patient. Patient may have all sorts of complexities, or they may not. And those are issues which a clinician has to weigh up. Having said that, I am aware that from time to time, individual clinicians working under pressure may make decisions with which I may not agree, you may not agree, and the patient may not be happy. And sometimes I've actually had to raise those issues with the management of the hospital to make sure that appropriate weight was given to all the factors that need to be considered. So that's the best I can answer on that question. I'll ask the Secretary whether she wishes to add anything. But
yeah, before we go to Ms Pearce, I would just say these are patients who receive regular and life-saving treatment in hospital. They are balancing their chronic conditions, so they have underlying health conditions which puts them at a greater risk for COVID complications. This particular patient that I'm aware of, and I'm told that there were others, was refused the treatment and then had to fight, presented an emergency, was told that they wouldn't be treated there, was told they had to receive their treatment in a COVID ward and was told there was not a place in the COVID ward. So this is creating a lot of anxiety amongst that particular community, but also other communities with chronic conditions.
If you give me the details, I'll do that and look at it. But can I tell you also, Ms Hussos, that if you were lying in a bed or in a chair receiving care in one of our hospitals, and you did not have COVID, and there were another 20 people in that ward receiving similar care who did not have COVID, and I don't think you would want necessarily to have a COVID patient put next to you. So those are the challenges in a 1 in 100 year pandemic. It's a balancing act of caring for the patient in the best way possible within the environment that is available, and sometimes it may not be perfect because it's a COVID pandemic. So I've given you the undertaking that I can give you, but I'll ask again. There's clinicians sitting at the table.
I'm happy to comment.
It sounds like the Secretary would like to add to that.
Clearly, we would want everybody who presents to a hospital to get the care and treatment they need. Absolutely. If you could provide the information about that specific example, we'd be very happy to look into it. Because whether you've got COVID or not, if you have an underlying health condition that requires care and treatment, we would expect to be able to provide that and would find a way to do that, as the health system has done all these many months to manage all manner of complexity associated with COVID. So I'd be very happy to receive any information you have in regard to that so we can follow it up. We will also, when we're talking to we have very regular conversations with the chief executives across the system and just remind them of that. But the Minister's quite right. Our clinicians have been placed in a position of having to make decisions at times which have been very difficult, but we'd better like to understand the issues that you're raising.
Yeah, and this specific incident happened during the Omicron wave, so obviously there's no need for further follow-up now, and I appreciate the offer, but the anxiety amongst patients, particularly in the face of increasing cases now again, is that they might not have that access to that regular treatment that they receive, and that, as you can understand, creates a great deal of anxiety within those communities. I appreciate what you're saying about referring to the clinicians, but they want that certainty to know that they're going to be able to receive their treatment.
But the only certainty I can give you is that what I've already said and what the Secretary is now repeating, and that is that obviously every patient should be given the very best service that we can possibly give them. And the New South Wales health system is I think, the world leader. It is. And the doctors and nurses who are in our hospitals work very hard to try and strike the balance when they have complex and conflicting pressures. And a pandemic is a very big conflicting pressure. So they need to make those clinical decisions. And I don't think it's fair really to expect there be a black and white situation. All we can really do is say, yeah, we agree with you. I agree with you that all patients deserve the very best care. But it's striking the balance within a hospital environment. It's not a one-off room by yourself with one doctor. It's not.
I appreciate that, Minister. I wanted to move on to the question of resignation of nurses. Do you have a figure on how many nurses have resigned since the 15th of December?
Since the 15th of December? Was that when the compulsory...
When the restrictions were lifted?
You're talking about the mandatory restrictions? All up, I think Health had, out of the 170,000 staff, I think there was approximately 1,000, but I'll ask, does anybody know? Oh, Phil.
Mr. Minns.
No, just to clarify, this isn't about the vaccination status, this is about how many nurses have left since the 15th of December.
Oh, well, okay.
I won't be able to give you the date since the 15th.
Why the 15th?
Without taking it on notice.
That was when restrictions were lifted.
But we have done some analysis of what's happened to our separation rates. Now, over the long term, our retention improved through the first period of COVID, reflecting, I think, a commitment of staff to support the system through what it was experiencing. We have seen a slight increase in separations in the period after Delta, so from about September. And there's an increase in separations in the month of January for the whole month. But that is pretty standard as a seasonal time when people choose to end their employment in the system. So it's less than... I'll give you the correct answer on notice, but if we've seen a change at all in the last quarter, it's in the order of less than 1%. But I'll confirm that precisely. But
if you could give me the figure for that particular period and then for the same period the previous year, that would be helpful.
Yep.
Thanks very much, Mr. Minns. I'd like to move to a separate issue, the Iluka ambulance station. Minister, I understand that the station was originally to be a 24-hour rostered station with a full complement of staff, which would have meant 12 staff. And I'm advised that currently there are 4 staff that are working there. Do you have any plans to recruit more, or what are the efforts that are going into recruit additional officers for that particular station?
Well, as I said to you before, those sort of staffing issues are entirely operational matters within the purview of the ambulance service. What the government is committed to, and you heard from Mr. Minns before, that we've been delivering on that commitment, is the additional paramedics that are then allocated, or that are being employed within the service, and allocations are then made by the service as they consider appropriate. But I'm happy to take the question on notice and direct it to the ambulance chief executive, who's not here, and ask him for his advice, and I'll table it.
If you can provide us with what are the current officers, what's the current staffing level at that particular station? Are there any efforts to recruit additional staff, and how many additional staff are attempting to be recruited? That would be helpful. Thank you very much. I just had some final questions on coming back to the Foster Tuncurry Hospital site. Are you planning on, you mentioned that there was 10, there was one preferred site. Are you planning on doing any community consultation around the selection of that particular site, or is it just if Health chooses?
I'm sure there will be consultation ongoing through the whole planning process, both around site selection and then generally what the function of that will be and how it will be planned.
Perhaps you can provide on notice with what that community consultation plan is and who's going to be coordinating it?
Happy to take that on notice.
Thanks very much. And if you can just, again, if you need to take that on notice, that's fine. But if the consultant role was actually to scope out those sites, if that was actually the role of the consultant, or what the role of the consultant was?
The consultant for the sites?
There was that $7.9 million consultancy budget commitment. I just wanted to find out if that was
wasn't that for
scoping.
general planning and to...
I understand the Sorry, Minister.
No, you go.
I understand the 7.9 million was in relation to pre-planning for a number of sites. I think it included perhaps Glen Ennis and a couple of others as well, so 4 in total.
That's right.
And so that would not have just been for consultant fees. That would be for the actual pre-planning work that's done by the whole HI team, which may also include consultant work.
And what's the pre-planning? Sorry if that's a dumb question. What's pre-planning?
It involves a range of things about what the functional briefing might be for a site to get it ready, sort of what the master plan might be for a particular campus, what the service requirements are, so liaising with local health district and the hospital in particular. It's often around master planning.
Master planning for the site?
Master planning for what the services might be. So on Foster it would not be that because it's a new site, but it would be what type of site would be required.
Okay.
As in to be able to work out how large it should be, what its location should be, what it needs to be near to.
There's also master planning, which is a slightly different term later on. Once it's all settled as to this is what the clinical services are, then the master planning or the physical arrangement of the hospital. So, whereas if it were a larger hospital, where maternity would be, to make sure that it might be right near the theatres, but is it close to other services? So all those things go on as well, but that's master planning at a later stage.
So the master planning you're talking about is in terms of how the actual geography or the location within the broader town.
I was talking more generally about the types of tasks that we undertake with that pre-planning funding.
Okay, all right. I think my time's expired.
No, we're till 5 past. That was 20 minutes.
Can I just, you're interested, I know you are interested in this, Walt, so I just had a note from the Children's Advocate just advising me that, and I had forgotten to mention it, so it's been raised, that in that vaping aspect that the health ministry and the team are all putting together to try and get some downward turn in the number of youngsters going vaping. The vaping campaign has been reviewed by members of the Youth Advisory Council as well, so there's been quite extensive consultation with younger people to make sure that it actually will, be absorbed by them in a sense.
Okay, thank you. Minister, you'd be aware that there were a number of cyber attacks on New South Wales government agencies, and New South Wales Health confirmed an attack in June 21. Now, have there been further attacks or breaches involving New South Wales Health since the June 2021 incident?
Not that I'm aware of. Is anybody at the table aware of it? Doesn't sound like it.
Okay. Thank you.
I'll double check it with Zoran Bolovic. He's not here. He hasn't. We could have 170,000 people sitting around the table, but
I understand.
I'll check and I'll let you know.
I was wondering
if there has been, I'll do a response to the committee. If there hasn't, well, the answer is no. Nobody here knows.
Okay. Okay. Fair enough. Okay. Thank you, Minister. Through the Minister to Ms. Dawson. Now, have things settled down at the HCCC? In 2019, there was a high-profile incident involved a person who was convicted of sexual offences who received a senior position in that. Have things settled down in the HCCC?
I think we can see through the People Matters Employment Survey that they certainly have. As you know, Mr Secord, many changes in practices and procedures were put in place following that situation, and they are working very well.
Have there been any departures since 2019 of individuals who were removed from the workplace for, quote, inappropriate harassment?
There have not.
There have not? There have not?
Appropriate harassment.
What was that?
I don't think there's any appropriate harassment, let alone inappropriate. Harassment's always inappropriate.
Oh, okay.
Just a language point.
So, Thank you for that contribution, Champ.
Doing something here today.
Yeah, okay. Now, since the 2019 incident, has the HCCC reviewed its internal complaints process?
It has reviewed all of its recruitment processes. It has reviewed and maintained, as it does with all internal policies, its process for making bullying or harassment complaints as part of its review of HR policies. So yes, there's been a very diligent attention to maintaining all of those disciplines in the people and culture space.
Now, the review of those procedures and protocols, was that conducted by an internal person or an external person?
As with all of our HR policies, we have a regime of reviewing those. Those are then examined and reported back to our Audit and Risk Committee. So there is a general program of review, amendment and approval.
Now, one last question, back to harassment. Now, as well as harassment, have there been cases, and if you could provide the number, involving complaints of bullying in the workplace at the HCCC since 2019 to March the 1st this year?
There has been one such bullying complaint. Yep. It was a worker-to-worker complaint. Yep. It was investigated and found not to be substantiated.
Who found that it was not to be substantiated?
It was through our normal procedure. Involves an initial investigation, some discussion with those who were involved, and it's through that process that finding of non-substantiation occurred.
One last question. Are those two individuals still employed by the HCCC and still in the workplace?
They are.
Thank you.
Thank you. That now brings us to the government members. Any questions that you may have to?
Thank you very much for the opportunity, Chair, but I think we're very content with the answers given today, and the government will cede its time.
Thank you, Ms. Lang. So that brings us then to the conclusion of today's supplementary hearing with respect to budget estimates for Portfolio Committee number 6. So thank you very much, Ministers, witnesses. Appreciate it very much.
Thank you.
Draw the meeting to a close. Thank you.
Thank you.